and rain, some things don't change. Thinking about the days we were young, we were younger. Innocent in our ways, we were dumb, girl. When nothing really mattered, I could always count on you. We were young, younger. The touch relieved me breathless, so let me give it back to you.
And maybe I don't want your love. And maybe I don't want your love. And maybe oh my, you're my broken heart. You're my broken. And maybe I don't want your love. And maybe I don't want your love. And maybe oh my, you're my broken heart. You're my broken. And maybe I don't want your love.
We were younger. You don't have to wait, you know my name. Sunshine and rain, some things don't change. Thinking about the days we were young, younger. Innocent in our ways, we were dumb, girl. When nothing really mattered, I could always count on you. We were young, younger. The touch relieved me breathless, so let me give it back to you.
And maybe I don't want your love. And maybe I don't want your love. And maybe oh my, you're my broken heart. You're my broken. And maybe I don't want your love. And maybe I don't want your love. And maybe oh my, you're my broken heart. You're my broken. And maybe I don't want your love. And maybe I don't want your love. And maybe, and maybe, and maybe I don't want your love. 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 Want your love. And maybe I don't want your love.
We were young, younger.
And maybe I don't want your love. Oh my, you're my broken heart. You're my broken. And maybe I don't want your love. And maybe I don't want your love. And maybe I don't want your love. You're my and maybe I don't want your love. You're my broken. And maybe I don't want your love. Look how it shines, baby, it's deepest blue. Look how it shines, baby, it's deepest blue.
I was there when the clouds parted. Do you remember the day we met? The day we met. I won't be all shy, but we take a swing. You're saying everything.
I wanna be ocean, deepest blue.
Shy, but we take a swing. You're saying everything.
You're saying everything, baby, it's deepest blue. Look how it shines, baby, it's deepest blue. Look how it shines, baby, it's deepest blue.
Hello.
Recording in progress.
With friends, blowing bubble gums with them. Bubble power is my gun. Blowing bubbles so they reach the sun. But maybe, they'll pop in front of my eyes. Yeah, maybe, they will not realize that it
to the Midyear Convention of the Philippine Society of Anesthesiologists Incorporated, hosted by Southern Mindanao Chapter, and its first combined hybrid and virtual convention with the theme Re-Navigating Anesthesia Practice. Let us stand up for the entrance of the maze by the PSA Secretary, Dr. Francis Mayuga. You may now take your seat. Let us now welcome our PSA past presidents. Chapter presidents. Subspecialty societies. And now, let us welcome our distinguished PSA officers, board members, host chapter, and local organizing committee of Southern Mindanao Chapter. Let us start with the PSA Processional March. The local organizing committee. Regional Directors. PSA Regional Director for Luzon, Dr. Carmelita Lunas. PSA Regional Director for Visayas, Dr. Emmanuel Prudente. PSA Regional Director for Mindanao, Dr. Ahmad D. Sangkopan. PSA Board of Directors, Dr. Godfrey Adcon. Dr. Salvador Brodit Jr. Dr. Maria Vanessa Christie. Dr. Maria Janet Serrano. Dr. Carl Matthew C. Su. Dr. Loretta Tayao. Dr. Benjamin Daniel Valera, PSA ex-officio. Dr. Erminia Montecillo Ocampo, PSA Treasurer. Dr. Francis Mayuga, PSA Secretary. Dr. Pena Francia Cano, PSA Vice President. Dr. Jose Beltran Jr., President of Southern Mindanao and Host Chapter. Dr. Edgard Simon, PSA President. And our keynote speaker, Mr. Jean Rose Taxon. Please stand up for the doxology and please remain standing for the Philippine National Anthem, followed by the Philippine Medical Association hymn and the Philippine Society of Anesthesiologists hymn.
Si
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم فقال ربكم ادعوني أستجب لكم آمين يا رب العالمين الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين اللهم اجمع شمل المسلمين والكريستيان والأمة في مدينة دباو وسلم دائما مجتمعنا هذا بالسلم والأمن والتقدم في بلدنا هذا آمين يا رب العالمين ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب ربنا إنك أنت الوهاب ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار وصلى الله على خير خلقه سيدنا محمد وعلى آله وصحبه وسلم سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين آمين يا رب العالمين.
In the name of the Father, Son, and Holy Spirit. Amen. Our most gracious Heavenly Father, we come to you today to praise and worship you and give you thanks for all the things you continue to provide for ourselves and our families. Father, we humbly ask for forgiveness for all the times we have offended you, when we forget to acknowledge your presence in the image of our brothers and sisters, and for moments we fail to be good stewards of the blessings you have given us. Continue to guide and protect each one of us, Lord, that we may always walk in the light of your everlasting love and mercy. Grant us, Father, with your comfort in times of distress and with your strength in times of weakness. Bestow upon us your unending grace and healing, that we may in turn become instruments of gentleness and compassion to others. We ask all this in the name of your Son, our Lord Jesus Christ, with the prayer and the intercession of our Blessed Mother. Amen.
Manama, mawantog ka. Warag po ko iling ko'y ko. O Diyos, kahibulungan ka. Busa ikaw lang ang simbahon ko. Busa ikaw lang ang alagaran ko.
Mga kababayan, ang pambansang awit ng Pilipinas.
Puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Tinalang
For the welcome remarks, I would like to call on our PSA President, Dr. Edgard Simon.
Good morning to everyone. For 2 years, the society has dwelled with the oddities brought about by the pandemic. Since we shifted our annual and mid-year conventions to the online platform, there was also an unceasing hope of a day when we will meet again face to face. Now, we are finally here, and it is indeed a relief to witness this dream slowly turning into reality during my term. It is such a great joy to finally personally witness the smiles of our Davaoenyo colleagues after a 2-year wait. And it seems like you are able to keep on brewing your welcome in the 2-year delay, because we could certainly feel the warmth with the way you received us. Thank you very much for your patience in waiting and unwavering enthusiasm in restarting this endeavor. To the PSA, Southern Mindanao chapter officers, their committees and members, and our partners in industry, congratulations for making this event successful. I'd like also to acknowledge the presence of our past president, Dr. Zenaida Mariano, who is here with us this morning. So 2 years may be relatively short. Everyone would agree that it is one of the longest 2 years of your life. We have endured and sailed through uncertain waters in recent years, and as we emerge from a stormy sea, there is no way but go forward to the path ahead. Remember that in our field, the path never goes straight. The road constantly changes. However, these changes should not be met with pessimism, as in our field, we are always aiming to change for the better. We always try to enhance what we know, look for solutions for our dilemmas, and find safer alternatives in practicing our craft. Then, how should we welcome these changes? The answer is here, as the society brings to you this mid-year convention. So hand in hand, let's welcome and come together in re-navigating anesthesia practice. Let us calibrate our compasses to find the twists and turns of our fields. In every step we take, the horizon keeps on expanding, and we have to keep up our pace so we won't be left behind by this evolving knowledge. Every time we move forward and turn new chapters, our fields keep on growing. Therefore, we bring you a wide array of topics, from common cases that we encounter every day to high-risk subspecialty cases. And as we immerse into these themes, we hope that you will be able to connect the dots, see the trail, and discover the path towards a holistic growth as anesthesiologists. While the pandemic was indeed a nuisance to all of us, it was also a time of first in our society. It is this time when we had our first virtual convention, and now we will be marking our first hybrid physical and virtual convention. Congratulations for being part of this, for together we are writing a page in the history of our society. It is still uncertain how we will go forward with our future conventions. It's too early to tell what will happen next. However, one thing is sure, PSA will continue to fulfill its mission to uplift the status of every member and maintain the quality of our standards. Virtual or physical, we will continue to deliver. As in a real trail, our goal is for no one to get left behind. We will all reach the end of the trail. lahat tayo ay pupunta sa exciting part. So with this, I welcome our colleagues sitting in front of me here in Davao and everyone in the Philippines watching their screens to this PSA's Midyear Convention for 2022. And may your spirits be as high as Mount Apo and the flight of the Philippine Eagle in the next coming days. Mabuhay po tayong lahat.
Thank you very much, Dr. Simon. And now, I would like to call on Dr. Jose Beltran Jr., the chapter president for Southern Mindanao, the host chapter for this year's Midyear Convention, to give our welcome address and to introduce our keynote speaker.
To the national officers of the Philippine Society of Anesthesiologists, the organizers, distinguished speakers, moderators, participants, industry partners, stakeholders, guests, ladies and gentlemen, a pleasant morning. It has been 2 years since we planned this yearly mid-year gathering, and the long wait is finally over. The pandemic initially may have dampened our spirits, but with our ever-dependable resiliency, we gradually rise and restore normalcy in our daily lives. We convert sorrow to excitements and opportunities. It is my pleasure to welcome all of you to our first pandemic hybrid convention in the Durian City of the South. Your host, the Philippine Society of Anesthesiologists Southern Mindanao chapter, with more than 200 members, prepared a 2-day array of extensive academic exercises, a gorgeous fellowship night, and post-meeting recreational activities for you to feast from sunrise to sunset and beyond. Enjoy our spectacular islands and majestic highlands. Take part in various fora that will address some most recent and pressing issues in our specialty. Then indulge in the delectable cuisine of Mindanao's bounty. Again, my sincerest appreciation to all of you for your interest, support, and participation despite these challenging circumstances. Madayaw nga pag-abot sa Davao, daghang salamat. Now I'm going to introduce our keynote speaker. She was born and raised in Davao City, just like other Davaoenos whose ancestors come from all over the country. Her maternal grandparents are from Bohol, and paternal grandparents from Bulacan. She studied at the Marinol Grade School, now Marymount, and high school at the UP Integrated School, Diliman. She finished her BS Business Administration degree at the Ateneo de Davao University. She worked as Executive Director of Davao Tourism Association in 1996, worked for a political office for 18 years, became a professional tour guide, and for the past 6 years, officer in charge of Davao City Tourism Operations Office. Ladies and gentlemen, let us all welcome Regina Rosa Jean Rose Texon.
Madayaw, ug maayong buntag sa inyong tanan. The past 2 years has cost us a lot, not just here in Davao or the whole country, but all over the world. Now, along with other countries, we are starting to open up and get on to the new normal. The Philippines had one of the longest lockdowns in the world, But we are now none the worse for our experience. We survived and we did okay. Grateful not only to our health professionals like you, but our other frontliners as well, and the vast majority who listened and followed the health protocols. Here in Davao, we are used to hardships and challenges, but COVID really tested our mettle. A little history for you. While the rest of the country was under the Spanish rule for 300 years, starting in 1521, the Spaniards only managed to enter Davao 50 years before they left the country in 1898. And that was when they defeated our local hero, Datu Bago. The Spaniards hardly had enough time to establish themselves here in Davao because they were constantly on guard for fear of being attacked by the natives, which only goes to show that we Davaoenos don't give up easily. In World War II, Davao was one of the first cities to be occupied by the Japanese and one of the last to be liberated in August 1945. The whole city was in shambles as much as it was bombed. So we rebuilt. Then, of course, during the late 70s up to the mid-80s, Davao was called a no man's land when the city was turned into a killing fields by the communist rebels. And the people of Davao City again suffered much socially and economically. The turnaround came when Rodrigo Duterte was elected mayor in 1988, and peace and order was his rule for the day, while instructing the vice mayor and the private sector to team up and institute economic reforms. Davao has since gone a long way. In March 2019, with the onset of COVID-19, our Mayor Sara, herself a nurse, at once consulted infectious disease doctors and together set up health protocols for the city. We were one of the first, if not the first, to establish the one hospital command and to assign only one hospital to admit COVID patients so as to avoid contamination of non-COVID patients. We set up quarantine facilities good for about 5,000 people and instituted one of the strictest guidelines for entry into Davao City, especially through our airport. After the ECQ was lifted in May 15, 2020, we started chartering flights for stranded Davaoenos to enable them to come home. But they had to undergo testing in the airport and quarantined for free till their results came out. Then, one by one, they were brought home and endorsed to their barangay officials for further quarantining, so to ensure that they observe the 14-day quarantine. Commercial flights were allowed by October 2020. But again, passengers were tested and subjected to quarantine. At about the same time, the city government requested for tests before travel from the IATF, but was denied. Hence, the testing upon arrival was in place for free until test before travel was instituted in May 2021 by the IATF. And the challenge shifted to checking if the RT-PCR results presented by the passengers were valid and not faked. All these efforts resulted in our being able to delay the entry of COVID in the city and avoided having our health facilities being overwhelmed. We had some hairy moments, but we managed. In June 2021, when the vaccines became available, the city exerted all efforts to have its citizens vaccinated. The private sector pitched in, and one of the best examples was the Bakuna by the Bay, set up by the private tourism stakeholders at the Waterfront Hotel for tourism frontliners. 87% of our 16,000 tourism workers were fully vaccinated in 2.5 months. At present, 85% of our 1.8 million population are fully vaccinated. And since February this year, we have opened our city to more economic activities sans requirements for traveling, entering the city. And we reassure our visitors and investors that the city will not lock down anymore, but continue to face the challenge of meeting COVID head-on. The city maintains, though, that the minimum public health standards be followed, especially the wearing of masks. Our accommodation sector now reports 85 to 95% hotel occupancy. More businesses have reopened, and this coming August 15 to 21, we will be holding our Kadewan Festival face-to-face. And we invite you to celebrate with us this Thanksgiving festival with our 11 ethno-linguistic tribes. Ours is not a perfect society, but we Davaoenos continue to forge ahead despite challenges and overcoming limitations, because we have learned that it is the only way to be. And our history and experiences have taught us to become resilient and united. At this point, allow me to show you a short video of what Davao City has to offer.
Davao City is located in the southeastern part of the Philippines. It is a large city where 1.8 million people live. Known for its rich natural resources, it is one of the Philippines' most progressive cities. Davao City is a beautiful city. It is home to warm and friendly people. It is a place where different cultures live together in harmony. This is a city proud of its heritage. This is a colorful place, bursting with creativity and artistry in its many sights and sounds. Inside Davao City, there are so many places to explore and things to do. We have golf courses, shopping malls, cafes and restaurants, luxuriant hotels, parks and greeneries, mountain resorts, spas, large convention facilities. We are also the gateway to Davao region, a land of beautiful beaches, dive sites, mountains, waterfalls, and many attractions await. Going to and getting around Davao City is a breeze. Health protocols are implemented and followed to ensure a safe and healthy travel to Davao. We are a safe and peaceful city. We have 911 emergency response system and world-class health facilities. You are in good hands in Davao. What are you waiting for? Davao City is waiting for you. Experience life in a place where you always wanted to be.
To the officers and members of the Philippine Society of Anesthesiologists Incorporated, daghang salamat for holding your 2022 Midyear Convention here in Davao. And once again, madayaw na pag-abot sa Davao, we wish you a beautiful life.
Thank you very much, Ms. Texon, for the inspirational message. I would like to call again on stage Dr. Edgar Simon, PSA President, and Dr. Francis Mayuga, PSA Secretary, for the awarding of plaque of appreciation to Ms. Texon. The plaque reads, "The Philippine Society of Anesthesiologists Incorporated presents this plaque of appreciation to Ms. Regine Rose D. Texon, Officer in Charge, Davao City Tourism Operations Office, as keynote speaker during the opening ceremonies of the PSA Midyear Convention, given this 26th day of May 2022, Dusit Hotel, Ballroom Thani 1, Davao City. Signed, Dr. Francis B. Mayuga, Secretary, PSA Incorporated, and Dr. Edgar Simon, President, PSA Incorporated." To formally open the scientific sessions, please welcome the PSA Director and CME Chairperson, Dr. Maria Vanessa Christie.
I formally open the scientific sessions.
Thank you very much, Dr. Christie. And I would like to call on Dr. Erminia Montecillo Ocampo, the PSA Treasurer and Chair on Trade and Exhibits, to formally open the exhibits.
I now formally open the trade exhibit of this year's PSA Midyear Convention. Thank you.
Thank you very much, Dr. Montecillo. And now, may I call on stage the PSA officers for a formal group photo to remember and mark this first hybrid convention. Please come up on stage po. Thank you very much. Thank you very much to our officers and host chapter. And now for some house rules and etiquettes. All delegates can enter the landing page of the convention through the link provided, sent to the email address used during registration. Virtual delegates will not be given audio and video capability except for those involved in the program. Both virtual and on-site delegates can type their questions and comments in the Q&A box, which may be read by the assigned moderator during each session. On-site delegates may ask their questions live as well. All delegates are encouraged to visit the virtual booths through the links on the landing page. Exciting prizes await you in some booths. All delegates must answer the evaluation form at the end of the convention to receive their certificate of attendance with corresponding CPD units. Again, welcome to the PSA Midyear Convention. Let us enrich ourselves with the knowledge and updates that we will learn in the succeeding days. Please stay for the plenary sessions which will follow shortly. Good morning.
Here, where... Yeah, kung nasaan siya. Maayong buntag sa inyong tanan. Welcome to the PSA Midyear Convention here in Davao. So to formally start our scientific program, let me welcome our first moderator for today. She took her clinical fellowship in pediatric cardiac anesthesiology at the Jupiter Hospital in Mumbai, India, and took her clinical fellowship in thoracic and cardiovascular anesthesiology in the UPPGH. Let us all welcome Dr. Angelica Palabiab Manalang.
A pleasant morning, everybody. To start off today's events, I would like to introduce to you our first speaker, Dr. Lisa Angela Nieto. Dr. Nieto is currently the Vice Chairman of the Department of Anesthesiology and Pain Medicine of the Cardinal Santos Medical Center. She is also the Chair of the Credentials Committee and the Training Officer since 2017. She is the head of the Accreditation Canada International Perioperative Services and Invasive Procedures Working Committee and an instructor of Access Philippines, which stands for Anesthesia and Critical Care Education through Simulation Special Interest Group. She is also currently doing her Master's in Hospital Administration at the University of the Philippines College of Public Health. Let us please welcome Dr. Nieto.
Good morning, everybody. Maayong buntag to everyone, Davao colleagues, PSA members, and officers. Thank you very much for this opportunity. I'm here today to talk to you about handover practices for patient safety. The what, when, where, and how of effective communication among healthcare professionals. Just a moment while the screen reboots. Once again, I'm here today to talk to you about handover practices for patient safety. The objectives of my lecture is to, number one, describe a clinical handover and types of handovers conducted during the perioperative period. I will also discuss the connection between the lack of a standardized handover and increased morbidities and adverse outcomes. I will discuss the components of an effective one and describe the challenges and barriers to implementing good clinical handover practices. And finally, I will discuss the need for handover education integration into the anesthesia residency training curriculum. I hope I will be convincing to you today. First off, what is a clinical handover? Well, first it involves the transfer of information about and responsibility for the care of our patients to another professional or group of professionals on a temporary or permanent basis. It is usually a routine activity. You may not know, but you already do handovers probably in your practice. It happens in a change in duty shift or in other clinical contexts, such as an interdepartmental transfer or when care is escalated to a higher dependency unit. Good quality handover is essential to a safe patient journey. And let me just pause to say, we might win in the technical side. I know we are all excellent technical clinicians. We are very, very vigilant during the procedures that we are anesthetists to, but let's not lose that excellence in the perioperative journey. The clinical handover is key for that. The primary intention of a clinical handover is to transfer information accurately and to ensure patient safety and continuity of care. It is one of the most influential moments in a patient's journey. Missing or fragmented information can lead indirectly or directly to death, delay, or disability. Ultimately, the clinical handover is our communication tool. It is essential. The clinical handover is essential on our road to patient safety. And what is patient safety? It is the reduction of risk of unnecessary harm associated with our field to an acceptable minimum. The problem is, in our realm, the perioperative realm, our patients are particularly at risk because there are a number of transitions in care from consultant to nurse, nurse to nurse, resident to nurse. There are many ways and transitions that our patients undergo, and that is why they are the ones that are most at risk. There is a study by Siddiqui et al. About the inconsistency of information. It is an observational study, and it showed that information deemed relevant by a PACU nurse may be different from what we deem as relevant. Important information is omitted without a structured format. So how did this clinical handover evolve? At first, it started with a surgical checklist. And then it evolves into an unstructured handover that we do ourselves. And then finally, this last decade, there has been a move to structure the clinical handover. And it started with the S-bar, and now it has morphed into an IS-bar, ISO-bar, and more specifically to our realm, the post-operative pro forma. And I will show you examples of this later. So let's start with the surgical checklist. In 2009, the World Health Organization endorsed this checklist, and it was designed to reduce errors and the occurrence of adverse events while increasing communication and teamwork during surgery. What resulted was a significant reduction in patient morbidity and mortality. So this checklist moved from the surgical arena to other hospital areas that are high risk. The S-bar, on the other hand, did not originate in our field. It originated in the US Navy. It was created to communicate between nuclear submarines, and likely so, because these are expensive, huge million-dollar machines. And so they needed to make sure that the communication was accurate. So here is the S-bar. As you can see, it is composed of 4 elements: situation, background, assessment, and recommendation. Situation are the patient details, the reason for the referral. B is background, patient history, lab exams, diagnostic results. And mind you, these are the pertinent measurements only. You don't read out the entire CBC, only the ones that are abnormal or are relevant to the case. Assessment is working diagnosis, what needs to be done, and possible differentials. While recommendation are actions that need to be taken and suggestions on ways to address the problem. This was first introduced in healthcare in 2002 by the Kaiser Permanente Rapid Response Teams. The IS-bar, and this is the one endorsed by the World Health, has a component of identify. And this is not just identifying yourself, it's identifying your patient to the one who is going to receive your handover. So it includes the patient in the actual conversation, in the handover itself. Situation, background, assessment, recommendation follows as usual. Here is an example of the written component of the clinical handover tool. This is meant to be printed out, and it has a lot of room for notes. And as you can see at the bottom, R can stand for recommendation, read back, and risk. So you can tailor it to your own center if you would like your handover person to read back to you what you said. And this is actually done in the next adaptation of this clinical handover. Another one is risk. So if you are having a patient that is acutely ill, you can also communicate the risk. So the ISO bar, and this is another variation of the clinical handover, this was introduced in Western Australia because there they had a lot of helivac from a local primary center to a tertiary center. So they needed a handover tool tailored to their area. And what this handover has, as opposed to the others, is the element of observation. So you can update your professional who is going to receive your handover on the most recent vital signs, the current state, sensorium, etc. As well as they emphasize readback so that the same shared mental model will not be different. Here is the post-operative pro forma, and this is specific to the OR to PACU transfer, and it has patient-specific data, anesthetic considerations, and surgical considerations. So this is the one that is for our realm, and I think this is the one that's best adapted to operating room to PACU transfer. Regardless of what you choose as a clinical handover, then there are 5 components of a good one. Number 1 is preparation. You have to have all the laboratory exams available, chart reviewed prior, and physical exam done, structured with a written component. So I cannot understate the importance of having a written component because it is like a prompt. So you can follow a format and sequence to prevent this missed information. It also allows for note-taking. It has to be sequential. The order of tasks has to be done at the same time. You cannot do a physical and verbal handover at the same time. That is prone to distraction and loss of information. It has to be in a protected time and place, free from distractions. And number 1, I think this should have been moved to number 1, it has to be supported by organizational leadership and training programs. You have to have the same clinical handover tool cascaded to the different departments. The importance of structure is that it organizes the relevant information in a way that allows for preparation, and it will also allow for the sender and receiver to have the same shared mental model, and that's vital to the success of a clinical handover tool. The problem with what we're doing now, the unstructured handover, this is what we're doing now actually. This happens in our PACU, and it is in a dynamic place. It's a complex place where practitioners are prone to this, what's called production pressure. We need to get things done. We need to move on to our next case. Our nurses might be short-staffed. This is an area with very high potential for information loss and error. Handovers are done here, both verbal and physical. So you're attaching your patients to post-op monitors. At the same time, you're shouting out orders to the nurse, to the resident. So actually, they found in a study, 65% of all our handovers are actually done this way. And this leads to distraction and lack of focus, and it creates a potential for information loss. The problem with miscommunication is rife in all the journals I read, and there are many. The majority of critical incidents in the ICU setting found that the causal factor is poor communication. 80% of serious medical errors caused by miscommunication during handover happens between medical providers. So it's among our teams. We are highly skilled, yet we miss out on information transfer. And the lack of standards of care are the reason. It's not a personal individual miss. It's actually just a systemic lack of standards of care. And this is what happens so that it contributes to the lapses in medical care. The impact of a poor handover, I'd like to share with you this older study just because we knew about this a long time ago. Brennan et al. In the Incidence of Adverse Events and Negligence in Hospital Patients, New England Journal of Medicine, 1991. 30,000 discharges from 51 hospitals in the New York State were studied. Out of those, only 3.7% suffered a serious event. However, 80% was found to be miscommunication as the causal factor during handover between medical providers. So this is a large patient data, and they found that miscommunication was at the heart of the problem. And then when a qualitative study was done by Nagpal et al. In 2012, they wanted to zone in on what it is that's failing in the communication. And they found that the failures in communication and information transfer happen across the surgical pathway. And what are they? They are usually content omissions. So there is incomplete or missing information. And this harkens back to a study I mentioned earlier, when the inconsistency of information is the root problem. And so what happens is there's content that is omitted. Another close second is too much information, too much unfiltered information that the professionals don't know what it is really important about the patient. A follow-up study by the same group in 2013 showed a direct correlation between poor communication and task errors, and an indirect correlation between good teamwork and the reduction in content omissions. So if the team was rated to be good, well-working, then there was also a consequent reduction in task errors. So it begs to ask, do we really have to do this? Won't structured handover just prolong the process and cause unnecessary delay? Is it really worth the time? My answer is yes, of course. The impact of a poor clinical handover is monumental because it not only is dangerous, it also lengthens their stay in the hospital. So it's shown to actually increase your average length of stay. So this potential for harm of miss and near miss, death and disability, misdiagnosis due to delayed action, this lengthens your patient's stay. So it's in our best interest to do them. What are the barriers that prevent good clinical handovers? Of course, you can surmise a lack of structure, no organizational support, no protected time, improper conduct, you don't do it right, staff hesitancy, nobody does it, and no written component and no training. So how can we fix this problem in our centers? There are many ways to go about effective education and training once it's supported by the organization. You can do simulation and role play, followed by didactic teaching so that they know why they're doing the clinical handover. A short video example was shown in studies to be very effective. You don't want to belabor the point. It's a simple thing to do. So a short video is enough with a little bit of structured didactic feedback. So the most important part is really to close the loop of education, direct observation and feedback by experienced clinicians. There is no halfway to do this. You have to do it the right way. And so there is a clinical handover assessment tool that I can provide for anyone who wants. It is a specific way that it is done, a correct way. It even critiques how you identify yourself, whether you need prompting or you do it at the end or in the beginning. So there are specific ways to achieve the clinical handover in the right way. So I would like to share with you what happens when you do institute clinical handovers in your center. There's a study done in London. It's called Improving Post-Operative Handover, a Prospective Observational Study. So they introduced a clinical handover in an acute center in London. A total of 90 handovers were evaluated by a trained researcher, 50 before and 40 after the introduction of a new handover protocol. This was the one I showed you earlier, post-operative pro forma. So this is what they used as the intervention tool. What they got as results was quite dramatic. So as you can see here, if you can see here, the blue bars show you the number of information omissions committed before the clinical handover, and the red bar shows you what happened after the clinical handover was introduced. So there was a significant, and it was statistically significant, reduction in information omissions with a simple handover tool. And here is a more drastic representation of the results. The number of task errors were greatly reduced in all areas before and after the handover. So the blue bar shows you the number of task errors that were committed before the handover, and the red bar shows you what happened after the handover tool was introduced. The added bonuses of having a clinical handover that was found by the study, and which were significant, were that it enhanced socialization of the teams. the nurses, the surgeons, and the internal medicine specialists actually were able to work together in a more efficient way. And why not? The Joint Commission statement says the breakdown in communication was the leading route of sentinel events reported during 1995 to 2006. So we've known about this quite a while. So I would like to share with you what happened in my hospital. I won't say when, and these are actually changed to protect the identities of the practitioners and the patients. This is just a reenactment, but this is based on real facts. We had a 26-year-old female, post-primary CS under CISEA. She arrives at the Paco DR, and this was her handover. Just a minute, there is no sound. Okay. Last night, the audio.
Here. Don't forget.
Okay. Okay, short glitch. So, like I said, this is an example of what happened in our center. This was a case that, based on real facts, this is the usual handover, and this was pre-intervention, of course. We had a 26-year-old female post-primary CS under CISEA. She arrives at the Paco DR, and this is close to probably what happened on that day for the handover.
Okay, very good here. Don't forget to have the nurse hook the patient up to the epidural infusion, okay?
Okay, thanks, Dom.
What do you want from Mano? Okay.
And this is between the resident and the nurse.
Please don't forget to hook up the epidural once the patient is watching. Thank you.
So as you can see, I barely finished what I said and it's over. So less than 8 seconds, the clinical handover was done. what really happened to this patient was that the epidural infusion was mistakenly hooked to the IV line, and the patient it wasn't detected until 8 hours after the procedure. So by the third duty nurse pa. So the patient had been transferred from our PACU to the floors, and then another shift happened where they were finally detected that the epidural infusion, and it was only detected because it ran out. So the epidural infusion was mistakenly hooked to the IV line, and this was wrong medicine, wrong mode of delivery. Nothing happened to the patient. There was only a fraction of local anesthetic that was given per hour, so nothing serious, but it showed us the potential for harm of a poor handover. So here is an example of an ideal handover. And this one, we just used the ISBAR. We didn't use the post-operative pro forma because I actually just stumbled upon that pro forma recently. And so we still use the ISBAR format. And this one on the left is the written component. And so you'll see here the resident use the ISBAR written component.
Good morning, ma'am. Endorsing patient Christine Reyes, 26, female, under she status post CS under combined spinal and epidural anesthesia. Intra-op, there were no complications noted, and our estimated blood loss is at 300 cc. The patient has no known comorbids, and currently her pain score is 0/10. She is in recovery with stable vital signs, and she is for epidural infusion once she is Bromach 4. Currently, the IV pain medications have already been started, and the IV antibiotics have also been started. Okay.
Okay, Doc, noted po. Our patient is Kristen Reyes, 26 years old, female. Status post CS under cesarea. No complication. Blood loss is 300 cc. No comorbidity. Pain score is 0. Out of recovery. Stable vital signs. For epidural pain. Pain management, once Bromach 4, IV pain medication started, and IV antibiotics started.
Perfect, thank you.
So as you can see, it only takes 1 minute. So, and this 1 minute can mean the difference between safety and not safety. So as you know, our hospitals, we try to make it the best, the safest place on earth, but we know it's not all the time. But did you know that Disneyland was neither? And let me share you this story, sort of to take a break from the didactic session today. I would like to relate to you a story of what happens when we move back on safety protocols, when we do not follow our safety protocols. Apparently, Disneyland had a dark day. And it was because in 1998, a new president of Disneyland was hired. And this was during the time that financial hard times beset Disneyland. It was a year that Paris Disneyland had flopped, and there were severe financial losses due to that. So they needed to do budget cuts. So what they did was hire this new guy to do some budget cuts, and they instituted what was called a reliability-centered maintenance to account for those budget cuts. They only examined rides that were historically problematic. When before they had a specific engineering team check every single ride every single day, they pared it down to one engineering team that went on duty at night and only checked those rides that were historically problematic. So the other rides, they were just on call. So previous safety protocols were foregone in the interest of money. So what happened? 4 years ensued of very grisly morbidities, accidents and death in the most benign rides. So you can research this really happened. They had accidents at the teacup ride. I rode that with my toddler. It's supposed to be benign. And then the Columbia ship, that's very slow, going around Disneyland, they had a very bad accident there as well. Of course, because of the budget cuts, even the Matterhorn and the roller coasters had accidents as well. And so when they investigated, OSHA, which is the Occupational Safety Hazard Association of the United States, they investigated 4 deaths in Disneyland from 1998 to 2003, and they blamed this reliability-centered maintenance. they saw that the practice of only examining and doing safety protocols on historically problematic rides was the problem. And they were questioning the engineers, saying, why do you keep on checking the lap bars every day? You know they're not gonna fail. And the main engineer said, well, that's precisely why we never fail. It's because we used to check them every day. So, like Disneyland, let's re-navigate towards patient safety. Let's move forward, like Dr. Simon said, re-navigate towards a safer outcome. Let's not move backwards on safety protocols. Safety training are habits. They begin in residency, as you know. And these standard safety procedures and handover tools, the checklist, S-bar, IS-bar, these all make up good habits. And this is vital in our road, in our journey towards patient safety. And when do we do this? 100% of the patients, 100% of the time. So thank you very much. I am done. It's an honor and a pleasure to talk to you today. Maayong buntag.
Thank you, Dr. Nieto, for that very relatable and relevant lecture. And now we know that the pandemic is far from over. And that, combined with the daunting tasks and responsibilities of us anesthesiologists, we would want to stress the importance of mental health, especially for the youngest members of our community, our residents. So to give us a lecture on residents' mental health is Dr. Josefina Lee Uson. She had her fellowship training program in consultation liaison psychiatry in the Department of Psychiatry and Behavioral Medicine of the UP PGH. Currently, she is the training officer of the fellowship program and the chair of the UP College of Medicine Committee on Student Resiliency and Wellness Program lead. She has been the former chief of the section of consultation liaison psychiatry of the Medical City, and currently she is the vice chair for education of the UP PGH and is an associate professor of the same department. Let us please welcome Dr. Uson.
Good morning, everyone. I'd like to thank the Philippine Society of Anesthesiologists for this invitation to give a lecture on mental health, particularly that of your residents in training. I commend your organization for choosing this relevant topic and giving attention to physician wellness, knowing how your work in the operating rooms and in the hospital can impact on your well-being. And of course, knowing how the situation in the country nowadays can even affect our mental health. Hopefully, it will allow you also to reflect on your own well-being as an anesthesiologist, whether you are a consultant or a resident in training. Indeed, we're in a field that cares for patients, but this is how important it is for us too to take care of ourselves and of course to give support to the residents who we train. Okay, so with that, we will follow this outline for the lecture. Okay, so how do we define mental health in the context of medical residency? So first, mental health is a positive concept. It is related to the emotional and social well-being of individuals. So for your residents, it's how they enjoy life, how they regulate their emotions, how they relate to each other, and of course, how well they function at work, in the operating room and in their workplace. So overall, health oftentimes is equated with physical health, but this is not enough, no? So it's physical and mental health that actually contributes to the overall well-being of any individual, including the trainee in your workplace. So what about mental ill health? This encompasses mental illnesses and mental health problems. So mental illnesses are those which are clinically recognized signs and symptoms that can be a diagnosis and can fulfill the criteria of certain medical mental health disorders. On the other hand, mental health problems are those which do not fulfill the criteria, but nonetheless, they are worthy of being concerned because they interfere with how a person thinks, how a person feels, how a person behaves, or even relates in situations. So oftentimes, mental ill health occurs as a result of various stressors. It can be personal stressors, psychosocial stressors, and of course, work-related stressors. Now let's look at the prevalence of mental health problems in your field, anesthesia. We know that for medical practitioners, the rates of psychological distress is quite high, but anesthesia as a special field in itself is known to have higher rates of mental health problems, including burnout, depression, suicidal behaviors, and substance abuse. So looking at these data, I thought that the first one, which was a study in China that comprised about 500 anesthesiologists, it showed that 65.4% had different degrees of bad moods, and almost 40% suffered from poor mental health. So you can just imagine how high the prevalence is of such concerns in the anesthesia field. So for burnout, at the OR setting, it can reach up to 40%, and in the ICU setting, even higher than that, up to 55%. Burnout is somewhat related to depression, and there's an increased risk as well of depression among medical physicians, but particularly among anesthesiologists. There's one study that showed about 30% rate in depression for not just anesthesia, but across all specialties. But for anesthesia itself, it is also quite high. And up to about 15.8% of increase was seen within 1 year of training. That means when they enter, they come in non-depressed. However, after 1 year of training, then they develop depressive symptoms. Closely related to that is suicide. There are also higher instances of suicide and suicidal tendencies and behaviors in anesthesia as a specialty. But there are also some studies that show that there is no difference across specialties. About 16 to 25% of those who suffered from depressive symptoms also reported suicidal ideations. For substance use and abuse, there is limited data about this, but there is enough data to show that there is an increased risk for substance abuse, particularly addiction in the field of anesthesia. So what are the factors affecting mental health of anesthesia trainees? So we know how there's a high level of work stress in the field of anesthesia. You're dealing with lives on the OR table and making sure that throughout the surgical procedure that the patient's vital signs are well, hemodynamics is good, so everything else is working until the patient is roused later on. So just imagine how high the level of stress is for that. And on top of that, there are long work hours. No? You work long hours, and then there's shift work, and there's also being on call at any time, especially for emergency procedures. There's also a low level of job control in your field, particularly because, of course, surgeons are the ones who schedule most of the ORs if they are elective, if they're emergencies. Likewise, for the different surgical fields, there are. And then, of course, those who give birth. No? So anytime they are ready to give birth, they will just do so. So there is low job control. And then on top of that, of course, being trainees, your consultants are also the ones who would actually advise, instruct you what to do. So generally, there is low job control, and as a result of that limited locus of control, usually there's also low job satisfaction. Many have also experienced isolation, especially if they don't experience that sense of belonging among their colleagues, whether it's the surgeons or their co-trainees as well in anesthesia. You know that once you are in the OR already, then you're not really able to see each other anymore. And usually this is part of the nature of the work. There's also a lot of exposure to trauma and death, since there are emergency cases or patients who may have medical conditions but are still operable, and hence you would witness a lot of these in your training. There's also a high level of stigma in that those sometimes who have been diagnosed or are seeing mental health professionals already may not be very open about their condition, because sometimes they are deemed to be unfit to work, or sometimes there are partialities also and discrimination that can exist. So apart from these, we also highlight substance abuse, because this is particularly also high and seen in the anesthesia field. So what are the risk factors for substance abuse? There's easy access and availability of opioids and other narcotics. I remember before, once upon a time when I was a trainee, we had tackle boxes which had all the drugs that we need. It was like a mini pharmacy in there. So you can just imagine the access among the trainees for these. And because of the high job stress, oftentimes this is how they would cope. Of course, it is an unhealthy way of coping, which is why it is something that is often used as a form of escape. So with additional stresses due to irregular work hours and sleep deprivation, and also the need for vigilance during long hours of surgery, others would resort to self-medicating with the use of opioids, sometimes to get a high, to numb themselves from pain or the stress that is in the workspace. So all of these would make them turn to substances. And of course, we know how unhealthy these are. So what about the effects of the pandemic on training? You can see here the aerosol box, which for a time was very popular when the outbreak started. We started to look for equipment that can help protect you from COVID. And we saw really how the anesthesia became one of the hardest hit fields in medicine as far as COVID is concerned. There were a few ORs or fewer ORs, only emergency ones left. So there's a reduced caseload, not enough for training. And then the subspecialty exposure also was likewise lessened. Perhaps the consultants would not go as often to the hospital and to the operating room. So there's also a reduction in the supervised procedures. There's a lot of cancellation of educational activities during that time. We know your in-service exams or diplomate exams were postponed. There were alterations in the clinical rotations. So it was really a lot of changes, a lot of adjustment going on. And of course, the work-related anxieties pertaining to shortages in PPEs, or sometimes even donning and doffing the PPEs in itself is a chore, and it's quite warm. And then, of course, knowing that COVID poses a risk to oneself, this really evokes a lot of fear among us and also among our colleagues. Apart from this, there's also home life disruption and concerns for families and even friends contracting the illness as well because of your exposure in the hospital. Okay, so how do we recognize signs of psychological distress among trainees? So how do we recognize these red flags? I think it's very important for you to know so that you can better support your trainees. So among the signs of burnout are difficulty with memory and concentration. So we know how in our field, it's very important to be quick in thinking and to be good in remembering. And so this can falter when burnout and depression come in. So there's also deterioration in productivity and in the work output. There's also a lower level of motivation and lack of interest in the work itself. There's difficulty in making decisions, indecisiveness, or even looking for solutions to problems. So oftentimes we would see trainees withdrawing from others, their own, let's say, colleagues, their consultants, or even their peers. And there could be significant changes in mood, lower levels of energy, and even lack of appetite. So aside from this, there could also be anxiety symptoms and then feelings of lethargy or feeling tired. There's excessive worry in some, nervousness, and high levels of irritability or feeling on edge, so high emotional states. And then for anxiety attacks, some can be hyperventilating, sweating, or experience numbing, or even shaking or trembling. And then, of course, signs of substance abuse we should also watch out for. Okay, sorry about the background. Okay, so how do we assess the mental health status of our trainees? So in PGH, where I teach, we use the health needs assessment tool as a form of being able to assess the health status of our trainees and also to monitor changes in this over time. So you can design your own health needs assessment survey actually and put in what you want to elicit from your trainees. So there is, of course, during the pandemic, where mostly we do things online. So an online Google form was distributed among residents in the entire PGH, of course, including anesthesia. And this is how it looks, no? So the health needs assessment form has a data privacy consent because, as you know, then the trainees will have to disclose information, personal information about themselves. So data privacy consent is necessary. So it's part of the pages in the form. And of course, social demographic and personal data there. And then lifestyle and sleep habits. No, we'd like to know what it is that they have on their diet. Are they taking certain supplements? Are they taking, substances even? What are their sleep habits? How much sleep do they actually get when they are on duty, post-duty, or pre-duty? And this is, of course, where we monitor whether the quality of sleep is restorative and good, or if it is not restorative. Are they able to do exercise? So how much time do they spend in exercise, let's say in a week? Are they able to do moderate level, low level, or high intensity exercises? Do they get to do this? And then we include in the form the depression, anxiety, stress, or DAS-21 scale, which helps us check if there are depressive symptoms, anxiety, and stress reactions. So this is a 21-item self-report questionnaire, which automatically gives later on the interpretation whether they are in the mild level, moderate, or severe for depression, for anxiety, and for stress. So this is a very easy tool to give, and that is what we picked because it has all the three components which are the most common that we have to watch out for. The brief cope is also another self-report questionnaire that assesses their coping styles. So if you'd like to know whether they usually use passive avoidant coping or approach problem-solving type of coping, then this will be able to elicit that. This is about 28 items. And then included in the form also are questions about their mental health and how they wish to be supported. So how they wish to be supported by the department, how they wish to be supported, let's say, by their peers, by their consultants also, and then by their institutions. So there are things which are even on the administrative scale to be dealt with within the hospital. So this is an opportunity for them to be able to inform us how they wish to be supported. So notice how it is collaborative in nature, in that we want to find out from the trainees themselves how we could better support them. So what are the workplace mental health strategies that can be employed? So we're calling here all the anesthesia departments with training arms. Perhaps you could employ some of these mental health strategies for your trainees. Okay, so we look at this model where the approach is holistic, in the sense that it tackles the three important aspects. One, promotion of mental health, that's at the bottom, and then followed by prevention of burnout and mental health problems by reducing some of the risk factors at work, and then the interventional aspect, where we provide medical and psychosocial services to the trainees with mental health concerns. So we would like to look at a program that allows all of these aspects to be covered. So first is the promotion of mental health. We can look at it in an individual-based mental health program. For example, encouraging your trainees to promote a healthy lifestyle, have a good, healthy, balanced diet, try to check on their sleep requirement if they are getting adequate sleep, even on days when they are not on duty. Are they able to do some exercise? So promoting a healthy lifestyle among your trainees is important. Another one is developing individual skills like financial management skills, stress management skills, and even communication skills, because these are life skills that can go a long way as they progress from this part of their career, and then eventually when they become consultants in the future. And then, of course, we want them to avoid unhealthy habits or vices, which they tend to turn to in order to cope with stress. So they can reduce drug use, nicotine use, and even take alcohol only in moderation, and not get into excessive intake of alcohol that can lead to addiction or dependence. So we mentioned that it's not just individual-based, but system-based is very important. So the entire department, and of course, if possible, the hospital should be able to create a safe and healthy work environment. And by this, we mean the kind of environment that fosters a healthy work-life balance, which means reduction in the workload, of course, and then a family-friendly environment, and some flexible working hours. Of course, hospitals usually provide services. So a work-life balance that will not compromise the services. Apart from this, the physical environment is also very important. So we know that one of the problems is that there is exposure to occupational hazards. In the past, let's say exposure to COVID patients. So having coverage for this, making sure that there is enough equipment, protective equipment also, or let's say scavenging systems are available in the operating rooms. So all of these even matter as far as physical wellness is concerned. Even providing compensation for, let's say, being overworked during the pandemic, or when they themselves become ill, is in itself helpful. No? So provide appropriate physical space to take breaks. So a place where they can have some quiet time to eat privately and also to rest. It matters a lot as far as their physical well-being is concerned. Increasing social connection and opportunities for peer support can address the isolation problems, no? So, which is why if you have socials or even game night activities online, or even for those who are at home, and then if they are in a staggered workforce, or of course, if they are present in the hospital, allowing them for opportunities to do so. At this point, let me show you this one. I must say, though I am literally married to an anesthesiologist, I've had a long-standing affair with the Department of Anesthesiology at the UPPGH. Our liaison program with them dates way back in 2012, and now on its 10th year, I'm quite proud and happy to see how they have developed their wellness program for the trainees. I'd like to thank Dr. Grace Herbosa and Dr. Maan Corsiga for sharing their photos with me. No? So they have what you call a huddle board, which is like a Viber group composed of all trainees and consultants who are part of the department wellness team. And so notice that they set this up in order to encourage their trainees to get engaged, to interact. And so this is a way of staying connected, even using the online platform. So and usually the activities need not be part of what they are learning already in anesthesia, because they have a lot of that. So exposing them to other interests, for example, let's say they've had a how to cook steak or how to brew coffee, where I think one of their residents is a barista and an expert in cooking. So these are things, or venues that they can share with each other. You know? On top of that, they also have wellness talks where they invite resource persons to do talks on aromatherapy, essential oils. You can invite somebody who does yoga or Tai Chi. They also had invited someone to talk about skincare and, of course, gender sensitivity as well. Some of the psychosocial support sessions that we have given them in the past include lectures on goal setting and time management, mindfulness-based stress reduction, and even sleep enhancement. No? So a mentoring protocol is also advised, and I think this is now in place also, and they have socials, no? So this is their Halloween party there, and I think looking at their faces, even covered by the masks, they look quite happy. Okay. All right, so the next layer, as we said, is prevention of mental ill health on top of the promotion of mental health. How do we reduce the risk factors? No? So it's very important to identify and address workplace contributing factors. I would say that no amount of wellness activities will really prosper if the stressors remain. And therefore, it's very important to address these stressors. So if it is heavy workload, or if it is the scheduling that is a problem, the trainees can actually express themselves so that the training committee can possibly do something about it, whether adjustments can be made with regards to the schedule, if there are certain workforce concerns, not enough people to station or to stay with the consultants in the ORs, this has to be addressed. And of course, keeping in mind that the services, we do not want to compromise these. So if there are solutions to ongoing admin stressors or work stressors, then these have to be addressed. Okay? So address concerns also about bullying, harassment, and discrimination. I think there should be zero tolerance for bullying and harassment. So if ever there are indicators and incidents showing this, it has to be addressed earlier on, no? From perhaps by the leadership, and of course, a committee that probably will look into it. Sometimes it's inevitable that, you know, batches, the freshman batch, and then the second years, and then the third year, sometimes there could be some conflicts. So if there is disharmony happening in the workplace, this also needs to be addressed. So oftentimes it can simply be conflict management or conflict resolution. But what we don't want is for these to be reinforced for a long period of time, such that they're already harboring ill feelings against each other. So the earlier you can address this, the better it will be for the whole team, so that they can work together harmoniously. And of course, it'll be stronger in that way. Okay, so again, it's also very important to improve the culture of medicine such that it promotes well-being and reduces the stigma of mental illnesses. It's very important to have that culture of acceptance, no? Whether you are in distress or not in distress. And it's also good to encourage proactively help-seeking behaviors. And so if you talk about mental ill health and the mental health problems that arise, then this can be addressed earlier on. And this is considered to be healthy behavior. So it's also very important to support early identification. So by the self, which means a person may be able to recognize signs and symptoms within himself, herself, or themselves, and then do something about it, no? So seek help. For others, it could be the peers who are lending a helping hand or extending their concern and their observations. Other times, it could be the supervisors, it could be the mentors or the consultants who can help identify these. That's why we showed earlier how to recognize the red flags. Developing a mentoring protocol in the department is very important. When we gave out the assessment tool in PGH, mentoring happens to be the top activity that the trainees found to be potentially helpful as far as boosting their well-being is concerned. So I suggest that you check on that if you would want to try it out in your own departments. And if you're interested, we could help you create such a mentoring program, okay? All right, so on top of the pyramid is the interventional measures for those who are in need. So it's very important to improve the capacity of staff members, especially the ones who want to help out, no? To recognize and respond to mental ill health. This is where you can learn mental health first aid. So how to approach, let's say, someone who has mental health concerns. So it doesn't have to be just a mental health professional who is doing this. Of course, this is just frontlining, but eventually forging partnerships with mental health service providers will be, of course, helpful. This is why we have that long-standing relationship between anesthesia and psychiatry, because we help them out whenever there are mental health concerns, no? And providing clear mental health pathways to help seeking and treatment is very important also, so that the trainees who have concerns know how to be able to access services. Okay, I'll show you later an example of the pathway. Okay, so I mentioned mental health first aid because this is something that you yourselves know. It doesn't have to be a mental health professional to do this. Mental health first aid is something that even a non-medical person can do. Of course, clinicians, this could go a long way as far as you helping your colleagues, your trainees, etc. So assess for signs of distress. That's why earlier when we showed how to recognize red flags, have a radar and watch out for these, because if you start seeing behaviors in your trainees that indicate that they could be depressed or anxious, then you can approach them. So when you approach the person, it could be one-on-one, it could be through the mentoring process, and this is usually appreciated by the person who you are reaching out to. As you approach the person, accept the person while he is in distress. No, there is no need to be dismissive about it or to try to lift the person's mood right away, but rather just approach and accept how the person is presenting himself or herself. And then listen empathically and non-judgmentally. Let us not be too quick to give advice, because we also want the person to express his feelings, thoughts, and any sentiments, no, or even problems or worries that they might have. So it's a big help in itself when you're there to lend a listening ear. Give reassurance afterwards if you think that the problems could use some solutions, no, and something can be done about it. Try to see how you could also teach better and healthier coping strategies to the trainee. And of course, hopefully the trainee will be open to these, and this is when it will be most beneficial. And like we said, you are not taking the place of the mental health professional here. You're just there to encourage them also if they have any hesitations or reluctance in help seeking. You also have to accept your limitations and know when the person is supposed to be referred. No? And then, meantime, while waiting to be seen, encourage self-care. They may be going through a lot, and sometimes it goes beyond their awareness that they may be neglecting themselves as far as eating, sleeping, hygiene, physical activities are concerned. So maybe being reminded of this will already help a lot. So encourage self-care and self-help also. So this is mental health first aid in a nutshell. So hopefully it's something that you can also do in order to assist your trainees in need. Okay? So this is the mental health referral pathway that I was referring to. So this is just an example. You can also create your own. So there is an arm with, if it is on emergency basis. So this is of course lengthwise, but we just showed it this way so that it could fit in the slide. And eventually, the recognition can be done at the level of the department, or the trainee himself could also approach the mental health professional. So making sure that numbers are accessible and they know who to reach. There is also an option to be seen by the fellow, the psychiatry fellow, or consultants on a private basis. No? So this mental health referral pathway is in place. So if in your institutions, it would help a lot if you also have this, so that the trainees can readily access mental health services. Okay. So we have presented, no, I have presented here how it is to actually create or establish a comprehensive anesthesia wellness program, which can have several arms, including the promotion of mental health, prevention of burnout and mental health problems, and then, of course, the interventional arm also for those with mental health problems. So if you would like to design your own, really to tailor fit it to your trainees, then it would be beneficial to them. So together, you can build a safe, healthy, nurturing, and compassionate work environment for your trainees and for the rest of the staff also. Okay. So with that, I'd like to thank you all for your kind attention.
Thank you, Dr. Lee Uson. And now let's have a 30-minute break. We're going to have a lecture symposium by our sponsor, Menarini Philippines. Let us welcome Dr. Gian Van Paulo Tenorio.
Hello. Good morning, everyone. In behalf of Menarini Philippines, I would like to thank everyone for being here today, this wonderful Thursday. We will be joined via a pre-recorded lecture talking about multimodal combination for the effective control of acute pain by one of our most esteemed experts, followed by a reaction from one of our highly regarded speakers. It is with great honor and pleasure to introduce our speaker and reactor for today. Our speaker for today is a consultant in pain medicine and director of analgesic and pain research unit in London, UK. He served as a consultant and senior lecturer in pain medicine at his hospital and is a director of pain research unit at King's College School of Medicine in London. An avid author, he has published extensively on the subject of pain. Our reactor for today is an anesthesiologist who finished her training at the Philippine General Hospital and has her practice in multiple areas such as in South Luzon, mainly at Perpetual Health. She is currently the chapter president of PSA Southern Tagalog. I am proud to introduce our speaker, Dr. Magdi Hana, followed by our reactor, Dr. Shireen Riza Inzo de Guzman.
My talk today is going to be about the effective control of acute pain and what's the role of multimodal combination and the logic behind that. Across the globe over the last few years, particularly since 2017 onwards, there's been an attempt globally to improve our awareness of how to control and the importance of controlling acute pain, particularly in general aspect following surgery, but also across the board of acute pain management. And there are specifically lessons to learn from all these attention and the global influence. And unfortunately, even till now, the 2021, here we are, a third of the 21st century, there are still major problems that confront us in the management of acute pain. across the globe, and this is not to do with any rich countries or middle countries or poor countries, acute pain has been found to be lacking in its management, and it's very poorly effective across the globe. It is interesting that with all the modern combination, codeine and paracetamol are still the most drug used. In a very recent analysis from Canada, only a few months ago, have found that this is very extensively used, even though there's been quite a considerable amount of evidence suggests that that combination particularly are not particularly very useful combination. In spite of the fact that we had tremendous improvement in basic science and clinical evidence, there is a reluctance somehow among general physicians particularly, is to translate that improvement, that understanding into clinical practice. One aspect as well, which has seemed to be a problematic and one of the hurdles in improving pain management is that professional, I'm talking about specialists, doctors, consultants, nursing staff, and so on, underestimate patient pain when you test that, as you can see within that recent article in Pain in 2018. And last and not least, there have been very few new compounds for pain. So really, we need to improve our understanding of the whole complex of pain management, and so use our drugs that we have considerably better. It's also, we need to evolve why we need effective pain control. It is not just about being nice, but in actual fact, it has a very major, important role to play in reducing the healthcare burden, to return patient to full function, but also at the end of the day, better economy and less wastage. That is the evolvement, the step we need to follow to actually get an improvement overall in pain control. And also we need to appreciate that there are consequences of poor management. And it's not just about being unkind to patient, but there are consequences which lead to increase the demand on health service by increasing hospital stay, increasing infection rate, increasing re-hospitalization, but as well as the emotional consequences. Now, one of the biggest problems which we see is that the increase in chronic pain development. And that is an issue which is very important because that has consequences on the demand on the health service. So how now we can improve that, how we can get a better outcome for acute pain management. And my understanding is really quite straightforward, how to break the barriers that we face. And the first thing is that we need to fully understand what is the mechanism of acute pain and the difference between pain models. There is a big difference between doing a bunionectomy and a difference between total hip replacement and a knee replacement. There is a difference between hysterectomies and dental extraction. That is a very important aspect. By understanding the different mechanisms, understanding the pain models, we can improve the outcome for our patient. It is very important to identify the risk factors, and there are very important risk factors. It is important to identify that gender has a role to play, that men and women behave differently and react differently to certain medication, and we need to identify that. Age is another risk factor, which is also very important. As globally we are getting older, then we need to understand the factor behind that. We need to target the individual patient and make the patient the center of the medication and the center of care, rather than treat all to be the same. And last and not least, there is no doubt that looking at the most effective way and the most improved outcome is that we need to think more away from monomodal or mono drugs into multiple modal and a combination therapy. And of course, last and not least, research the best combination, the best dose. I know that is not easy, but that is the way that we can appear to improve the outcome of acute pain management. and pain management in the general aspect as well. The mechanism of acute pain has always been sort of subconsciously related to nociception. But in reality, when you analyze the different mechanism of acute pain, you found it is really much more complex than that. There is a significant degree of sensitization of the whole neural system, particularly as the pain intensity increases from moderate to severe. So this is something that we need to appreciate, because with sensitization, you need an exaggerated signal. With exaggerated signal, you need the pain signal will increase, and as a result of that, there are other aspects within the neural system will be activated. Yes, nociception plays a very important part, but again, the degree of nociception activation varies by the degree of insult that the patient receives within that particular trauma, whether it is surgical trauma or acute trauma as a result of any other injury. There is a significant degree of inflammation associated with nociception as well as with original injury. And that is something that we need to be very careful about. And last and definitely not least, we ignore the fact that there is a considerable in pain, in acute pain, there is a degree of neuropathic pain mechanism being activated, particularly in certain surgical aspect. For instance, knee trauma and surgical intervention of the knee have significantly more neuropathic pain involvement than hip surgery. Appreciating the different parts of that, that is how we can achieve a really patient-centered care plan and improving the overall pain management of our patient. Looking at this diagram, you'll see how complex pain moderating is. It's from the pharmacology to the environment to genetics to gender and so on. Appreciating all these factors, put the patient in the middle of it, and in the middle of it, then we can put patient care at the heart of that center. So when we think about multimodal, why do we think there is a rationale for that? And I think if you look at pain neurobiology, you will see that the system is a very complex system, that monomodal analgesics are insufficient in most moderate to severe pain. The evidence are there now accumulating more and more that there is an improved outcome when you use multimodal combination, specific multimodal combination, rather than mono combination. And it has now expanded beyond pain, in actual fact expanded in cardiac and pulmonary and oncology as well, and I will show you that in 1 second or two. How do we define multimodal? The International Association of Study of Pain have released its exact definition in 2017, and it is the concurrent use of therapeutic intervention with different mechanisms. That is really important to understand that. It is not just adding one drug to another. The drugs we have to use have to be specific and part of the cycle itself of the neural circuit that involve in pain. That is how we define it, and that's how we should approach it, and that's how we actually support it and supply the combination of drugs that can read that. It has to be aimed at different mechanisms within the circuit itself, rather than to be just an added to. So adding codeine to paracetamol, for instance, as I highlighted early on, would not fit in with that sort of definition of multimodal therapy. It is very interesting now, in actual fact, very, very recent. There was a wonderful article, which I would ask all our primary care physicians to have a look at The Lancet. It was only a few weeks ago in September, so it's really very recent from that point of view, a couple of weeks ago, which have analyzed the effect of multimodal therapy in cardiovascular disease. And not just an improved outcome that is reducing myocardial infarct, for instance, but it has reduced significantly the mortality and the morbidity of cardiovascular disorder. And this is by using a multimodal therapy and applying that within the medication you use for cardiovascular patient, rather than just monotherapy. Equally, in the respiratory disease, that's actually coming along, and there are some publications which have shown that. I think cancer therapy is one of the aspects, particularly recently, which we have looked at in the UK, and the combination therapy in cancer therapy has improved survival rate in things like breast cancer and other cancer as well. And there is no doubt that in acute post-operative pain, particularly moderate to severe, in situations like hip replacement, knee replacement, abdominal surgery, the improved outcome by how quickly patient can reach physiotherapy, how quickly patient can discharge, has now, I think, beyond doubt, have put forward that multimodal improve outcome significantly more than monotherapy. The classical picture of multimodal analgesia, in actual fact, has started some time ago in the 1980s. But I mean, now we have the scientific background to show that really one of the classical combination, which is mu opioid agonist, plus COX inhibitors in the form of non-steroidal anti-inflammatory, have produced an improved outcome. And this is very important aspect, is that what do we mean by improved outcome? It's not just by reducing dose of one drug or another, but actually by improving the overall picture and reducing side effects. And I think that, again, is one step improvement in our understanding of what multimodal analgesia is all about. And this is the crux of the matter. So you're just adding one drug plus another without any improving the outcome, reducing side effect, and so on. That is actually not enough to put the combination therapy there. And that is a significant understanding in our improvement of how to get a better outcome for our patient. Fixed dose multimodal combination have some practical aspect as well, is that you're putting 2 or more drugs in one tablet or one injection. That makes it much easier for patient compliance. It's easier to administrate. It produces a better efficacy and undoubtedly reduce the pill burden. And again, this was highlighted in a very recent publication by Varasi and all in Drugs in July last year. And I commend all our colleagues to actually look at all of these publications and read them at their leisure. I'm introducing for you today a relatively new for Southeast Asia, but it's been around now for the last year and a half across Europe particularly, and in certain parts of South America as well, is a new combination of dextromethorphan and tramadol. And I will introduce the rationale plus some of the clinical studies that we have conducted over the last 2 years and a half or so. Dextromethorphan is not a new compound. It's been around in the marketplace for at least since the 1990s. It's an equally COX-1 and COX-2 inhibitors. It's been analyzed significantly. We know that it has a significant peripheral analgesic action, like most non-steroidal anti-inflammatory, though it does produce its analgesia well before its anti-inflammatory effect. And that's most likely coming in from its central effect. And though originally we knew that it produced a reduction in central sensitization, very recent publications have shown that it has an effect on the descending track of the 5-HT and serotonin effect. And from that point of view, we now know that the central analgesic effect could be also through moderating the descending track inhibition. So we have a nice combination within one drug of a peripheral, very strong peripheral and anti-inflammatory effect, as well as some central which produce early analgesia before the inflammatory effect starts to kick. The pharmacodynamic is well known. We have analyzed that in a recent publication a couple of years ago. It is effective in acute pain. It has an efficacy in osteoarthritis, surgical pain. And within the multimodal setting, as far as from the 1990 to 2002, multiple studies that we have conducted, we have shown that it produces opioid sparing effect. but it also reducing the side effect of opioid. And overall, the effect on acute pain is not dissimilar to COX-2, and the side effect is very similar as well. Tramadol, again, is not a new compound. It's been around, particularly in Europe, since the 1960s, and in the UK, it's probably since the 1980s. It is well known to have quite a unique mechanism of effect, as it has very weak mu opioid agonist effect, but it does have a significant effect on serotonin and norepinephrine reuptake. So in other words, it also does reduce the degree of sensitization on one hand, but also does have an effect on the descending tracks, and by so promoting more analgesia than actually the weak mu effect. Overall, it appeared to have a lower abuse potential than the pure mu agonists like morphine, fentanyl, hydromorphone, and so on. The combination of these two medications, you can see from this diagram, it has a very interesting sort of design. From that, it does actually fact have exactly what is the definition of multimodal analgesia is supposed to do. So it does have a track effect from the periphery to the center to the supraspinal as well. So we have an effect on the periphery, effect on the spinal cord, and the effect on the supraspinal opioid receptors. And that combination produced that interesting combined effect. When we're looking at any combination, I think we're looking at a specific target effect, whether we produce a better pain relief than the individual compound, that it does have a target on the specific part of the mechanism of pain itself, that the pharmacokinetic will not be balancing itself, but complementary. It produces overall a better side effect profile, and overall the dose we use is smaller, but finally improve responder rate and broader spectrum effect. Looking at the pharmacokinetic profile of that combination, and you can see the Cmax of dexketoprofen is relatively quick. It's from 15 to 60 minutes, and the average is 30 minutes, where tramadol, its Cmax is 1.6 to 2 hours. So the combination of the two produce, on one hand, initial faster action, but also can last for a reasonable period of time, for 4 to 6 hours. And that is a fascinating aspect from that point of view, that adding that complementary pharmacokinetic profile of two medication in one pill. And that's what makes it much more interesting for moderate to severe acute pain. There have been several studies of that combination in acute clinical pain. The first study, the first study was the third molar extraction study, and that was a dose finding study. We looked at abdominal hysterectomy with visceral pain, somatic pain in the form of total hip replacement, and last and not least, a combination study to compare what's available in the marketplace of tramadol paracetamol against tramadol dexketoprofen. And I will highlight some of the data that we have seen so far with the publication that you will find out at the bottom of each slide. So the first study, which is in severe, moderate severe dental pain, to identify the best dose combination of this in moderate to severe pain. And as you can see, I will highlight that for you. Tramadol 75 milligram achieved only 25% of the TOPAR over a 6-hour period. Compare that to 55% with dexketoprofen alone. Combination of the two, I think you will see that the tramadol 75 milligram plus dexketoprofen 25 milligram achieved the best result out of all of them. And that was the first study that decided on that 75 and 25 combination are likely to produce the most optimum result of that combination. Those for efficacy data for the hysterectomy study. This is a classical example of visceral pain, one of the commonest surgical operation, particularly in women. And as you can see here, the difference between the placebo line and the combination line in pain intensity score. And looking at that, you can see a significant difference also against 100 milligrams of tramadol and 25 milligrams of dextromethorphan. This paper as a whole has been published in the VMC Anesthesiology in 2016, so please, you can actually look at the full detail. There is much more of data in that paper, of course, beyond the scope of this talk today. I think one of the most challenging operations, particularly in combination therapy, tend to be the arthroplasty, both hips and knee. Is now one of the commonest surgical procedure globally. Understanding is so because we're all getting older, so we all need our new hips and new knees done over a period of time, and it is now exceed more of any of the visceral. So this surgical procedure was quite an interesting procedure to look at. And again, looking at the difference between the combination here, which is the red line, and individual medication of 100 milligrams of tramadol and 25 milligrams of dextromethorphan. And I think it's very clearly, you can see from hour 1 onwards, that there are significant difference between the combination against a larger dose of tramadol and the individual dose of dextromethorphan, as well as, of course, a significant difference against placebo. And that is highlight that there are not just a possible addition of the efficacy of the two drugs, but possibility. So we cannot say clearly there is a synergism, but there is a possibility of a degree of synergism as well. In other words, the analgesia of that combination exceed the individual compound significantly so. And that is, you can see that after 8 hours in that particular study. We also looked at this study, particularly at multiple doses, to look and see if efficacy is sustained. And as you can see, again, the red line shows the combination, and it is sustained up to 48 hours. And overall, in every single point of analysis, it was significantly better than the individual compound of the tramadol, which is, I highlight again, the tramadol dose was higher than the tramadol dose in the combination 100 milligrams to 75 milligrams and 25 milligrams dextromethorphan. And of course, quite a big difference as well, how sustaining with only dextromethorphan alone. And that shows that the efficacy is not just a single dose efficacy, but highlighted by multiple dose efficacy over a period of 48 hours. Looking at the responder rate of the efficacy result, again, you can see that, excuse me, a single dose phase, the red line can show there is a significant difference between that and the 100 milligrams of tramadol, dextromethorphan, and of course, hugely different between placebo and that combination. And that has carried on all the way through in the multiple dose phase as well. More recently, a recent study which we have published in 2019, which we compare tramadol, dextromethorphan with the available in the market place, particularly in significant part of Europe, with tramadol paracetamol. This was a double-blind, randomized, placebo, active control parallel study in moderate to severe acute pain. And I'm highlighting some of the points about the study. Over 650 patients were analyzed. 75 milligram tramadol, 25 dex, again is 75 milligram of tramadol, and 660 milligrams of paracetamol. The efficacy primary parameter was pain intensity, but also the TOPAR at 6 hours. And of course, percentage of responders and safety and side effect were fully analyzed. And in this here, I want you to concentrate first on the gray line, and you can see the gray line, this is the placebo line, and then the red line was the tramadol, paracetamol, as well as the blue line, which is the tramadol. The tramadol paracetamol was the blue line, and the red line is the tramadol dextromethorphan. And you can see at every point analyzed at point first hour, and 1.5 hours, and 2 hours, and so on up to 6 hours. The tramadol dextromethorphan was significantly different, significantly better than the tramadol paracetamol, and that is in the mean effect. And you can see that I think it's really quite different across the period of the first 6 hours in that sort of pain model. So again, just to recap on that, you're looking at the paracetamol line, at the placebo line, which you can see the effect there at the bottom, and they're looking at the tramadol paracetamol 75, 660 is the red line here, and then the tramadol dextromethorphan, which is the blue line over the period. And also looking, if you look to calculate the area under the curve of each of the combination, you'll see there is significant difference between the two. And I think that is very clearly with a degree of significance of more than 0.006, shows that there is a really quite a difference in the overall efficacy parameter of the dex tramadol combination than the tramadol paracetamol combination. And I think looking at the 50% of maximum of the TOPA, again, you can see there is the difference between first the placebo and the two active compound. But look at the blue line here, which is the tramadol dextromethorphan of 71%. Again, it's 44% of the tramadol paracetamol. So the dex tramadol has a significant difference at 2 hours, 4 hours, 6 hours, and it does reduce a little bit, though there is still significant, particularly to placebo, at 8 hours. And I think that is one of the highlights of the most recent study. And overall, if you're looking at global impression, you can see that there is again statistical significant difference between tramadol dextromethorphan and tramadol paracetamol. Exactly the same dose, exactly in the same model. And I think that is a significant factor. So, looking at overall so far of the clinical study that has been conducted, I have to say there is an ongoing other studies at the moment, but it hasn't yet finished. So once it's finished, maybe next time when we talk, I'll be able to highlight that for you. But overall, the conclusion of all study, that dextromethorphan tramadol combination, that is a 25-75 milligram, have shown efficacy in multiple pain models, both somatic, visceral, and inflammatory. I think overall, in moderate severe pain, that has been concluded. There is no doubt that the combination of 75-25 milligram in one pill is superior to tramadol 100 milligrams by itself, and dextromethorphan 25 milligrams alone. And also the combination of 25-75 is undoubtedly significantly better and superior to tramadol 75 and a paracetamol 655 milligrams. The analgesic effect as well, which is quite interesting, is not just a single dose analgesia, but it also has been sustained through multiple doses of analgesia. And overall, the safety profile across all of these studies have produced a very good result from that point of view, that overall is a good safety combination of the two compounds. So lastly, to complete that, the fixed dose combination of 75 tramadol and dextromethorphan 25 milligrams have produced a direct effect on multiple pain mechanisms exactly within the definition of the YASP of multimodal therapy. It has produced a broad spectrum of effect on multiple different types of pain, whether it is visceral pain, inflammatory pain, and somatic pain, moderate severe effect, and overall it produced a very good efficacy and effective pain control. Thank you.
Hi, good morning, everyone. So I'm Dr. Shireen Insa de Guzman. I'll just give a quick summary of my reaction to Dr. Magdi Hanna's lecture in the interest of time. Well, I absolutely agree with the use of multimodal therapy, not only for the effective control of acute post-operative pain, but also for the improvement of the general outcome of the patient. So including the psychological impact when undergoing surgery. So there's less pain, less trauma, decreased hospital stay, and a satisfied patient. Now, a fixed dose, multimodal combination drugs such as dexkitoprofen plus tramadol is a good option in this approach. Both drugs are very efficient in addressing moderate to severe pain, of course, provided that we are mindful of the patient's medical history and condition. While dose adjustment is limited, which we usually need, especially for patients with elderly patients with impaired hepatic or renal function, sometimes less than 75 milligrams is enough. But the important advantage, however, as mentioned by Dr. Hanna, is the reduction of pill burden, so which results in better patient compliance. So they just have to take one tablet once or twice or thrice a day to address the pain and not worry about having a daily timetable. So again, it is important that one needs to find the suitable combination for a given condition to provide the best analgesia for our patients. Well, if you have questions to Dr. Hanna, kindly just type them in the chat box and with your email addresses so we can send it to him and reply with the answers. That ends our session, our symposium. Thank you.
Okay, our next speaker has several fellowship training experiences under her belt. She is a cardiac anesthesiologist and an intensivist, as well as she's also a pediatric cardiothoracic anesthesiologist, and she also did her simulation in anesthesia and critical care in Canada. Currently, she's the lead instructor of Access Philippines, and she's a member of the Philippine Board of Accreditors of the Philippine Board of Anesthesiology. She's also an associate professor of the University of the Philippines College of Medicine. Let us please welcome Dr. Grace Catalan.
Good morning. Let me begin by thanking the Philippine Society of Anesthesiologists for giving me the privilege to participate in this year's mid-year meeting. The topic of my talk is on debriefing after a critical event, one that is close to my heart. This has been our advocacy for years now. And as we catch up with the rest of the world in adapting to the changing landscape in anesthesia education and training, we are more aware of the need and the value of debriefing in promoting patient safety, practitioner safety, and systems improvement in the healthcare. So, for my disclosure, I am not a psychiatrist, psychologist, or behavior therapist, and this session is not about stress debriefing, which is a therapeutic intervention to treat or prevent psychological trauma after a stressful event. Rather, this talk is about debriefing in real life to improve clinical practices in the future and is based in the context of the science and art of debriefing. So I have divided my talk into 3 parts. And the first, we shall look at the reasons why we should talk about debriefing after a critical event. And This is followed by a simplified structure on how to conduct the briefing after a critical event in parallel with the debriefing phases in simulation-based education. And finally, as we get ready to flex our debriefing muscles, we shall talk about critical points to remember to make your debriefing more effective and meaningful. Debriefing after a critical event follows the same basic principles in debriefing in sim-based education. The difference being it is done in real clinical scenarios and it is timed immediately after the event. Hence, it's called proximal or real-time debriefing, or hot debrief, or point-of-care debrief, or warm debrief, as this is carried out face-to-face or in person. On occasions, we can do tele-debriefing whenever debriefing is necessary and there are no debriefers within the premises. The goals are the same: to improve or to reinforce clinical skills and improve performance in future events. The participants should include all the members of the team, which is multidisciplinary or transdisciplinary and is not limited to one specialty. This should include all of the members who were involved in the care of the patient: nurses, surgeons, internists, and technicians. So why talk about it? Or what is the rationale in debriefing after a critical event? We shall look at two studies to further strengthen the move to integrate debriefing in processing critical events. So this first study was published in 2019 in Anesthesiology, and this was conducted by the group of Alexander Arriaga. This is a mixed method qualitative study done in a single institution, and the data collected were based on interviews of residents who were recently involved in a critical event. And the study revealed the following. Inasmuch as all the respondents agree that routine debriefing should be conducted after a critical event, only 49% practice warm or proximal debrief after a critical event. It is more difficult to debrief if the critical event is related to interpersonal issues or communication breakdowns than it is to talk about specific clinical aspects of the case. The failure to debrief in interdisciplinary teams soon after a critical event can negatively impact the team members, who are now called second victims. And again, this will negatively impact the care of their subsequent patients, who are now the third victims. And delaying debriefing is also a missed opportunity for learning, and the chances of repeating the same error is increased. So one of the recommendations at the end of the study is for establishing a multidisciplinary debriefing immediately after a critical event to improve relationships and culture and to provide an opportunity to prevent future similar critical incidents from happening, help support the clinicians for improved patient and provider safety. Now, the second study is a quality improvement study which analyzed the effects of human performance deficiency. This is the new taxonomy used to describe human errors and how it is linked to critical surgical events. This study was conducted by the group of James Solberg, and this is also a single institution but in multiple sites. And the data collected were from the weekly morbidity and mortality presentations of the Department of Surgery done for 6 months. So the study analyzed the role of cognitive behavior of healthcare teams and individual members utilizing the HPD or Human Performance Deficiency Classification to specifically highlight actionable cognitive errors and adverse events. So the results showed that more than half of the critical events were related to errors in cognitive function, such as lack of attention, lack of recognition, and lack of knowledge of concepts, whereas only 10% were attributed or related to errors in technical function or execution, and 26% were attributed to errors on team dynamics, that is communication and teamwork. So at the end of the study, one of the recommendations include the use of simulation-based training focusing on cognitive behavior of practitioners and teams to reinforce systems-based safety constructs in high-intensity surgical care. Now, when we talk about cognitive behavior, we are actually talking about diagnostic reasoning, which is now the focus of interest with regards to human errors or adverse events related to human errors. And diagnostic reasoning is defined as the cognitive process and the behavioral skills involved in the diagnosis and management of clinical situations. So it's a dynamic process of thinking and reasoning in the context of what you know and what you understand about the clinical concepts. Further, cognitive diagnostic reasoning can be broken down into three components. The cognitive part, which is memory and reasoning, and the behavioral aspects of diagnostic reasoning, which are one, in intrapersonal component, which is the capacity to manage one's behavior and emotions to achieve one's goals, and the interpersonal behavioral aspect, which is expressing one's ideas and interpreting and responding to the messages from others. So, in summary, if you meld the domains of cognition and behavior, then that will be your diagnostic reasoning. And an effective diagnostic reasoning skill equals safe clinical practice. Now that we have looked at the rationale for debriefing in real life, we now move on to talk about how to conduct debriefing after a critical event. So I will present a simplified 4-step structure on how to conduct debriefing following the phases of debriefing that we use in sim-based education in a simulated clinical event. And I will also present some structured debriefing scripts, which was adapted from PEARLS, or Promoting Excellence and Reflective Learning in Simulation. So the 4 R's are regroup, review, refocus, and reset. In reality, the actual debrief could last anywhere between 15 to 20 minutes. It doesn't have to be long, but it should be carried out in a quiet corner or small room where privacy of the group is ensured. The most difficult part, I guess, is regrouping your team after the critical event, because some might have gone home for the day and some will probably be working in another case. But it's very critical to conduct a debrief after a critical event. So I shall present a clinical vignette, this is going to be the platform for our structured debriefing process. So we have 2 junior residents, anesthesia residents, attending to an emergency vascular case, and one of them inadvertently administered IV heparin instead of topping up the muscle relaxant is rocuronium. Apparently, they are similar looking vials. And this resulted in the surgeon complaining of an oozy operative field all throughout the surgery and caused prolonged hemostasis. However, they did not inform the surgeons, but in the post-op period, they decided to report the event to another senior co-resident in the PACU. The PACU resident advised them not to tell anyone since the patient is already doing well. However, the plot thickens because the attending PACU nurse overheard the conversation and decided to inform the surgeon. So let's try this one. Okay, so the first step, like I said, is to regroup. Okay? So this is equivalent to the reaction space in briefing, where you talk about your emotions and try to vent out strong and emotions that during the critical event, and simply for the debriefer to be able to feel what is going on in the team. So like I said, so here are some phrases that you might want to use when you start your debriefing. And so for this case, the debriefer can probably say, how are you guys feeling? Maybe we can go around so we can listen to how everyone is doing. So as simple as that, simply to give time for each and everyone to vent out emotions. This doesn't have to take long, and it will probably take 2 to 3 minutes to go around the group and hear how everybody is feeling. So the next step is to review and record. So in the script, this is also equivalent to the description phase in debriefing in sim-based education. So you can use the following scripts, okay? So can someone summarize the case from a medical point of view so we are all on the same page? Or you can use a sentence. From your perspective, what are the main issues we have to deal with? And then you can have a follow-up question by asking, so what happened next? Now, again, trying it out in our example or illustration, let's call the other junior anesthetist as Anna. And so the debriefer could probably state his question like, Anna, since you are the primary in this patient, could you please tell us the main issues we have to deal with in this case? Simple, isn't it? And easy to do. So now we move on to the third part, or the third step. Now this is now the crux of your debriefing conversation. So refocus and redirect. The debriefer plays an important role simply because you have to keep in mind your role is to be a guide and not the hero. So you don't have to tell everyone what happened, what went on, and what to do next. So the role of the debriefer is to be the Yoda of the team. So let's look at the script, and this corresponds to the analysis phase of your sim-based education debriefing protocol. So the first step is to signal the transition to this stage, or to this phase of the debriefing. So this is called previewing. So you can make a statement like, now that we are clear about what happened, now let's talk more about the case. And now you can move on to some debriefing strategies. You can use the plus delta, which is probably the simplest and will give you a good yield in terms of getting the information that you need. So you talk about the aspects of your case that went well, for example. So what are the aspects of the case you managed effectively? And then you move on to the other end of the poll by asking your participants about what aspects of the case you found challenging or difficult. And this is also the point where you can identify performance gaps. So in this case, you can start by asking, does anyone know how to reverse the effects of heparin? And that could start off another conversation. Now here, this time, talking about the medical aspects of the clinical case. So this will probably, we will probably get more contribution or participation from the team. And so the last part is to reset. And this corresponds to the summary phase of your debriefing process. So again, you will have to signal or preview that you are transitioning or you are moving towards the end of your debrief. So you can ask questions such as, are there any outstanding issues that we need to take up before we end this debrief? This will give your participants an opportunity to air situations, events, feelings, or conditions that were not taken up, or these are the burning issues that are in their minds that needs to be vented out before you end the debrief. Okay? So in this scenario or in this illustration, you can probably say, so let's close this debriefing by having each one of you state one or two takeaways that will help you in your future cases. It is very important for you to let the participants identify the learning points. And as I said earlier, you have to be the guide, not the hero. You do not have to know it all, you do not have to tell all, and you simply have to guide or coach your participants so they will be able to uncover their frames and discover why they do what they do. Okay. So another would be some, like you can say, let's look at the key learning points in this case. So now you're ready to reset and the team is ready to move on to the next case. Easy, isn't it? Now, so we are ready. So we are ready now to start flexing our debriefing skills and start debriefing whenever there is a critical event. But before we end, I would just like to give you some critical pointers and something that to remember in order to make your debriefing more effective and meaningful. And again, these are based on studies. So these are myths that are related to debriefing. I know a lot of people say that debriefing is difficult and that it should be done only by the experts, or some of you would go to the extent that it is not necessary and it's just extra work. But as we have uncovered the rationale for debriefing, we would also like for you to have some takeaways on what not to do or what to be mindful of when you're debriefing. So the first one is, again, debunking some debriefing myths. And one of them, and one very important myth, is about the neutral debriefer. So the neutral debriefer is simply one who cares more about personal relationships than caring for the task performance, which is what caused the critical event. So what happens if you have a neutral debriefer? Well, you end up with a shallow, vague, and unreal debriefing. So at times, often, you fail to discuss the critical topics. And this is actually the failure on the debriefer to establish a psychological safety prior to the debriefing, and also the failure or of the debriefer to admit or include his advocacy during the conversation. So what are the recommendations? One is to establish psychological safety before the debrief. This is a huge topic and something that will probably require another lecture later on. The other recommendation is to use the debriefing framework, and in particular, we're talking about the advocacy inquiry framework of debriefing. Or you can adopt a stance of multi-partiality. Instead of just being partial to one or one thought or one person, then you can look at everything and be partial to the different perspectives presented by your team. And the other aspect that I would like for you to remember about debriefing is that you have to take into account the effects or the impact of culture in debriefing. Okay? So this study examined the impact of cultural considerations in how we communicate, teach, and learn. And we have to be very conscious of the cultural differences, not only in terms of ethnicity or geography, as this can affect teacher-learner relationships in debriefing. So what are the strategies that were stated in this study? So one is to increase your awareness of the cultural considerations. Second is to continually develop your global dexterity, meaning to say you have to be curious about others. You have to be mindful about the cultures of others. And again, these are not just, we're not talking about ethnicity or race. We are talking about the culture as a group. Each department has its own culture. Each hospital has its own culture. And improve or work on your cultural intelligence. And finally, and probably very important, is to be mindful of the generational divide. So we need to close the gap on generational divide, simply because we are now working in a multi-generational workforce. And so very briefly, if you look at the group that you are in right now, whether in your department, in your hospital, chances are you will have multi-generations in your group. So you have your baby boomers and your Gen Xers, probably your teachers and your consultants. And you have your millennials and the iGen, who are now the newer residents, and probably the fellows, not the fellows. And the reason why we talk about generational divide is not to emphasize this as something negative or something that is positive, okay? So we have to continue to describe the generational characteristics and attributes, and this is as neither positive or negative traits, but as facts. And we need to consider this when using our existing education content and methods, as well as when we develop future strategies. So some of the conversation dynamics that you have to think about or be mindful of in multi-generational discussion is that for some generations, purpose, autonomy, and hierarchy is important. For the younger generation, a lot of feedback and consensus is needed, but they also require a fair amount of autonomy. But the more, again, what is obvious now in our midst is the ubiquitous technology which we all have to learn and use, and something that we need to be flexible and resilient about. So in summary, post-critical event debriefing benefits not only individuals in benefits teams, the environment, and the overall healthcare system. We know that we need to bridge the gap between theory and actual practice. And we have to look at the influence of competence, culture, in the way we teach, train, and practice. Melding cognitive and behavior domains is how we teach, train, and assess in a multi-generational workforce. We talk about diagnostic reasoning. And finally, there is still a role. In fact, a lot of the studies emphasize the role of simulation-based education and training and continual practice in order to positively build a robust debriefing skills, not only for sim-based education, but for real-life events. At this point, I would like to thank the Group of Access, Anesthesia, and Critical Care Education through Simulation. It's a special interest group of the PSA for continuing to promote sim-based education and debriefing to all the training or to promote education in anesthesia and critical care. So here are my reference if you would like to do some further readings. And so thank you everyone for your kind attention and enjoy the day.
Thank you, Dr. Catalan. Our next speaker for this morning session is Dr. Zenaida Mariano. Dr. Mariano is the past president of the Philippine Society of Anesthesiologists. She is the director of the Regional Anesthesia Society. She is also the chairman and associate professor of the Department of Anesthesia of Our Lady of Fatima University. She is the head of the pain clinic of the said university and is also a department manager of the Education and Training Department of the Lung Center of the Philippines. Dr. Mariano is a board member of the Asian-Australasian Regional Section of the World Federation Societies of Anesthesiologists. Dr. Mariano has a PhD major in Educational Management and has a Master's in Science of Clinical Epidemiology. She has a Master's in Health Services Administration and she's a pain specialist who trained in Daradia, Kolkata, India. Let us please welcome Dr. Mariano.
Okay, thank you for that kind introduction. A pleasant good morning to everyone. First of all, I would like to thank the PSA for giving me this opportunity to share the program, Fast Track Research Program. Okay, during my dissertation study for my PhD in Educational Management, I designed and developed the Fast Track Research Program, or the FRP, to tailor the needs of our anesthesia residents in protocol development. But at the end of the program, I realized that the consultants have a vital role in the post-course discussion part of the FRP. So our training objectives for this lecture are: discuss the importance of a well-developed program in research, define a fast-track research program, and differentiate it from traditional program protocol development, discuss the feasibility of a fast-track research program on protocol development, and lastly, discuss how to establish a fast-track research program. So the current trend towards evidence-based medicine in the management of our patients relies heavily on research studies. Completion of a research study among anesthesia residents has an important aspect of their training. Knowledge and skills in the conduct of research should be learned during this period. Although research was considered to be important, the actual participation rate of residents remained low, and the reasons for this was unknown. In order to find out the reason for this low turnout of research among residents, we need to answer the question, why are residents unable to complete their research studies? A training needs assessment using a cross-sectional study was done to answer the question. The study was entitled, Perceived Training Needs of Resident Anesthesiologists to Conduct Research Study. The results shows that residents considered availability of guidelines from protocol development to the writing of the research paper as the task requiring greater training. Hence, the FRP will provide a reference guide. And the second result show that research protocol development was the primary specific area where residents required further training. Therefore, a training in protocol development is where we will focus. Residents were unable to comply with the completion of their research due to difficulty in research protocol development. Every clinical research begins with the development of a research protocol. Without a research protocol, you cannot go to the next step of the research engagement. And writing a research protocol is probably one of the most challenging and difficult tasks in the conduct of research. I hope you agree with me. Okay, and furthermore, it seems that the residents had inadequate knowledge on the different parts of the protocol development. Hence, the FRP will provide knowledge enhancement in protocol development. According to studies, there is a shortage of clinician researchers and deficiency of suitably trained and qualified research consultants. So consultants will also be trained in protocol development. Hospitals in different parts of the world recommends the following. For the research curriculum, the FRP has developed a curriculum for protocol development. Regarding outcome evaluation, the FRP has provided program evaluation to ensure continuous improvement, and finally, a dedicated faculty who will be assigned to facilitate the post-course discussion at scheduled time. Hence, the consultants will come in this part. In a survey comparing face-to-face classroom environment versus purely online learning environment, it shows that there are improvements in clinical skills, motivation in submitting assignments, and better grades of medical students. Hence, FRP will also use a learning management system. In summary, these are the features of the fast-track research program. It has a research curriculum, uses the LMS, provides reference guide, and has program evaluation. There are two parts of the FRP. These are didactics, which be delivered through the learning management system, and the post-course discussion, which can either be delivered online or face-to-face. Initially, it was supposed to be face-to-face, but due to COVID pandemic, the post-course discussion was delivered online. With regards to the didactics, there are 4 courses and 10 modules. And the post-course discussion, we have 4. So a post-course discussion will done when it is where the residents will submit their outputs. For example, the first course, research question and research objectives. So during the post-course discussion, residents will submit their output here, and the consultant faculty or the research coordinator will immediately correct any revisions for the research question and research objectives. Then the residents will submit the revised one, to the consultant, and after it has been corrected, then the resident can go to the next course. Now, the post-course online discussion, these are the comments of the resident. Cannot make the module task without the PCOD. it is also possible to do the module task without the PCOD, but will be very difficult. Percentage of assistance in completing and revising the module task, lecture video 40%, and the PCOD 60%. This one, if no PCOD, it will entail a lot of effort and courage for the residents to complete. So with regards to traditional protocol development, this is being characterized as fixed time, fixed date, and fixed venue. So if you cannot make it on the designated date and time, you will need to wait for the next workshop. Yet, there is no assurance that you will be available for the next workshop schedule. Hence, will lead to delay in the research engagement of the resident. In comparison to the traditional workshop, the FRP offers flexibility in time, date, and venue, and is available 24/7. It's like watching Netflix. So if you have something to do, if you have a case, then you can pause it. And after your case, you can go back to it. If you find it difficult, you can again move it backward once, twice, or several times until you have the full grasp of the concept. But during the video lecture, if you find it quite easy or you have been exposed to it, you can move it forward. So it depends on the residents, on your time. So when we will have the fast track research program and the video lectures, will be just like watching Netflix. And it is very convenient. You can use a desktop, laptop, tablet, or even your cell phone. You can access the lectures anytime and anywhere as long as you have internet connection. So now the question will be, what if you don't have an internet connection? I will answer that later. Okay, so aside from this, the FRP offers 3 opportunities for lectures, for learning. So you have the lectures, the module reference guide, and the post-course discussion. For the lectures, the lectures are in video format, so it's quite interesting. So let me give you an example. Okay, it's not moving. Okay, wait. Ayaw yun. Ha? Ikaw mag-click.
Hello there. I am Dr. Zenaida Mariano, and our topic for today is about research question formulation. As I have said during the orientation, that there may be many formats of a research protocol, but we will follow the one that has been proven effective based on my experience. The parts of a protocol are title, authors, introduction, literature review, research question, research objectives, methodology, ethical considerations, timetable, budget, references, and lastly, appendices. We will not start the protocol development chronologically, but we will begin with the research question.
Okay, that is just an example, and this video is around 9 minutes. So for the interest of time, I will pause it, and probably if this will be approved by PSA, then you can open it again and watch the rest of the videos. So again, going back to the lectures, the examples are given based on the anesthesiologist's perspective, making it easy to understand. If you read journals or books regarding protocol development, they are usually in the perspective of medicine. So these are about patient who requires long follow-up, which is very different from our practice. The high-impact presentation creates interest among the viewers, and of course, the shorter duration of lectures is within the attention span of the participants. The shortest lecture is around 8 minutes, and the longest one is 24 minutes. So we have 2 lectures which exceeded the 20 minutes attention span. Okay, so this is the answer to the question, what if there is no internet? So the second opportunity for learning is the module reference guide. This is a step-by-step guide on how to go about the module in order to accomplish the module task. And it influenced the memory consolidation process because this is a second exposure and may transform short-term memory to long-term memory. So this can be printed or saved in the gadget, so your internet connection is not a problem. The third opportunity for learning is the post-course online or face-to-face discussion. So as I've mentioned earlier, the resident will present his output, and during the discussion, the consultant can suggest revisions. So this will provide an in-depth discussion of the module task. Now here are some of the residents' comments during the program. So one resident said, I belong to the type of students or residents who are not adept in writing my own research, but I was able to write. The expertise and talent on writing a research is not always present in every student or resident, hence the need for proper guidance and instruction of their superiors. So here, the consultant's role is being emphasized. Okay, here's another, and perhaps this comment was during the sample size computation. The resident struggled because he was not able to appreciate the computation. So meaning, he found it difficult to compute for the sample size. But this was not a barrier because he said he just needed time to learn the math. So this means that the residents are motivated to find out the solution to any problem that they will encounter. And the best part is they do not give up. When I ask them if they think this will benefit other residents, they say yes, it's convenient, easier to consult because during the post-course discussion, their outputs are already checked and they can revise it immediately. Imagine if they finish the whole protocol and the research coordinator or consultant said that there's something wrong with your research question and research objectives. So this will be a major revision for the resident. And another comment is the FRP in the modules were helpful. And it saved time, it facilitated learning, and there's less physical efforts. There are 3 phases in the FRP. These are the pre-implementation phase. This is where we prepare. The implementation phase, or the application or administration of the fast-track research program. And finally, the post-implementation phase, where expected output is seen. So for the pre-implementation phase or preparation, we prepare for the research curriculum. And then we upload the modules and the courses in the Canvas Learning Management System and also upload the reference guide. In the implementation phase, wherein we administer the fast-track research program, there is the enrollment of the students, general orientation, and the implementation of the courses, modules, and lectures. In the post-implementation phase, we have the expected output. So the first one is the research protocol submission, and then the assessment of the program. Now, the question is, how do we avail of this program? So we recommend it to PSA, and I hope that Dr. Simon is here or will look at this and make it available for our residents and consultants. thank you for your kind attention.
Okay, before we start our open forum, I would just like to announce that the fellowship night is tonight at 7 p.m. and not on May 27. So again, the fellowship night is tonight at 7 p.m. So the floor is now open for you to ask questions. Kindly direct yourselves to the mic if you have questions, and then we're going to entertain our questions that are in our virtual format also. To start off, this morning's session focused heavily on residents' mental health and how the briefing can, promote our residents' well-being, how research can be fast-tracked for them. So first, there's a very interesting question for Dr. Lee Uson. Before residents enter anesthesia training, a psychiatric exam is being conducted. And some of these doctors or applicants have history of depression, anxiety, or poor coping mechanisms. Do you think this should be a deterrent for them to enter this specialty?
First off, good morning to all the members of the Philippine Society of Anesthesiologists. Thank you, Dr. Manalang, for that question. I think that's a very valid question, especially for the admitting committee of the department. No? We emphasized earlier the importance of not discriminating against those who have mental illnesses. But of course, since performance is something that we have to monitor while in training, it's very important to determine whether the patient is actively, the trainee, the applicant, is actively experiencing symptoms, and is he or she or they seeking help. Because if they are undergoing therapy, then you maximize the chance of the trainee or the applicant in performing very well. In fact, there are reports of those, testimonies of those who have mental health problems, who are one of the top-notchers, no, even in their field. So this is something they shouldn't be discriminated about. But as we know, because of the stigma, sometimes they don't undergo therapy. So it will be an opportune moment also for you, if you think that the applicant is experiencing symptoms, to ask them to seek help. And that way you can really consider if you would want, given the other parameters that you check upon admission, because I don't think it's just the mental health status that you check. No? Past history does not mean that the individual is not able to function and perform optimally. I hope that answers the question, Dr. Manalang.
Okay. And in terms of debriefing, considering that residents are decked consecutive cases within the day, when is the best time to do the debriefing following a critical event? I think this is for Dr. Catalan.
Good morning. Sorry. Good morning, everyone, and thank you, Angel, for the question. No, as I mentioned earlier, it's called hot debrief because it has to be proximal or immediately after the critical event when the memory is still fresh, although probably the emotions are still heightened, but it's very important to do it right away. I think for the mentors and for the trainers, it would be easy to set aside 15 minutes to 20 minutes of the time, or for the whole group to come together and do a debrief. No? And it is something that we need to be mindful of. We really have to change the system and change the structure in how we work. But I think the yield in terms of improving patient safety and provider safety is there. So it's a big effort, but it is not something that we cannot do, and it is something that we should start working on, I guess. So immediately after, that's the ideal time.
Thank you, Ma'am Grace. And for Dr. Nieto, since PACU is under the jurisdiction of the anesthesia department, how can we as anesthesiologists help our PACU nurses and younger residents take a more proactive role in the handover process when they still need more experience in the field?
Actually, that's a good question. Thank you for that. We can be the leaders of patient safety because it is in our realm that we handle the patients pre-op and post-op. So, of course, we need organizational support to do the handover tool so that even the nurses can learn it. And I urge you as anesthesiologists to be active in the safety committees of the hospital. Actually, the handover tool is recognized by all the standards, JCI, ACI, and even PhilHealth Benchbook as a must for all hospitals to start doing, because it's widely known. As I mentioned in my lecture, it's been around for a long time that they know that communication tools are a must. So it's included in all the safety standards that are required nowadays. So it's important as anesthesiologists to spearhead the movement towards safety. Thank you.
Thank you, Doctor. For Dr. Mariano, we all know that during training, research is one of the biggest stressors in anesthesia training. So this fast-track research program, how can, or has this helped those residents enrolled in the program, have a faster output experience, or have a better experience with research in general?
Okay, actually, as I've mentioned, that writing the protocol is one of the most difficult and challenging aspect of research engagement for the residents. So I think because we provide here a post-course discussion wherein the residents' output will be immediately corrected and revised, and then once this is corrected and revised, he can go to the next course. So because the research protocol, the main foundation of this lies on the research question and the research objectives. If you get this right, you can have already a smooth transition up to the completion. But if you submit your protocol complete, if you submit a complete protocol, and then the consultant will tell you, oh, your research objectives are not correct, and then what you need to do is to revise, to do a major revision. Imagine the time that have been spent in making the previous protocol, and then you have to make another. So if research is a stress, revising the protocol, having a major revision is also an added stress. So here, in this program, this is not only a one-way program wherein the residents will attend the workshop and then he is on his own. We have also a part for the consultants to check the residents' output so that he can transition to the next course. So this is the reason why the training should be for both consultants and the residents, so that the consultants also can correct, because when I did this program, I was the only one. So there were only a handful of residents, like 12, but if we will use this nationwide, I will not be able to correct all the outputs of the residents. So this is why the consultants should be trained so that they can correct their output. So siguro the next question is the consultants are not trained also. So how can they correct the output? And if they correct the output, how sure are they that they're doing it correct? So I thought of this. So this is an addition to the program kasi I just thought it last night. So maybe during the post-course, before the post-course discussion, we will have a nationwide Zoom meeting wherein 5 outputs of residents will be corrected, will be presented and corrected by the consultant. Siguro by the team which Dr. Eman will organize so that the other consultant from the different hospital will know how to correct the residents' output. So that's all. Thank you.
Thank you. There is a question in our virtual chat box regarding an emerging field in medicine called medical improvisation, wherein the principles and techniques of improvisational theater are used to improve active listening, empathy, teamwork, adaptability, and resiliency in the field of medicine. So the question is medical improv something that we can adapt in our training program to help promote our residents' mental health, and are there local groups already practicing this? For Dr. Lee Uson.
Thank you again for that question. No? Medical improv actually is the short term for medical improvisation. I haven't come across any local group or institution that is already doing that, but currently it's being studied well. In fact, training sessions are also being run in the US, particularly I think University of Washington. It's very similar to what we do in psychiatry, which is called role playing. So it's like it's also similar to simulation-based learning, where you mimic what had happened during the incident and you try to get inputs from different people. And from here, there are other skills involved that is also being taught, no? Which is why communication, empathy, listening, all in a teamwork kind of approach. So I think it is for your training members in your training group, the ones who develop the curriculum, to review that, because I think it is a good idea to incorporate, just like there are other training and teaching methods also that can be used. Incidentally, for example, in the Department of Obstetrics and Gynecology, currently POGS is looking at how they're going to incorporate mental health in their curriculum in the way that they are teaching OB-gynecology to trainees. So perhaps it's also a call to anesthesia to do the same, especially since your specialization is really considered to be high stress, no, in terms of the stress levels also. So I think it would benefit. And you could explore different learning strategies, not only this one, because this one I think you'll have to get training from the US for it. But certainly a lot of system-based learning can come in to help the program. Thank you.
Thank you. Thank you, Doctor. And because of our limited time, we can only accommodate 2 more questions. So just a follow-up question, Dr. Lee Uson, are there ways to reprimand or discipline residents who are already tagged as red flag to have mental issues?
Okay. I think the approach to our trainees, especially if they are already in your program, is not necessarily to reprimand, but more of to understand where they are coming from. So as it is, they are already suffering or experiencing very difficult, debilitating symptoms. What we can do is really to reach out to them and find out how we can help, especially if we think that they are already experiencing psychological distress and yet they are not seeking therapy. That is where we come in, because we can extend and reach out to them and encourage them to seek help. So we want to encourage this culture of accepting that mental health is part of our well-being. It is important. We are not superhumans as doctors. So anyone can actually experience bouts of depression, perhaps related to other reasons. But in this case, our trainees could be experiencing it because of work-related stress. So not reprimand and discipline, but rather try to see how we can help them cope. We know that services are important, and so their performance and even their learning and training is important. So how, let's say, the mentors or the supervisors can guide them so that they can perform and function better in the workplace. They are still part of the workforce. We need to take care of our workforce as well, because if they are functioning optimally, then we know we are giving the best kind of care to our patients also. Okay, thank you.
Thank you, Doctor. So in light of that, mortality and morbidities are always, one of the reasons why our residents quit, especially during this time of the pandemic. So are mortality and morbidity conferences valid and effective debriefing instruments as far as achieving goals for debriefing? Dr. Ma'am Grace.
In general, debriefing is another modality. I think we have to keep morbidity and mortality conferences because the focus really is on the medical expertise part. When we talk about debriefing, we touch more on the non-technical skills of our trainees or the practitioners. We talk about communication, we talk about a lot of behavior. So they work hand in hand together. And if I may, just to partially answer the previous question, we have simulation programs being put forward now in our curriculum, so that will help siguro to augment or just to supplement what you call yung medical improv na we are looking at. So that's one. And second, I forgot. Ano na yung sumunod na isang question, Angel? Sorry, I forgot. Yeah.
If
yes, debriefing. So debriefing should be carried out separately talaga from the morbidity and mortality conference, and I think it will help. It helps vent out a lot of issues that are not taken up in a formal MMM or morbidity and mortality conference. Thank you.
Thank you, Ma'am Grace. And so before we end this open forum, may I invite our speakers if they have more to say regarding their lectures. As a last words from our speakers.
Okay, I would like to thank the PSA for allowing me to share my program, and of course I'd like to thank also the people who are very enthusiastic in helping me with this program. So I hope that with this program, our residents will be able to complete a protocol, and then they can proceed to the next step of data collection, and then statistical analysis, and then writing the protocol. Okay, so the research protocol is not the only part of research engagement. So we intend to follow this up with other learnings on the different aspects of research engagement. Thank you very much.
I guess as parting words, I would like to stress how anesthesiologists are now at the forefront of safety and perioperative medicine. We must no longer work as islands, and we must really reach out to our colleagues in the nursing division and also the surgical division to make sure that our patients are well taken care of beyond the operating room. Thank you.
Thank you. Of course, I'd just like to address that many of us, we belong to a different generation. Of course, the younger trainees now, they are also of another generation. But instead of dividing that gap, no, we want to bridge that gap by really understanding And it goes both ways. It's important that they understand those who are of an older generation, and we understand those who are of a younger generation. And together, hopefully, we could work together and really build a safe, a psychologically safe, nurturing, and compassionate training environment in your workplace. Thank you.
Thank you. Thank you, everyone. We encourage you to ask questions via the Q&A chat box. Thank you.
Okay, so we have a few announcements. There is a correction. So our fellowship night is tonight at 7 p.m. On our ID, it says May 27. So just a reminder to everybody present here in the ballroom that the fellowship night is tonight, May 26 at 7 p.m. And if I may ask Dr. Beltran, please to stand here in front. Okay. Sige lang, sir. Yes, sir. Yung model lang tayo. Can you, you can actually avail of having this very beautiful barong made for you, no? Sir, can you turn around? Turn around. Ayan. Ayan. So, it's 5.5 plus 200 pesos for shipping daw. So, you can have your measurements taken in the host chapter booth in the exhibitions area. They will be here from 8 o'clock to 3 p.m. For both days po. So, it's a very nice barong. Okay? Thank you, sir. And if you want to see the female, Doktora, come po. Magmo-model lang, sandali. Yes, okay na po yan. So, this is the beautiful female barong. Can you turn around, Doktora? Ayan. Thank you. So, it's also 5.5 for females. Yes po. Sige. Thank you very much, Doktora. Okay. So, for our next program, part of our program, so we will have a sponsored lunch symposium care of BioLite. So, you can actually start getting your food. It's already open. The buffet is now open. So, to start this session, may we call on Dr. Jessie Jane Paco. No, she's the chairman for Pain Management Center for Lanang Premier Doctors Hospital, Inc. She took her clinical fellowship in pain medicine at the St. Luke's Medical Center Global City and presently heads the section of pain medicine for the Department of Anesthesiology for the Southern Philippines Medical Center and the Davao Regional Medical Center. So, ladies and gentlemen, let us all welcome Dr. Paco.
Hi, good afternoon. While having your sumptuous lunch, let us listen to our next speaker, who is a Chief Medical Specialist of Guangdong BioLite Meditech Company Limited, and he is also a science and biology teacher at Citizen Education, and at the same time, he is a cardiovascular specialist at Southwest Medical University, and our speaker had his internal medicine cardiovascular disease residency program at Southwest Medical University last 2019. So let us welcome Dr. Muhammad Sakib Mudabar as our speaker for today.
Thank you for your interest in BioLite. My name is Dr. Sakib, and today I'm going to be introducing a couple of parameters that are useful for anesthesia monitoring. So we are going to talk about RSO2, NMT, BIS, and a clinical assistive application known as balance of anesthesia view. So let's first talk about RSO2. We first need to take a look at what does regional oxygen saturation refer to. So we know regional means that it is specific to a localized area such as the brain, the kidneys, the limbs, the abdomen, and the chest, etc. Oxygen is what we are looking for, and saturation is the concentration of oxygen that we are in this case trying to measure. This device is most commonly used to monitor the oxygen of the brain, hence its nickname, cerebral oxygen. So let's take a look at how to use this device. First of all, we need to find a subject with a brain. Alright, here we have a subject with a brain, I suppose. So let's measure the subject's cerebral oxygen saturation. So step 1 is to choose the correct sized sensor. So let's pick 2 adult sensors and paste them onto the subject's forehead. Step 2 is to connect the cables. Now when we do that, we need to keep track of these numbers. We need to know where is lead 1 or lead 2 attached, and I'll tell you why in just a moment. Step 3 is to connect the cables to the patient monitor. Now this is a screenshot of the central monitoring system, which is quite similar to what it would look like on the patient monitor. You can see this is what RSO2 would look like. Now let's zoom in to take a closer look. Now remember, we talked about the numbers 1 and 2. Well, here they are. Here you can see they correspond to the leads. And you can see it says left forehead next to 1 and right forehead next to 2. Well, you don't have to remember that. If you click on RSO2 and go to the Settings tab, you'll be able to change the labels based on how you connected the sensors and where. As you can see, there is a list of areas to choose from. So wherever you place the sensor 1 is where you are going to choose here. The same goes for the other sensor. Let me show you the Alarms tab. This is where you set the baseline RSO2 value. The way to determine the baseline is that you would attach the RSO2 sensor to the subject's region that you would like to monitor while they are clinically stable and observe for about 200 seconds. The lowest value that you observe while the patient is clinically normal is the value that you set as the baseline. The normal range for RSO2 is around 58 to 86%. Here we can select several different parameters that we prefer. BL is our baseline that we just mentioned. Delta baseline is the difference of the current monitored RSO2 value from the baseline. AUC is area under the curve, which is basically the percentage of the time in minutes that the RSO2 reading remains below the set baseline for the duration of the session. Delta SpO2 is the difference between RSO2 and SpO2, and AVG is the average RSO2 value. As we can see here, that the RSO2 on the left is higher than the right. This is perfectly normal. Now let's take a look at the RSO2 value, which is 80, and add the value of delta SpO2, which here is 19. And we should be able to get the SpO2, which would be 99. It's important to note that this delta SpO2 value only displays if SpO2 is available. Same goes for the other side. Alright, now let's understand why the RSO2 values are lower than SpO2. Let's take a look at this capillary supplying oxygen and nutrients to this tissue. If we measure the oxygen saturation within the capillary and here within the tissues, we would observe that the concentration of oxygen in the tissues further away from the capillary is lower, whereas the oxygen saturation in the capillary itself is close to 100%. Let's take a look at this picture as an example. If you measure the amount of water in the pipeline here or here, the concentration of water might be close to 100. Whereas if we measure it over here, then the concentration of water would be lower, as there are many other things here, such as the soil, the plants, the air. This is why when we connect the probes to the forehead of a subject, we are monitoring the oxygen saturation of the brain tissue. The image shows how Masimo O3 technology is able to monitor oxygen saturation not only at the surface level, but also within the deep tissues. This technology uses 4 wavelengths of near-infrared light, 2 of which penetrate the deep tissue, while the other 2 penetrate the superficial tissue, providing with a stable and accurate reading of the oxygen saturation of the tissues. So, RSO2 is available on the BioLite P-Series patient monitor. This is what the module and the accessories look like. Now let's take a closer look at the clinical applications of RSO2. RSO2 provides information regarding regional tissue perfusion depending upon the site of the probe. It does this non-invasively, directly and continuously, and measures the regional tissue hemoglobin oxygen saturations in the veins, the RSO2 value, to indicate the adequacy of the balance between regional tissue oxygen delivery and extraction. Its interpretation is analogous to the systemic venous saturations, SVO2, indicating the balance between oxygen delivery and extraction, only more reflective of the local tissue balance. The RSO2 reflects the amount of hemoglobin still saturated after passing through the local tissue bed. A 2-probe technique with 1 cerebral probe and 1 renal probe can be routinely used to continually assess the regional venous saturations of both the brain and below the diaphragm. This not only provides an indication of the adequacy of total cardiac output, but also the simultaneous adequacy of local perfusion to these areas. In a normal physiological state, the cerebral saturations are lower than the systemic venous saturations, whereas the renal saturations are higher. This is reflective of the combination of both a higher cardiac output delivered to the renal bed and lower oxygen extraction by the kidneys compared to the brain. When the venous return from the upper body, the cerebral venous return, and lower body, the renal venous return, meet, they unite to form the systemic venous oxygen saturation. Ideally, the RSO2 should be connected pre-operatively when the patient is awake, well and stable. This allows for a baseline RSO2 value to be set, which is the patient's own control. Subsequent RSO2 value changes from baseline during an operative procedure that can be measured from the initial values when the patient is awake and well. If RSO2 is connected, for example, after cardiac surgery, a baseline value should still be taken, as it allows an immediate appreciation as to how therapy has influenced regional tissue oxygenation. The skin where the probe is attached with should be inspected every 6 hours by gently peeling back the sensor to show the full area under the probe. Whilst its use should be at the discretion of the doctor, 4 cohorts of patients that merit specific consideration are suggested. Infants less than 6 months of age with either low cardiac output state or potential for it to develop, for example post-cardiopulmonary bypass cases, coarctation repair, etc., or cyanotic congenital heart disease patients who are dependent upon a balanced circulation. Any patient with cardiomyopathy or myocarditis. Any patient supported on ECLS, extracorporeal life support, and patients with trauma or sepsis. So what are the acceptable parameters? Acyanotic circulation, arterial stat should be above 95%, SVO2 should be above 65%, cerebral RSO2 should be above 55%, and renal RSO2 should be above 65%. Cyanotic circulation. These patients are more at risk of ischemia and hypoxia because of the reduced oxygen supply capabilities. Arterial stat should be above 75%, SVO2 should be above 50%, cerebral RSO2 should be above 45%, and renal RSO2 should be above 55%. A cerebral RSO2 less than 40% is associated with neurological morbidity. A 20% fall in an RSO2 value is significant, and the patient should be assessed carefully. The trend of all these markers is the most important part of the data. So let's take a look at a quick guide. If the RSO2 values are worrying, check arterial and patient mixed venous blood gases and inform a senior clinician. Check the monitor for any sensor-related alarms. The trend is more significant than the actual value. High values may indicate dead tissue. Absolute cerebral RSO2 less than 40% may mean significant neurological ischemia or hypoxia and may be associated with a poor neurological outcome. Seek senior medical advice immediately. The trend in value is more significant than the actual number. RSO2 probes are placed onto the skin. Near-infrared light is emitted from one end of the probe and passes through the superficial tissues, where it is either scattered or absorbed. The amount of absorption correlates to the degree of saturation of hemoglobin. The detector in the skin probe senses the light that has not been absorbed, measured as relative deoxyhemoglobin, and converts this data into a number that indicates the regional venous saturations. The percentage of RSO2 is also called NIRS value. A poor cardiac output may reduce the delivery of oxygenated blood to the tissue to a critical level sufficient enough to threaten cellular metabolism and risk cell death. The cells of the tissue will extract as much oxygen as needed to stay alive. But if its availability is so poor because blood flow is so marginal, the reserve contained within the venous blood will become increasingly depleted relative to the inadequacy of the supply. The more marginal the oxygen delivery, the lower the residual oxygenation of the venous blood. Cellular metabolism is augmented such that oxygen demand exceeds supply. Let's take a look at a few clinical scenarios. So if both cerebral RSO2 and renal RSO2 decrease, that would mean that global oxygen delivery has fallen, or there is a global increase in oxygen consumption. We can confirm this with paired arterial and venous blood gas analysis. If increased oxygen consumption is suspected, treat by analgesia, sedation, cooling, and paralysis. If decreased oxygen delivery is suspected, Treat by red cell transfusion. Consider whether the arterial blood is optimally saturated. Take care in patients with parallel circulations, as the ventilation changes may adversely upset the balance. Recruitment maneuvers. Increase positive end expiratory pressure, increase positive inspiratory pressure, and increase the fraction of inspiratory oxygen. Augmentation with inotropes and or manipulation with vasoactive agents of the cardiac output. If the patient is on extracorporeal life support, then do the following. If the patient is on VA ECMO, that is venous to arterial ECMO, perform diagnostic oxygenator membrane checks, plus check optimal circulating blood flow. If the patient is on venous to venous ECMO, perform diagnostic oxygenator membrane checks, exclude evidence of recirculation, exclude evidence of right heart failure, and the need for inotropic support. If only the cerebral RSO2 has decreased, this could mean that the cranial blood supply cannot meet demand, which could increase the risk of neurological injury. Exclude thromboembolic events and intracranial hemorrhage. Consider the need for neurological imaging. If oxygen consumption is increased, you may suspect the patient is awake, is having seizures, or has hyperthermia. If oxygen delivery has decreased, it could be due to the decrease of PaCO2, which is a powerful cerebrovascular vasoconstrictor. Excessive ventilation, if on ECMO, consider reducing sweep gas flow or adding CO2 into the ECMO circuit. If on ECMO, check arterial cannula position. If only renal RSO2 has decreased, this could mean that the infradiaphragmatic blood supply cannot meet demand, which increases the risk of renal or gut ischemia infarction. It is to be noted that decreased renal RSO2 may reflect the presence of a PDA. The lower infradiaphragmatic arterial saturations are showing up as lower renal tissue saturations. If oxygen delivery has decreased, if on ECMO, check cannula position. Secondary to systemic vasoconstriction, vasopressin, noradrenaline, or secondary to physiological compensation to reduce cerebral blood flow. Renal RSO2 can potentially be used as a warning sign for acute kidney injury. Low renal RSO2 infers reduced infradiaphragmatic blood flow and the risk of developing necrotizing enterocolitis. But as the renal blood flow far exceeds GIT demand, the threshold fall in renal RSO2 that is strongly correlated with the development of NEC is unknown. So that's all about RSO2. Now let's take a look at NMT. So let's take a look at what NMT means. Neuro refers to the nerves in our body. Muscular refers to muscles. And transmission refers to the communication between the two. So when you decide to move a part of your body, let's say your arm, for example, your brain sends a signal that passes through the nerves of the spinal cord, all the way to the muscles in your arm. This signal, which is electrochemical in nature, travels through special types of neurons, known as motor neurons, and then arrives at the muscle, telling it to contract. And that's how you're able to control your arm. So what is an electrochemical signal? Well, let's take a look at it. This signal is electrical within the neuron. Neurons are typically very long cells, with some of them over a meter long. When the signal is transmitted from one end of the neuron to the other, it happens over charged particles, that travel within the neuron. Therefore, this signal is electrical in nature, and this electrical potential can be measured with a galvanometer. However, when the signal goes from one nerve cell to the other, it is chemical in nature. Neurons are not physically attached to each other as an electrical wire or cable. Neurons have a little space between them, which is known as synaptic cleft. The neuron that is transmitting the signal releases neurotransmitters that go through the synaptic cleft to the other neuron. Since this signal is purely chemical, it is hard to analyze it directly. Combined, this electrochemical signal has a name, and it is called neural impulse. Neural impulse is how we can tell if the brain is controlling the muscles or not. Now you must be thinking, why is this important? Well, it's because this is what we are trying to block with anesthesia during surgery. During anesthesia, we don't want the brain to be controlling the muscles. Otherwise, the patient might keep moving during the surgery, which would make it really difficult for us to operate on them, and also could lead to many accidents. Therefore, it is important that the patient remains still during the entirety of the procedure. Anesthesia is based upon 3 different kinds of medicines. One is for pain, so the surgery is comfortable for the patient. This is what we refer to as analgesia. One is for hypnosis, so that the patient sleeps through the surgery and has no memory of it. This is what we refer to as hypnosis. And one is for muscle relaxation, so that the patient doesn't move during the procedure. This is what we refer to as paralysis. So in order to monitor adequate anesthesia, we can use several different parameters, such as BIS or AG for hypnosis, PI for analgesia. You may refer to my videos on those topics or the balance of anesthesia view. However, in this video we are going to focus on NMT. So let's take a look at how to set it up. There are 2 electrodes, positive and negative. The negative electrode is connected over the ulnar nerve, whereas the positive electrode is connected proximally on the skin, but not over the ulnar nerve. And the gyroscope is placed onto the thumb and the other side on the index finger to keep it aligned. Now we need to choose a mode. BioLite P-Series patient monitor supports 7 different modes of NMT. The first one is train of 4, then we have double burst mode, post-tectonic count, tetanus, twitch, supramaximal current, and auto. But for the simplicity of this video, we are only going to focus on the most popular mode, which is train of 4. So this is what it looks like on the monitor. This is a train of 4 ratio. This is a timeline, the unit of which can be adjusted in the settings. This is a graph showing the percentage of movement of the thumb caused by the 4 twitches. If the thumb moves less than 4 times, this is what it looks like. And here you can see the TUF count. This is the electrical signal in milliamperes that we set. And this is approximately what is transmitted. This value is only for demonstration purposes. and its value needs to be determined by the physician attending the patient. Usually, the physician starts from a smaller value and slowly increases it until adequate response is observed. Now let's take a look at what those graphs and those values mean. In this diagram, you can see the distal end of the upper limb. This blue structure is the ulnar nerve that connects to the muscle, adductor pollicis brevis, which controls the adduction motion of the thumb. This is the negative electrode, which is placed directly over the ulnar nerve. And this is the positive electrode, which is placed proximal to the negative electrode, but not on the nerve. When the monitor's NMT mode is turned on, it sends an electrical signal, mimicking the electrical impulse, which in turn triggers the muscle, causing the thumb to adduct. Adduction of the thumb means that it moves towards the index finger. During anesthesia for relaxation, anesthesiologists give neuromuscular blockade. Now, in order to observe whether that drug is working or not, we can use NMT. So what is the TOF ratio and the TOF count? Basically, the monitor sends an electrical impulse every 0.5 seconds for 4 times every 15 seconds. This is called train of 4. The time interval between each train of 4 can be adjusted in the settings. The number of times the thumb moves as a result of TOF is called TOF count. And the TOF ratio shows how much the thumb moved. So remember the 4 TOF counts? Well, they are numbered from 1 to 4. T1, T2, T3, T4. We can calculate the TOF ratio by dividing the percentage of T4, which is the 4th twitch, with the first one. So for example, there's a patient who hasn't been administered neuromuscular blockade. This is what it would look like. Since the thumb moved all 4 times, the TOF count here would be 4. And since it moved 100% with T4 and T1, the ratio would be 1, and the percentage of TOF ratio would be 100. Now let's take an example of a patient who has been administered a non-depolarizing neuromuscular blockade a minute or 2 ago. Since the thumb still moved all 4 times, the TOF count here would be 4. And since it moved 27% with T4 and 100% with T1, the ratio would be 0.27. And the percentage of TOF ratio would be 27. Now let's look at the same patient after a couple of more minutes. The TOF count would be 3. Since the thumb only moved 3 times, and since it moved 0% with T4 and 70% with T1, the TOF ratio and percentage would both be 0. In the case of a patient administered with a depolarizing drug such as succinylcholine, the graph would look like this. This is adequate relaxation, even though the TOF count would be 4 and ratio would be 1. This is known as phase 1 blockade. However, in case of overdose, the graph would show a phase 2 blockade, which looks similar to adequate relaxation of a non-depolarizing drug. the TUF count would be lower than 4 and the ratio would be 0. This is not normal and can lead to several side effects of the drugs. Although depolarizing drugs are quite rarely used these days. So why do we need NMT monitoring? It helps us measure and manage the level of neuromuscular blockade. This can reduce chances of unnecessary side effects, avoid accidental early extubation, reduce the amount of residual neuromuscular blockade, reduce the amount of drugs used, saving medical costs, and ensure the efficacy of the drugs. It is primarily used intraoperatively by the anesthetist and in the ICU. So that's all about NMT. Now let's take a look at BIS. Bispectral index. How it works, what does it look like on the monitor, some of the parameters that it measures, and their clinical significance. So in order to understand what BIS is, let's take a look at the triage of anesthesia. Anesthesia can be classified into local and general anesthesia. The main purpose of local anesthesia is to eliminate or at least reduce the amount of pain during a procedure. Whereas the purpose of general anesthesia is not only to ensure a painless surgical procedure, but also to make sure that the patient remains unaware of the procedure and remains still throughout the procedure. These three goals, analgesia to prevent pain, relaxation to prevent movement, and hypnosis to prevent awareness or recall, are the foundations of general anesthesia and generally require several different kinds of anesthetic drugs to achieve adequate anesthesia. Today we are going to focus on the hypnosis part. But how can an anesthesiologist know the correct dosage of drugs to administer to the patient? Well, generally, the anesthesiologist can check the patient's height, weight, age, some other physical characteristics, and the type and duration of the procedure to determine the dose. But this approach is very subjective, and not all patients react to medications the same way. Objective monitoring of the state of mind can be really useful in determining the adequate dosage of hypnotic drugs. One way we could do that is with the help of electroencephalography, or in short EEG. For more information on that, please refer to my lesson on EEG. Although EEG is one way to determine the state of alertness of the brain, it still requires to read the waveforms and interpret them. Therefore, we can use the bispectral index, or BIS for short. Even though the EEG waveforms are really easy to read on the BioLight patient monitors. BIS is a numerical value that is inferred from the EEG and calculated by the patient monitor. The electrodes of BIS are simply attached to the patient's forehead, and that's it. BIS monitors the EEG of prefrontal cortex of the brain. Now let's take a closer look at BIS. As you can see here, these are the parameters that you would observe when using BIS. The bispectral index, the signal quality index, the electromyocardiogram, the suppression ratio, and the spectral edge frequency. In the following couple of minutes, I'm going to explain what these parameters mean and what they look like on a patient monitor. Alright, so let's start with BIS. Bispectral index, BIS, is used to monitor depth of anesthesia. A BIS value of 100 means the subject is fully awake. As the value decreases, the level of alertness decreases. A BIS value between 20 to 60 is considered hypnotized. However, anesthetics prefer to keep the BIS value between 40 and 60 as an indicator of an appropriate level for general anesthesia. The reason for this is to avoid getting too close to 20, below which burst suppression can occur. The BIS value thus gives the anesthetist an indication of how deep under anesthesia the patient is. BIS cannot be used as the sole monitor of anesthesia. Therefore, it comes with a single channel EEG built in, which is acquired from the prefrontal cortex. Looking at the BIS on BioLite P-Series patient monitor, we can see EEG waveform on the left and BIS value to the right of it. We can also see some other parameters to the right of the BIS. If we click on the waveforms, we would go into BIS settings, where we can see several different options to choose from. So if I choose Trend BIS, this is what it would look like. Trend of BIS can help us visualize change in anesthetic depth over time. Now if I choose Trend BIS and EMG, we would see the BIS trend as well as the EMG numerical value next to it. EMG value can help us assess whether the BIS value is accurate or not, as muscular activity of the forehead can disturb EEG signals that BIS monitors. Although the principle of EEG is similar to NMT, neuromuscular transmission, it is not an indication of adequacy of neuromuscular blockade, since the BIS electrodes are attached over muscles and not nerves. This means that the muscle can be directly triggered by the electrode, rather than going through the nerve, giving the false impression of inadequate neuromuscular blockade. This is a very important difference to understand, to prevent overdosing of patients with neuromuscular blockade. The lower the EMG during anesthesia, the better. Now let's choose Trend BIS and Signal Quality Index. Here we can see the Signal Quality Index next to BIS. The higher the better. It, just like EMG, refers to how accurate the BIS value is. Now let's choose Trend BIS and SR. Here we can see suppression ratio next to BIS. When the burst suppression is above 40%, the suppression ratio values show up on BIS. It is correlated to BIS between 0 to 20%, sometimes 30%. Suppression ratio value means hypnotic drug overdose and is extremely dangerous. Although sometimes burst suppression is induced intentionally for therapeutic purposes, to treat refractory status epilepticus or increased intracranial pressure, burst suppression is generally considered potentially harmful and to be avoided. Therefore, it's best to maintain BIS between 40 and 60. Suppression ratio can also indicate cerebral anoxia as a consequence of a previous cardiopulmonary arrest. Now let's choose Trend BIS and BC, which is burst count. Here we can see burst count, which is the number of times burst suppression occurs. The lower the better, unless intentionally induced. Here we can see a lot of other parameters. SEF is spectral edge frequency, which can be used to determine the depth of anesthesia. Its value refers to the highest frequency detected, regardless of the power of the frequency. An SCF of below 17 is generally considered being under anesthesia. However, SCF is not as precise as BIS and hardly shows the depth of anesthesia. TP refers to total power, and it's simply the combined power of all the frequencies observed. Now if we click on sensor check, we would be able to see which of the sensors are connected and working, or if they have high impedance, or if they are not connected very well resulting in noise, and if they are disconnected. And the Alarms tab lets you set an alarm for the BIS values. These are the numbers that appear to the left of the BIS value, as you can see here. Let me zoom in on them for you. So let's understand the relationship between BIS and EEG. As I explained earlier, bispectral index is based on EEG. Therefore, it needs to process about 15 seconds of EEG data in order to give a value, whereas the EEG that comes with BIS is displayed in real time. The EEG waveforms that are displayed with BIS are from the frontal and temporal lobes of either side, which depends on the placement of electrodes. So what are the clinical advantages of BIS? Well, BIS allows for adequate anesthesia by preventing both over and under sedation. In the clinic, this translates to preventing the following. You may pause the video to read at your own pace. So in this video, what we have learned is what BIS is, where is it used, what parameters can it monitor, and how to interpret them, and the clinical advantages of BIS. So that's all about BIS. Now if we had a software that would allow us to monitor all the anesthesia related parameters in one place and make them more intuitive, then that would be the balance of anesthesia view. Let's take a look at it. In order to understand what balance of anesthesia view is, we need to take a look at the basics of how anesthesia works. Anesthesia is one of the most underappreciated inventions of mankind. But if you think about it, waking up from a surgery without the memory or pain of surgery is a privilege that was not possible before modern anesthesiology. On October 16, 1846, Dr. William T.G. Morton and Dr. John Collins Warren at the Massachusetts General Hospital performed the world's first surgical procedure under anesthesia. Since that day, anesthesia technology has improved a lot, with modern high-tech equipment and research in anesthetics used. Modern anesthesia is not only extremely safe, it is a routine procedure all over the world. This credit goes to the extreme professionalism of anesthesiologists who keep you alive during the procedure to see you again after surgery. To ensure patient safety, anesthesiologists need to constantly monitor numerous parameters and keep them within the nominal ranges. Anesthesiologists are also some of the most overstressed health professionals, with long working hours and fewer holidays in most parts of the world, mainly due to a shortage of people in this profession. Now let's take a look at how anesthesia works. Anesthesia is mainly based on three different kinds of anesthetic drugs. One for hypnosis, that is to put the patient to sleep. One for analgesia, that is a painkiller. And one muscle relaxant, to keep the patient from moving during surgery. These three medications form the triage of anesthesia. In order to objectively monitor the efficacy of these medications, we can use several different parameters. For hypnosis, we can use bispectral monitoring, mean alveolar concentration of anesthetic agent, or electroencephalography. For paralysis, we can use neuromuscular transmission monitoring. And for analgesia, we can use perfusion index, available with SpO2 to ensure the drug's perfusion into the tissues. And there are some other drugs that require hemodynamic monitoring. Keeping this in mind, BioLite has introduced a brand new tool for anesthesiologists. This new tool helps anesthesiologists monitor all the parameters they need to, whether it be CVP, invasive blood pressure, or one of the parameters for the triage of anesthesia, or Aldrich score to help you decide whether the patient can be transferred out of the surgery room, all in one place. We call it balance of anesthesia view. This view assists you through the complete process of anesthesia, from induction to maintenance, all the way to recovery. Let's take a look at each of these views and what they can do for anesthesiologists. First is the induction view. This is at the beginning of anesthesia, when you have set all the alarms, the arterial lines are in place, CVP is in place, AG is set, infusion lines are set, ventilator is set, anesthesia machine is ready, regional oxygen saturation probes are attached, the patient is ready, and you are about to intubate the patient. Induction view allows you to select the parameters you need to see and put them in one window. At the bottom of the window, when you are intubating, you may use the timer, which allows you to intubate with confidence. It shows you the time elapsed since you started intubating the patient and alerts you if you spend too much time intubating, preventing apnea. This view is especially useful in patients with difficult airway that are hard to intubate. Next is the maintenance view. This view allows you to monitor all your favorite parameters, such as the heart rate, invasive blood pressure, neuromuscular transmission, mean alveolar concentration, etc., in both waveform and graphical manner. The parameters you see in the menu depends on the modules connected. The ones you see here are only for demonstration purposes. Show this to any anesthesiologist and they will tell you how much they love this feature. This allows for a focused approach of parameters that matter the most. Next is the recovery view, which, as the name suggests, is designed for patients who just finished the surgery and are getting ready to be taken out of the operation room. This view employs the Aldrich score, which is a score used to assess whether it is safe to remove the patient from the operation room or not. Generally, a score of 10 is considered to be safe, and below that, not. Balance of anesthesia view does not obstruct the view of all the other parameters that can be normally seen on the monitor. It just shows up to the left. So in this video we have learned the brief history of anesthesia and how the balance of anesthesia view helps anesthesiologists focus on relevant parameters. So these are the features you can get with the new BioLite P-Series patient monitor. I hope you enjoyed my presentation. Thank you for your attention and thank you for supporting BioLite.
Thank you, Dr. Muhammad Sakib Budawar, for the very extensive lecture. I think in the interest of time, we cannot entertain any more questions for now. So let's go to our next topics. I'll give the floor to Dr. Panuda.
Thank you, BioLite. Thank you, Dr. Paco. So we'll have a 5-minute break, then we can resume our sessions. Thank you. I hope everybody enjoyed the lunch, care of BioLife. A few reminders again. The fellowship night will happen tonight, May 26 instead of May 27 as written on your IDs. Okay, so also the exhibition area is open behind the plenary hall. If you have time, later there will be a 30-minute break. You may want to visit the booths from our dear sponsors. And to open our afternoon session, I'd like to call on our next moderator. He is the chairman for the Department of Anesthesiology of the Digos Doctors Hospital. Let's all welcome Dr. Giuseppe Panuda.
Good afternoon. Good afternoon, everyone. Are we ready for our next lecture? Or are we all sleepy from our lunch? Okay. So, our first speaker for this session is the head of anesthesia and deputy director of the Tibo Cure Hospital, Davao City. She is a 2001 recipient of the Jim Poulos Prize from the Anesthetic Department at Royal Devon and Exeter Hospital in England. She is also a 2007 recipient of the PASC Certificate of Honor for Service to Anesthesia in Developing Countries. Here to talk about safe anesthesia care in the low-resource settings, please welcome Dr. Sarah Hodges.
Good afternoon, everybody, or maybe I should say maayong hapon. Thank you very much for inviting me to speak today. It is definitely an honor and a privilege. My name is Sarah Hodges, and I'm a UK-trained anesthesiologist, but I've been working in Uganda and the surrounding countries in East Africa for about 18 years. And today my talk is entitled Safe Anesthesia in Low-Resource Settings. I kind of feel my talk is a little bit misplaced, just coming after that BioLite talk, which the sort of the high end of anesthesia, and now I'm going to talk about low-resource settings. But anyway, so I'm not entirely sure what you're expecting from this session. It's certainly not going to be a tutorial on how to anesthetize a child with a piece of string and a tin can, and neither will it be the do's and don'ts of draw-over anesthesia. Firstly, I just want to say that I have no disclosures whatsoever. Perhaps the only thing I need to say is that anesthesia in austere environments is a subject that is actually very, very close to my heart. And these are the objectives that I will really try and achieve this afternoon. So firstly, as an introduction, Uganda is a stunningly beautiful country. Unlike the Philippines, it is landlocked. It's situated in East Africa, but most of the country is on a plateau at about 1,000 meters, and it straddles the equator. The western border is formed by the snow-capped Ruwenzori Mountains, which you can see in that photo down the bottom there, and they're at a height of 5,109 meters. And the southern border of the country is delineated by Lake Victoria, which is the third biggest lake in the world. But before we go any further, I want to share a few important vital statistics to demonstrate some of the differences between Uganda and the Philippines. But as you can probably see, the biggest difference is the infant mortality rate and the number of anesthesiologists per 100,000 population. And just to put things in perspective, in the USA, they have 20.82 anesthesiologists per 100,000 population. So the Philippines is not far behind. And although you can have amazing monitoring from companies like BioLite, what we also know is that actual presence of the anesthesiologist is what ensures safe delivery of anesthesia. And it must be glaringly obvious to us all that the lack of qualified anesthesia providers has a huge impact on perioperative outcomes. I'd also like to go into a little bit more detail about that last line on the table. In 2005, I did a study in Uganda trying to determine how many hospitals had sufficient basic equipment to perform a safe general anesthetic for an adult, a child, and for a cesarean section. The requirements were extremely rudimentary, and they were developed using guidelines from the WFSA. The list for an adult general anesthetic consisted of a supply of oxygen, suction, tilting table, face masks, oropharyngeal airways, laryngoscope, endotracheal tubes, and pulse oximetry, and that was it. For pediatrics, it included correct size endotracheal tubes, pediatric laryngoscope, and small intravenous cannulae. For a safe cesarean section, the list was a little longer, as it included spinal needles, local anesthetic, magnesium sulfate, hydralazine, oxytocin or ergometrin, disinfectant to clean the skin, sterile gloves, and capability to give a blood transfusion and measure blood pressure. It was not rocket science, and yet only 23% of surveyed hospitals had everything to perform a safe GA on an adult, 13% for a child, and 6% for a C-section. And one of the main items that was actually missing was pulse oximetry. And it was out of this study that came the Lifebox initiative, which you may have heard of, which has made huge improvements to the distribution of pulse oximetry across the globe and hence enhance the safety of anesthesia. This slide demonstrates the high mortality rate, which reflects the lack of anesthesia providers in low middle-income countries. The study from Togo was an excellent study, incredibly well done. Unfortunately, the author got into big trouble with his government for publishing the study, but he did follow it up with another one showing that most of these deaths were preventable, and a number of very small improvements, like good quality handover from the anesthesia provider to the recovery, as was talked about earlier, could change these figures dramatically. Now, I hate to say this, but I am actually old enough to have used ether on a daily basis. And when I first came to Uganda, the only monitor was a finger on the pulse and a precordial stethoscope. I have worked for many years in low middle-income countries, and my energy, my enthusiasm, it ebbs and flows quite dramatically. As I realized while trying to deliver safe anesthesia in an austere environment, that however much I try to be involved in teaching or try to improve the quality of the monitoring, the funds to buy drugs, the standard of the operating theatre, the disparity between North and South continues to widen. And the reasons for this are so much greater than anything I can do, and many times they feel insurmountable. I'm going to try and attempt to illustrate some of these challenges by using the core indicators of the Lancet Commission. Now, it was 40 years ago that Dr. Mala, the then Director General of the United Nations, gave a speech where he said, and I quote, "The distribution of surgical resources in countries throughout the world must come under scrutiny in the same way as any other intellectual, scientific, technical, social, or economic commodity." And yet, the Lancet Commission for Global Surgery was not published in 2015. And that was when finally essential surgery and anesthesia were recognized as key components of universal health coverage. Surgical care has always been seen as expensive, complex, and a relative luxury. And although great gains have been made in combating global infectious diseases, in only 2010, 33%, that's a huge number, 33% of all deaths worldwide were lost from conditions needing surgical care. Now that figure well surpasses all the deaths from HIV, TB, and malaria combined. The Lancet Commission report was designed to address crucial gaps in knowledge, policy, and action in relation to development of surgical and anesthetic care in low middle income countries. And for that, I truly welcome it. We all know about the figures bandied around. There's 5 billion people who do not have access to safe and affordable surgical and anesthetic care, and 25% of people receiving surgery will incur catastrophic financial loss. But numbers, what do they actually mean in terms of real people? So to try and make these statistics real, I've divided the Lancet Commission core indicators into 4 headings. And I will try, using these headings, to describe to you the practice of anesthesia in a resource-constrained setting through real patients. As my practice is mainly pediatrics, the focus will be on children. So I'm going to start with access. And what do I mean by access? Is it distance from a hospital? Is it a usable road? It's many things. Access is not just about needing a homemade stretcher to get down the mountains. Our first location in Uganda was in the foothills of the Ruwenzori Mountains. And a village high in the hills would have what you called a stretcher tax. You paid that stretcher tax, and that ensured that when you were sick and you needed to be brought to hospital, you could be carried down in an emergency by 4 strong men, or maybe more. And many times we had a laboring woman with a cord prolapse who would arrive at the hospital, having been carried down the mountains, knees, down on her knees, head between her legs, bottom in the air, trying to avoid compression of the baby's head on the prolapse cord. And many times that baby would survive. Access is also about losing your one main road, becoming totally impassable every rainy season. But access is also about knowledge. This young girl, she fell out of a mango tree. This is a common occurrence in mango season, and she sustained a supracondylar fracture. And in most villages and towns, there are people called bone setters, and they're very, very popular, these bone setters. And she was taken to one of these bone setters by her parents. Her arm was wrapped up tightly, strapped to a piece of wood, and the parents told on no account to remove the bandage for at least 3 days, even if she cries out in extreme pain. As we can see from the photo, she developed a gangrenous forearm and needed an urgent amputation. She was septic when she was finally brought to our hospital. We were working in a very poorly equipped hospital, and her surgery took place under just some little intermittent ketamine. That's all we had. Access is also about access to knowledge and information, as well as physical access. Her parents obviously didn't know that the bone setter's treatment was going to be detrimental to her health. The next point is stuff and staff. Quite a broad point. This means a functional health unit and not just a building. This photo was taken in the Democratic Republic of Congo. A small church-run hospital had invited my husband and I to come and do some surgeries for them. They had nothing. Well, actually, they'd just painted the room ready for our arrival because they were so excited. The operating light was 4 low-energy bulbs, and the operating table was an examination couch. And there was nothing else except 4 brown ampules looking all exactly the same, but containing 4 different drugs: frusemide, diazepam, chlorpromazine, and atropine. I'm not a magician. I'm really not sure what I could have done with that. Some basic facilities like running water and constant electricity are also essential for running an operating theatre. And of course, the people we always forget, the biomeds. We need qualified staff to do the maintenance work. And many, many times, these basic support services are just lacking. I was speaking to a colleague the other day who works in a city. He's about 4 hours from the capital, Kampala, and he's a fully trained surgeon, but he hasn't been able to operate for days now due to a lack of linen. If you have no dryer and it's the rainy season, the linen and scrubs don't dry in time, and you have no linen and scrubs. Stuff is also about the right stuff. It's about equipping hospitals with the correct equipment. There was a large consignment of GE anesthetic machines distributed around the country. I'm sure there was a bit of a backhander to it too, but many ended up like this one, shoved in a corner with a cover, as the hospital only had oxygen concentrators and no supply of compressed gases. So these machines were absolutely useless. Supplies are beginning to improve in the big cities. But in the rural areas, most equipment must be washed and reused and reused and reused. Stuff and staff is also about being trained, about being present, and about being motivated. This is Carolyn. There's a common belief that when your teeth are coming, your newly erupted teeth are coming, and often children develop diarrhea, that diarrhea will be treated if you remove the teeth with a little piece of wire. And this was what happened to Carolyn. Her grandmother removed her teeth with a piece of wire as a cure for her diarrhea. But when she arrived at the hospital, there were no doctors, no antibiotics, and she received no treatment. So the infection spread and demolished half of her face. This is Carolyn partway through her reconstructive process. Because staff are not paid adequately, because staff are not motivated, they are just not necessarily there when patients arrive in the hospital. Now, lastly, let's look at economics and affordability. I've tried to convert Uganda shillings into pesos to give some indication. These are a nurse's salary, school fees, because education is not free, the cost of a cesarean section up country, the cost of a surgeon's fee alone for a tibial plateau fracture in city, and ICU in the city. And labourers, of course, will learn even less. And when there's such a discrepancy between earnings and the actual cost of healthcare, then many people do not access the required treatment, and the rate of disability increases. And this is illustrated here by Helen. Helen initially had bilateral hemiepiphysiodesis for G. nuvaris. But her parents never brought her back for removal of the plates because they couldn't afford the transport costs. So now her disability is even greater, and she's going to require multiple surgeries for this to be rectified. This is something that would be done generally under spinal anesthesia, even in very young children. Last but not least, we have post-operative mortality rate. And this relates to the quality of care. This poor boy arrived septic, dehydrated, scrawny, and malnourished. And this undoubtedly increased his morbidity and mortality. But when there are no national or local measures to check on outcomes, there becomes a fatal acceptance when a patient dies, and people say, it was his time. If a hospital has poor outcomes, then patients vote with their feet and stop coming. Yet the need for functional healthcare units is huge. In many countries, there are no national guidelines, no DOH inspections. In 2018, I had a break from working in Uganda, and I went to the UK and worked there for 4 months. And I really enjoyed my time there, because I worked with a team of people with different strengths, different skills, and where we had regular audit meetings to assess our practice, and where we were continuously aspiring for excellence. It is very difficult to aspire for excellence when you work alone, or the hospital administrator chooses not to replace your oxygen cylinder, or there is a stock out of opiates. The Association of Anesthesiologists of Uganda have a WhatsApp group which is reasonably active. And a colleague of mine working in a hospital about 2 hours from Kampala was desperately asking for an ICU bed for a 19-month-old child post-cardiac arrest. Her regional hospital has no ICU beds, and the 2 hospitals with ICUs are both 2 hours away and were both full. How do you aspire to good quality care in such situations? You saw the statistics at the beginning of the talk about the numbers of anesthesiologists, but in fact in Uganda, most anesthesia is given by nurses or clinical officers who work alone with minimal resources and little opportunity for CPD. In 1992, when I first went to Uganda, we were 5 anesthesiologists in the whole country. Since the publication of the Lancet Commission, surgical capacity is beginning to improve, fortunately, in low middle-income countries. But the people who make resource decisions don't always understand the essential role of anesthesia in the provision of surgical care. The development of anesthesia has been given a lower priority than the development of surgery, but you cannot have surgery without anesthesia. The two are married. Access to safe anesthesia is often the limiting factor in providing safe surgery. The consequences of this are that in some parts of sub-Saharan Africa, people are 1,000 times more likely to die of complications related to anesthesia because of a lack of the essentials for safe anesthesia, like adequate workforce, proper equipment, and appropriate medicine. And most of these deaths are preventable. I personally think that the most fundamental problem is a lack of trained providers. Anesthesiology is complex and hazardous. The anesthesiologist oversees care of the patient before, during, and after surgery. And as that key word on the South Mindanao chapter says, vigilance. It's vigilance from the anesthesia provider. And if that person is not available or not even properly trained, then outcomes from surgery will be substandard and fatal at worst. It truly breaks my heart that a huge percentage of our world cannot access what most of us take for granted. It is as though surgery has become a luxury rather than a human right. Yet, the World Bank have reported that for every dollar invested in anesthesia, you get $10 back in productivity. That is why it is so important for us to be active in this. We who have voices need to to make a much louder noise around this, to improve the safety and the quality of care we all as professionals aspire to give for our patients throughout the world. Thank you for taking time for listening, and I'll be happy to take questions at the end. Thank you.
Thank you, Dr. Hodges. Okay, for our next speaker, she is the current chairman of Pain Management Center, Lanang Premier Doctors Hospital. She is also the section head of pain medicine in the Department of Anesthesiology, Southern Philippines Medical Center, and Davao Regional Medical Center. She had her clinical fellowship in pain medicine at St. Luke's Medical Center, Global City. Here to talk about acute pain management in trauma, please welcome Dr. Jessie Jane Paco.
Hi, good afternoon. Let's talk about acute pain management in trauma patients. The current definition of pain by the International Association for the Study of Pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. Majority of trauma victims experience pain, and pain represents the most frequent cause for patient admission to the emergency departments. So let's discuss briefly the acute pain management in trauma patients. This includes the epidemiology of acute pain, the importance of managing it, the physiology of acute pain, and let's also review the management guidelines on acute pain in trauma patients. That includes the assessment of pain in trauma patients, the available pain therapies, analgesic management for painful procedures outside the OR, perioperative analgesia undergoing surgery, and the acute pain management in the ICU for critically ill patients. There was a study done by Mura and Company, which is a 4-week prospective observational study which was carried out on 2,838 patients who visited a second-level urban emergency department. So there was a pain prevalence of 70.7%, and that 40.44% of which was caused by traumatic events. Another study was done by Payne's Coscape and Company that showed that out of 450 patients, trauma patients, that is 91% reported pain on admission, and that 86% reported pain on discharge, and 2/3 of which reported moderate to severe pain. The majority of trauma patients experience pain, and that the acute pain can impact respiratory function, increased metabolic demand, wound healing is being impaired, they suppress the immunity and reduce mobility. The inadequate acute pain management after trauma delays return to work. It lowers the quality of life, and it increases the post-traumatic stress disorder risk. Poorly managed acute pain also increases the risk of chronic pain development. Let's discuss the physiology of pain. Pain begins with the activation of nociceptors. So in transduction, messages initiated by the nociceptors are propagated proximally in the nerve cell to the spinal cord, where they synapse with the second-order pain neurons. So these neurons transmit the message through the well-defined pathways to the brainstem and ultimately the cortex. The modulation of the signal occurs through a second pathway extending from the cortex downwards the spinal cord. So perception now is the integration of modulated pain signal and multiple other sensory and cognitive outputs into the individual's active awareness. a given stimulus can produce an exaggerated or diminished response based on the context. The patient-reported self-efficacy is still the better predictor of satisfaction with pain management. So for us to assess the pain levels of trauma patients, we use the unidimensional scales. The tools that we use for the pain assessment must be interpreted contextually during the patient-provider interactions. So we have to avoid changing tools used for assessment. For all patients, the goal of pain management is a tolerable pain level that allows the patient to function and not zero pain, okay? So in the interest of time, I'm going to enumerate the different pain assessment tools. So for the cognitively intact adults, we have the numerical rating scale, or the NRS, which is an 11-point patient-reported metric that scores the current pain level on a scale from 0 to 10. 0, no pain at all, 10 being the worst. And the other one is the visual analog scale, or the VAS, wherein the patient marks their pain level on a 10-centimeter line with no pain written on the left side and the worst possible pain on the right side. For the adults with cognitive impairment, we use the behavioral pain scale, or the BPS, which is a 3-domain tool with 4 scores in each domain, with possible score of 3 to 12. If the score is more than 6, it tells us that the level of pain is unacceptable. So this is objectively scored at the bedside, okay? So we also use this BPS, or behavioral pain scale, for the sedated, mechanically ventilated, and critically ill patients. We also have the critical care pain observation tool, or the CPOT, which is a 4-domain tool that includes the facial expressions, body movements, ventilator compliance or vocalization, the passive muscle tension. So with this, you have to get the baseline values first. So observe the patient at rest for 1 minute, and then you get the pain assessment during any procedure known to cause discomfort or pain, such as turning the patient side to side or dressing, wound dressing. And you have to note the changes from the baseline values. So the patient is attributed the highest score for each domain during both periods. So the possible score range is 0 to 8, and 8 indicating the worst kind of pain. So we also have the functional pain assessment tools, clinically aligned pain assessment, or the CAPA, which provides the framework of conversation between the patient and the provider. So this focuses on pain intensity, the effect of pain on function and sleep, the efficacy of the treatment being given to the patient, and the progress towards relief. The functional pain assessment tool, or the functional pain scale, the FPS, is used in assessing pain in older population with comorbidities like dementia and delirium. So the functional pain scale has 3 domains of inquiry. If the pain is present or not, then rate the pain if it is present, and rate if the pain interferes with the daily activities. So for the pain assessment also used in the older adults, the hierarchical approach includes the assessment of the pain using the unidimensional or functional pain scales for those who are cognitively intact. And for patients with severe dementia, use the PAIN-AD, functional pain scale, DOLO +2. And for the nonverbal patients who cannot self-report, you use the CPOT or the BPS, and look also for the behaviors such as guarding, grimacing, and also you need to seek the input from the families, the caregivers, or the bedside nurses of the patients. So the pain ad or the pain assessment in advanced dementia is scored from 0 to 10. It has 5 domains for evaluation, and this is more reliable in hospitalized geriatric patients with dementia. So this is an example of the pain ad. So the Dolo Class 2 is used for adults who are cognitively impaired. It has 3 domains: the somatic, the psychomotor, and the psychosocial. This is the example of the Dolo Class 2 scale. So pain reassessment is very important in every aspect of pain management. So a hospital must have defined criteria to screen, assess, and reassess the pain of the patient that are consistent with the patient's age, condition, and ability to understand, as being advocated by the Joint Commission International Standards. So a trauma center must reflect the standards to include the interval in which a patient is assessed and reassessed for pain. If the patients are to be awakened for pain assessment and after pain intervention is completed. So you have to reassess the patients for both the pain control and at the same time the adverse reactions of the patients from the medications that we have been given. So when significant change in worsening pain level is noted, you have to reevaluate promptly for possible evolving or there's a missed injury to the trauma patients. So there are also other available pain therapies such as the non-pharmacologic pain management, the pharmacologic analgesia, and the regional analgesia. So for the non-pharmacologic pain management, we have the cognitive strategies and the physical strategies. I am not going to discuss this, but I'm just going to enumerate the following. So for the cognitive strategies, we have the animal-assisted therapy, we have the cognitive behavioral therapy, the hypnosis, the mindfulness, music therapy, virtual reality also. So for the physical strategies, we have the acupuncture, the aromatherapy, the iontophoresis, the immobilization, the massage therapy, temperature, which is cold and hot therapy. And we also have the transcutaneous electrical nerve stimulation, the TENS, the ultrasound or the HIFU. And 4, remember that in such patients, or not just for the trauma patients, in our patients in general, we are using the multimodal analgesia. If you could remember the physiology of pain, so we have the transduction, transmission, the modulation, and the perception. So depending on the pain pathway, we can give medications accordingly. So if you want to alleviate the pain or somehow control the pain during transduction, so these are the medications that we could give: the NSAIDs, the aspirin, the paracetamol, or the opioids. During transmission, you can give the opioids, and during modulation, you can give the opioids, the selective serotonin reuptake inhibitors, or the serotonin or epinephrine reuptake inhibitors, for our tricyclic antidepressants. And for the perception, you can give the following medications: the opioids, still the SSRIs, SNRIs, the TCAs, right? So this is the role of the pain medications in the pain pathway. Remember the transduction, transmission, and the descending modulation. So the following exerts its effort or its mode of actions during the transduction, transmission, or the descending modulation. The NSAIDs is at transduction. So the following exert its effort or its actions on transmission of the pain. These are the following: the local anesthetics, anti-epileptic drugs, the gabapentinoids, the opioids, the peripheral and spinal nerve blocks, week 2, the epidural and the intrathecal analgesics. And for the descending modulation, still you can give the opioids, the antidepressants, the SNRIs or SSRIs. We have also adjuvant analgesics. As mentioned earlier, the gabapentinoids the serotonin norepinephrine uptake inhibitors, and our tricyclic antidepressants. The antipasmotic agents can also be given to our patients, and the dexmedetomidine also, as well as the lidocaine. Since in our patients, remember that in acute, or let's say in the moderate to severe type of pain, it can be very difficult to obtain an effective analgesia with a single drug alone, right? So as a consequence, analgesics are commonly combined to achieve better control of pain. So the optimal strategy now is to use a drug or combination of drugs or techniques that contribute through multiple mechanisms or different modes of actions to reach the therapeutic endpoint. So aside from giving the analgesics, the medications, you can also give, or you can also do regional analgesia. So you do regional blocks, either the epidural, paravertebral blocks, ultrasound-guided fascial blocks, the extremity blocks for such patients, okay? So for the multimodal pain management across the trauma care continuum, this is what we usually give. So pre-hospital, you can give the non-pharmacologic therapy, such as the positioning of the patient, splinting, using the heat and cold therapy or the calming therapies. And then as the severity of the pain increases, you might want to give also acetaminophen or the paracetamol or the NSAIDs, unless otherwise contraindicated to your patients. So you also have to give the symptom-driven adjuvants. You just can't give any adjuvants to such patients. So you might want to give the muscle relaxants, gabapentinoids, SNRIs, depending on what the patient needs. So if the pain of the patient is severe already, you might want to give the IV systemic opioids to the patients. Okay, so it is prudent to use or utilize the short-acting agents. You can use the intravenous opioids to our patients as needed for severe acute nociceptive pain or during the procedural pain, or if the patient has pain during the procedures, right? So use the regional anesthetic techniques as much as possible. So they should be based on the patient-specific considerations. So for the phases of care and the use of multimodal strategies, pre-hospital, emergency department, perioperative, intensive care unit, ward, and discharge, we still use, number one would be the non-pharmacologic strategies. These are still the positioning, splinting, using the heat and cold therapies, the calming therapies, and we can use the short-acting analgesics to such patients. For severe patients or severe pain of the patients who are in the emergency department, you can give the IV opioids, whichever is available in your institution. So you can give the fentanyl, morphine, the oxycodone, or the tramadol. But for severe pain, you might want to give the fentanyl or morphine or the oxycodones. You can also give the ketamine and the non-steroidal anti-inflammatory medications unless otherwise contraindicated to your patients. So still, you use the analgesia or even the opioids based on the needs of your patients. So for localized pain also, you might want to use the local anesthetics for painful local injuries or for procedures. You can use the regional blocks. Unless contraindicated, you may want to give the NSAIDs or the paracetamols or acetaminophen. And of course, for the breakthrough pain of the patients, you can give the oral opioids or the IV opioids, depending on the needs of your patient. So perioperatively, the above mentioned are still being advocated. We still use this based on the symptoms of the patient or the cases of the patients. So in the intensive care unit, still, we use the non-pharmacologic strategies, the paracetamol or the acetaminophen, unless otherwise contraindicated. We also use the NSAIDs. If not contraindicated, use the opioids, the NMDAs, ketamine, alpha-2 agonist, aclonidine, dexmedetomidine, the local anesthetics, regional blocks, and as well as the symptom-driven adjuvant therapy. So when the patient is already in the ward, or if you have patients in the ward who have pain, you can still use the non-pharmacological strategies, the proper positioning of the patient, again, splinting, using the cold and the heat therapies and the calming therapies, etc., etc., etc. And upon the discharge of the patient, you might want to taper the opioids as well as your NSAIDs to the patients, or your paracetamol, depending on the severity of the pain of the patient. So when the patient is already up for discharge, it's expected that the pain level of the patient should be diminishing also, unless otherwise patient has chronic type of pain, or the patient has infections, or if the patient has anxiety, etc. But for such patients, I think these patients will not be advised to go home unless the patient does not want to stay in the hospital anymore, right? So you have to taper down the medications that you use, especially the pain meds that we give to the patient. So for the perioperative analgesia, for the patients who are undergoing surgery, of course, we have to note that the history and P of the patients is still very important. So you have to note the neurocognitive disorders if the patient has this, because this will affect the analgesic requirements of the patient. If the patient has ischemic heart conditions, as this may lead to subsequent oxygen supply demand. If the patient has pulmonary dysfunction, because your opioids may have an effect to the respiration of the patients. Also, if the patient has renal or hepatic diseases, then the coagulation disorders of patients. So intraoperatively, we can still give the opioids, as this is the cornerstone of intraoperative analgesia. You can give the NMDA antagonist, and at the same time, you can also, if you want, you can give the dexmedetomidine intraoperatively. And now let's go to the acute pain management in the ICU for critically ill trauma patients. So for such patients, the validated measurement tools that we use to assess the pain of the patients are very important in the analgesic program in the ICU. So an ICU multimodal analgesia protocol is needed to match medications and their doses or titration to the severity of the patient's pain. So the use of opioids as first-line agents for patients with severe acute nociceptive pain in the ICU setting as a part of the multimodal analgesia pain management plan is very important. So we have to consider also the patient comorbidities and medical history of the patient. So especially when you choose the medications for analgesia and sedation. So also the transition of the patients from parenteral to enteral medications prior to the transfer from ICU whenever possible. So the intent of the guidelines is to increase the use of the multimodal analgesia and to improve the pain management for the more than 50% of patients who reported to have inadequate pain relief while they were in the ICU. So our multimodal analgesia decreases the use of the opioids, or it decreases the opioid requirements in the ICU. So it is very important also to account for the patient's past medical history and comorbidities whenever you use an analgesic regimen. So patients with substance disorders, no, so including alcohol, tobacco, or prior admission, they are often an multimodal analgesia challenge. So whenever we try to or attempt to manage the alcohol or drug withdrawal and to achieve the satisfactory levels of analgesia. So it is very important to recognize the undertreatment or the overtreatment of pain, as this contributes to the development of chronic pain syndromes, specifically in the ICU area. So chronic pain syndromes are common following trauma and surgery, and it is very naive to think that chronic pain syndromes can be alleviated by better pain management. So remember, hyperalgesia in response to opioids, and the relation of the hyperalgesia may lead to chronic pain syndrome development, right? So the first priority in ICU patients is pain management. So we use the opioids if necessary, and you also use the other analgesics to decrease the total dose of opioids. So adequate sedation must be prioritized also in the ICU patients. So typically with benzodiazepine sparing regimens, it is of the light to moderate sedation along with the daily sedation at holidays. So we use this benzodiazepine sparing regimen. So when we use this medication, there is an associated decrease in the opioid consumption and increased ventilator-free days, decreased incidence of delirium, and at the same time, decreased length of stay in the ICU. So remember, sleep disruption or sleep fragmentation is associated with increased pain perception. So the use of sleep promotion protocols that reduce in-room activity or the unwanted noise is of important also in such patients. So that's why we sedate these patients whenever needed. So this is my last slide, and this is of the references that I have used for today's topic. Thank you.
Thank you, Dr. Paco. And I'm reminding the audience, both live and in our virtual audience, that you can type in your questions in the Q&A box so that the speakers can answer them in our open forum session after the lectures. Our last speaker for this session is a training officer of the Department of Anesthesiology at Zamboanga City Medical Center. She is a member of the Doctor to the Barrio Foundation, the Islamic Medical Association of the Philippines, as well as the Integrated Chemists of the Philippines. She had her clinical fellowship in neuroanesthesia at UP-PGH. Here to talk about anesthetic management of patients with traumatic brain injury, please welcome Dr. Saida Aminulia Abdul.
Good afternoon, everyone. First of all, I would like to thank the Philippine Society of Anesthesiology for giving me the opportunity to talk about the anesthetic management of patients with traumatic brain injury. The learning objectives are as follows. To review the pathophysiology of traumatic brain injury, discuss the initial assessment and resuscitation of TBI patients, present updated guidelines in anesthetic management in TBI patients, and discuss fluid resuscitation, blood transfusion, and vasopressor use in TBI. TBI is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. Alteration in brain function is defined as one of the clinical signs listed. This definition recognizes that clinical symptoms of brain injury may be delayed or absent, and that other evidence of brain pathology can include imaging or laboratory investigations. The focus of this definition is brain rather than head injury. The 6 categories of external force that may result in TBI are also listed on the slide. Estimating the global burden of TBI is challenging. High-quality epidemiologic data are mostly available from high-income countries. The global burden of disease study estimated the annual incidence at 27.08 million with a prevalence at 55.5 million. Falls were the single most common cause of TBI in every socio-demographic index category, with road traffic injuries the second most common cause. The immense expenditure on clinical management of TBI patients and associated socioeconomic problems have imposed a heavy burden on the healthcare system and the society. TBI has traditionally been classified using injury severity scores, the most common of which is the Glasgow Coma Scale. The GCS is universally accepted as a tool for TBI classification because of its simplicity, reproducibility, and predictive value for overall prognosis. A GCS score of 13 to 15 is mild, 9 to 12 is moderate, and 8 or less is considered severe. However, it is limited by confounding factors such as medical, sedation and paralysis, endotracheal intubation, and intoxication. An alternative scoring system, the full outline of unresponsiveness score, has been developed in order to attempt to obviate these issues. The 4 score includes brainstem reflexes, visual tracking, breathing pattern, respiratory drive, and motor response, with 4 as the highest score for each component and 0 the lowest. We shall now discuss the pathophysiology of TBI. It is divided into 2 separate but related categories: the primary brain injury and secondary brain injury. The primary insult results from mechanical damage occurring at the moment of impact and is exclusively sensitive to preventive but not therapeutic measures. The secondary insult is delayed, non-mechanical damage, represents consecutive.
Sorry, we just have to pause for a while. I think the electricity fluctuated, so we could not stream this live. So can we, you'll probably need to move 2 slides back.
Okay.
Okay, sige. Okay lang.
Is this?
Yeah, sit down na lang first. We'll let you know when we can start.
Okay.
For a short break, we'll just fix the electricity and the internet. Thank you.
Greetings to all distinguished guests, colleagues, and friends. In behalf of the Philippine Society of Anesthesiologists,
Hi, good afternoon. We're going to resume the sessions already. Thank you for your patience.
Okay. Good afternoon, everyone. So,
Recording in progress.
Moving on. Traumatic brain injury has traditionally been classified using injury severity scores. The most commonly used is the Glasgow Coma Scale, which is universally accepted as a tool for TBI classification because of its simplicity, reproducibility, and predictive value for overall prognosis. A GCS score of 13 to 15 is considered mild injury, 9 to 12 is moderate, and 8 or less is severe. However, it is limited by confounding factors such as medical sedation and paralysis, endotracheal intubation, and intoxication. An alternative scoring system, the full outline of unresponsiveness score, has been developed in order to obviate these issues. The 4 score includes visual tracking, motor response, brainstem reflexes, and respiratory drive, with 4 as the highest score for each component and 0 the lowest. We shall now discuss the pathophysiology of TBI. The pathophysiology of TBI-related brain injury is divided into 2 separate but related categories: primary brain injury and secondary brain injury. The primary insult results from mechanical damage occurring at the moment of impact and is exclusively sensitive to preventive but not therapeutic measures. The secondary insult is a delayed non-mechanical damage, represents consecutive pathologic processes initiated at the moment of injury with delayed clinical presentation. The secondary injuries from traumatic brain injury leads to alteration in cell functions and propagation of injury through processes such as depolarization, excitotoxicity, disruption of calcium homeostasis, free radical generation, blood-brain barrier disruption, ischemic injury, edema formation, and intracranial hypertension. The figure shows the schematic representation of pathophysiology of traumatic brain injury. Blood-brain barrier dysfunction caused by TBI insult allows transmigration of activated leukocytes into the injured brain parenchyma. Activated leukocytes, microglia, and astrocytes produce reactive oxygen species and inflammatory molecules such as cytokines and chemokines that contribute to demyelination and disruption of axonal cytoskeleton, leading to axonal swelling and accumulation of transport protein at the terminals, thus compromising neuronal activity. Excessive accumulation of glutamate and aspartate neurotransmitters in the synaptic space due to spillage from severed neurons, glutamate-induced aggravated release from presynaptic nerve terminals, activate NMDA and AMDA receptors located in postsynaptic membranes, which allows the influx of calcium ions. This would then lead to production of reactive oxygen species and activation of calpains. These cellular and molecular events, including the interaction of fast ligands, ultimately lead to neuronal cell death. To understand the secondary injury, let us review brain physiology. According to the Monroe-Kelly doctrine, inside the cranium, the overall volume of cranial vault is constant, such that brain parenchyma, CSF, and blood component must adjust when there is an increase in ICP. Since brain tissue has minimal compensatory capacity, in the presence of cerebral edema, CSF and blood volume must decrease in order to regulate ICP. CSF may drain through the lumbar plexus, and blood volume is tightly autoregulated by both the PaCO2 and PO2. The goal of ICP monitoring and control in the TBI patient is to maintain an appropriate CPP through either increasing MAP or decreasing ICP. A variety of therapies may be applied to lower ICP and reduce cerebral edema in an attempt to maintain sufficient CPP to provide adequate oxygen delivery to avoid secondary cerebral injury due to ischemia. There is a delicate balance between increasing cerebral perfusion and keeping ICP and cerebral edema minimized. Pre-anesthetic evaluation should be as comprehensive as possible, but may be limited by the acuity of the clinical situation. In most cases, patients will present to the operating room after evaluation and initial management at the ER. The primary goal of preoperative evaluation for patients with TBI is to minimize secondary brain injury by the prevention and treatment of hypotension and hypoxia, two systemic insults known to be major causes of secondary injury. The severity of TBI estimates the degree of impaired physiology, determines the urgency of a surgical procedure and the plan for postoperative care, and predicts risk for complications and overall prognosis. Preoperative laboratories should be reviewed, which includes hemoglobin, platelet count, clotting parameters, electrolytes, glucose, and blood gases. Abnormalities of coagulation parameters are common and require ongoing assessment and correction. For the neuroimaging, CT is the preferred modality, and it will detect skull fracture, intracranial hemorrhage, and cerebral edema. While MRI is currently less available in acute setting, it would take longer to perform and more expensive than CT. It has superior sensitivity for the identification of hemorrhagic axonal injury and small contusions that are not evident on the CT scan. The goals for anesthetic management of patients with TBI includes the following: stabilization of the patient if still unstable, which includes facilitating early cerebral decompression in patients with expanding intracranial hematoma, maintain cerebral perfusion pressure, and treat increased intracranial pressure. Avoid secondary insults including hypotension, hypoxia, hyper and hypocarbia, hypo and hyperglycemia, seizure, and coagulopathy. Optimization of cerebral hemodynamic and oxygenation, which includes providing adequate analgesia and amnesia. And to facilitate early postoperative neurologic evaluation when possible. So what can we do as anesthesiologists? As discussed earlier, the best hope for improving outcome in traumatic brain injury patients is a better understanding of the processes and the development of therapies that can limit secondary brain injury. Critical aspect of avoiding secondary brain injury after TBI is the avoidance of secondary brain insults. With that said, it cannot be overemphasized that we anesthesiologists play a major role to improve outcome in our TBI patients. This slide summarizes the goals of treatment for TBI patients according to the American College of Surgeons. This should, however, serve only as guide in our treatment, since management of TBI should be individualized. We will now discuss the treatment recommendation for severe TBI. For the airway control, studies have shown a correlation between hypoxia and poor outcome. Intubation by inexperienced providers showed a 4-fold increase in death and a significantly higher risk of worse functional outcomes when compared to patients whose airway was secured in the emergency department. Pre-existing hypoxia, intracranial hypertension, full stomach, and coexisting injuries such as cervical spine trauma and maxillofacial injuries may be present that predisposes a patient to difficult airway management. Thus, careful preparation and pre-oxygenation is mandatory. For the ventilation, it is recommended that end-tidal CO2 should be maintained between 35 and 45. Ventilation rates are recommended as follows: for infants, 25 breaths per minute, children, 20, adolescents and adults at 10. Hypoventilation should be avoided as increased PCO2 levels may lead to cerebral hyperemia with an increase in blood volume and ICP. Hyperventilation, on the other hand, results in an increased risk of vasoconstriction and increased tissue hypoxia, especially in the penumbra zone, so it is best avoided. Target tidal volume should be at 6 to 7 ml per kilo. Prophylactic hyperventilation done at ER is not recommended. The Brain Trauma Foundation guidelines recommend hyperventilation only for obvious signs of herniation. In such cases, only mild hyperventilation is recommended at ETCO2 target range of 30 to 35. FiO2 setting should be adjusted to achieve a PaO2 of 90 millimeters mercury, which can oxygenate the penumbra zone. High PaO2 should be avoided considering the risk of hyperoxic cerebral vasoconstriction and hyperoxic lung injury. A PEEP of 5 to 10 cm water may be administered to prevent atelectasis. And although early tracheostomy may not be associated with a reduction in ventilator-associated pneumonia risk, ventilator or ICU days are reduced. Thus, the Brain Trauma Foundation has recommended that early tracheostomy should be performed to reduce ventilation days when the overall benefit outweighs the complications associated with the procedure. However, ventilation should be guided by blood gases rather than by end-tidal CO2. Osmotic therapy is generally utilized in TBI patients who are clinically symptomatic from cerebral edema or have documented ICP elevation that does not respond to initial measures such as CSF drainage, analgesia, and sedation. Even though mannitol is used most commonly intraoperatively because of its rapid onset, efficacy in decreasing ICP, and improvement in brain relaxation, hypertonic saline has been used as an alternative. The slide compares the properties between the two agents. Mannitol works by dehydrating the brain, especially in areas of cerebral edema. It increases cerebral blood flow by plasma expansion, decreasing the blood viscosity via deformed erythrocytes and promoting osmotic diuresis. Unfortunately, it loses some of its efficacy with time and has some potentially serious side effects, including renal failure and pulmonary edema. Serial serum osmolarity should be measured and kept below 330 milliosmoles to reduce the risk of renal failure. Hypertonic saline can be administered for patient refractory to mannitol or if repeated administration of mannitol results in the adverse effects such as renal injury, hypervolemia, or electrolyte disturbances from profound diuresis. Hypertonic saline decreases endothelial cells and erythrocytes, which increase the diameter of the vessels and deformability of erythrocytes and leads to plasma volume expansion with improved blood flow. The rebound phenomenon seen with mannitol has not been reported in TBI after 3% saline administered, even with multiple uses. It may aggravate pulmonary edema in patients with underlying cardiac or pulmonary problems. Another table summarizing the different properties of mannitol and hypertonic saline. 3% hypertonic saline is most commonly used as a continuous infusion, while the 23.4% is typically used in intermittent boluses. Hypertonic saline should be administered via a central venous catheter because of the risk of extravasation injury when used with peripheral IV access. Because of the limited evidence, the Brain Trauma Foundation guidelines recommends mannitol, effective for the control of elevated ICP while avoiding hypotension. The Brain Trauma Guideline did not find strong evidence to make recommendation on the use, concentration, and method of administration of hypertonic saline. There has been many studies comparing hypertonic therapy regimen, but none have found compelling evidence to suggest superiority of either agents to improve outcomes such as mortality or functional recovery. After TBI, there is a marked catecholamine surge with cortisol release and glucose intolerance, leading to significant hyperglycemia. This has been associated with an increased odds ratio for an unfavorable neurologic outcome and an increased risk of mortality. In critical ill patients, hypoglycemia is strongly correlated with increased morbidity and mortality. Therefore, moderate glucose control target with a range of 140 to 180 millimeters per deciliter are currently recommended so that hyperglycemia and hypoglycemia can be avoided. For the temperature management, the goal is to maintain normothermia. In clinical practice, even mild hyperthermia has been associated with poorer outcome and longer ICU stays, as it may lead to increased edema and inflammation. Therapeutic hypothermia has not been shown to improve outcome in patients with TBI. The Euroterm trial was terminated prematurely because signs of harm with the treatment arm were evident. Therapeutic hypothermia treatment should therefore be limited to clinical trials or to patients with elevated ICP refractory to other therapies after discussion with the family. For anti-seizure medications are generally recommended to prevent and treat early post-traumatic seizure in the setting of severe TBI. While Brain Trauma Foundation guidelines recommend phenytoin to prevent early post-traumatic seizure for the first 7 days following injury, levetiracetam is gaining preference. Studies of phenytoin use in other conditions, such as subarachnoid hemorrhage, have revealed an adverse association between higher cumulative dosing of phenytoin and worse long-term functional and cognitive outcome. A randomized clinical trial that compared levetiracetam with phenytoin for seizure prophylaxis in neurosurgical ICU patients revealed equivalent efficacy for seizure prevention but improved 6 months functional outcomes with levetiracetam. Subsequent meta-analysis that include observational studies revealed fewer adverse drug events with levetiracetam. Corticosteroids should not be given empirically in the operating room because there is no benefit in these patients. In patients with severe TBI, high-dose methylprednisolone was associated with increased mortality and is contraindicated. For fluid management, patients with elevated ICP should be kept euvolemic and normo to hyperosmolar. This can be achieved by employing only isotonic fluids, and serum osmolality should be kept between 295 to 305 milliosmoles. The initial management is always administration of glucose-free isotonic crystalloid fluids. The primary objective should be to maintain a systolic BP of 90 to 100 millimeters mercury because transient episode of hypotension leads to irreversible secondary brain damage in a time and dose-dependent manner. It is advised to measure the ICP to estimate CPP and maintain it at greater than 60 millimeters mercury. Colloids are associated with increased chance of acute kidney injury and increased use of renal replacement therapy in critically ill patients. They appear to provide no further benefits, and the SAFE trial found increased mortality in patients receiving albumin compared to saline. Recent Cochrane review have demonstrated that the use of colloids is not superior to crystalloids for overall mortality, especially in patients with trauma, burns, or post-surgery. Evidence seems to suggest that this is volume of fluid infused rather than the choice of fluid itself that plays an important role in outcome following TBI. A liberal transfusion threshold hemoglobin greater than 10 grams per deciliter did not result in improved outcome at 6 months compared with threshold of 7. And the 10 grams per deciliter threshold was associated with a higher incidence of adverse thromboembolic events. Transfusion should be based on ongoing bleeding, the clinical status, and patient comorbidities rather than a specific hemoglobin trigger. Vasopressors are commonly used to augment CPP in the setting of TBI, although data comparing this drug is limited. The effect of these drugs on cerebral physiology are complex and reflect the baseline BP, the status of autoregulatory mechanism, the mechanism of drug effect, and the magnitude of BP change. For patients with TBI, available evidence does not support a preference for a particular vasopressor over others. The selection of vasopressor should be based on patient factors and the clinical situation. Induced hypertension in high-risk group of patients is associated with the development of symptomatic ARDS. Thus, efforts to optimize CPP should first focus to lower ICP rather than elevating MAP with vasopressors. Hypertension is more likely to worsen cerebral edema when protective autoregulation is impaired. The fourth edition of the Brain Trauma Guidelines recommends maintaining SBP at 100 or greater than 100 millimeters mercury for patients 50 to 69 years old, or at 110 millimeters mercury or above for patients 50 to 49 or over 70 years old, to decrease mortality and improve outcomes. The recommended target CPP value for survival and favorable outcome is between 60 and 70 millimeters mercury. Avoiding aggressive attempts to maintain CPP above 70 millimeters mercury with fluids and pressors may be considered because of the risk of adult respiratory failure. For patients with elevated ICP that is refractory to the measures described above, they may be managed with decompressive craniectomy, barbiturate coma, or hypothermia. The rescue ICP trial showed that at 6 months, decompressive craniectomy in patients with TBI and refractory intracranial hypertension results in lower mortality but higher rates of vegetative state and lower severe disability compared to medical care. While effective for control of ICP by decreasing CMRO and decreasing cerebral blood volume, the use of barbiturate coma has not been shown to improve outcome following TBI. Therapeutic hypothermia has a potential to reduce ICP as well as to provide neuroprotection and prevent secondary brain injury by the reduction in glutamate release, preservation of energy balance, reduced apoptosis, reduced free radical and inflammation. Therapeutic hypothermia has not been convincingly shown to improve outcomes. So in summary, we have discussed the definition, epidemiology, severity classification, and pathophysiology of TBI. The best hope for improving outcomes in traumatic brain injury patients is a better understanding of the processes and the development of therapies that can limit secondary brain injury. Critical aspect of avoiding secondary brain injury after TBI is the avoidance of secondary brain insults. When dealing with severe TBI, the following is the recommended guideline published by Dash and Shavali in Korean Journal of Anesthesia in 2018. With that, I would like to thank you for your kind attention.
Thank you, Dr. Abdul. Okay, so the floor is now open for questions, both from our live audience and from our virtual audience. So you can approach the mic. Okay, so there's a question here. I think this is for Dr. Paco. Is opioid the only recommended drug for breakthrough pain?
Well, opioid is not the only recommended drug for breakthrough pain. So you can use NSAIDs or the paracetamol unless otherwise contraindicated to our patients. You can also give different medications. Let's say if the breakthrough pain is, let's say, being caused by anxiety of the patient, you might as well give anti-anxiety, or you can give anxiolysis to the patients. So opioids, although it is one of the gold standard in giving pain medication to our breakthrough pain patients, so there are still other medications that you can give to the patients. So I think.
Okay, thank you, Dr. Paco. This next question is also for you. Any alternative for NMDA if the surgery requires an awake patient post-op?
Well, aside from the low-dose NMDAs, the ketamines, the methadone, we can also use, let's say, the magnesium sulfate to our patients.
Okay. One last question for you, Doc.
Okay.
In relation to chronic pain, can you expound more on the development of hyperalgesia with opioid use?
Oh, okay. So we're talking about the opioid-induced hyperalgesia. So most of these patients, these are from patients that have been using the prescribed opioids. Now, the opioids itself is that when these patients take the opioids, the pain definitely has to be diminished. So once the opioids attach its effect on the opioid receptors, it sends a message to the brain telling the brain that the pain of the patient must be lowered now. So this does not necessarily happen most often if one of the effects of the opioid is to decrease the pain of the patient. However, the opposite reaction of that is a hyperactivity or hyperreactivity to the opioids. So when the patients who have been using opioids, naibaba natin ang kanilang pain to this level, so the patient's body has now a new normal pain threshold. So when the patients have another kind of pain, the pain is magnified. So definitely the pain of the patient will need another dose of the opioids. So the more opioids that we give to the patient, the more the pain of the patient is magnified. So some of the studies also say that these OIH patients have genetic predisposition. So I think that's it. Other questions?
Okay, that's all for the questions for Dr. Paco. The next question is for Dr. Abdul. So the first question is, what is the manifestation of a disruptive calcium homeostasis in TBI?
Hello. The question is, what is the manifestation of
A disruptive calcium homeostasis in TBI.
a disruptive calcium homeostasis in TBI? Well, it's actually molecular or cellular level So usually the manifestation is in terms of in terms of the vital signs. There is the autoregulatory mechanism is disrupted. So that's one of the most common disruption.
Okay. This next question is also for Dr. Abdul. What is the role of permissive hypernatremia in TBI? When is it beneficial and when is it detrimental?
Well, actually, the management of traumatic brain injury should be individualized. So we should, there is really no specific target for the hypernatremia. And so we have to look at the patient if the baseline of the patient is the baseline sodium of the patient is on the higher side. We have to check also if his or her physiologic reserve is equipped to handle such abnormal sodium.
Okay, there's another question for Dr. Abdul. In your opinion, in what parameter should we base the transfusion threshold?
As lectured earlier, the transfusion threshold is, the recommended is at 7 grams per deciliter. However, as medyo paulit-ulit na. So, the treatment should be individualized. So we should not be limited by the recommendation, but we have to look at the patient if the vital signs is still on the normal side, and we have to check for the blood loss. So these are the more of we transfuse blood based on the clinical picture of the patient rather than the cut-off hemoglobin threshold.
Okay, one more question for Dr. Abdul. May I know why high-dose methylprednisolone is contraindicated and highly fatal intra-op in a TBI patient?
Based on the study done before, they had the study showed that there had been increased mortality when high-dose methylprednisone was given to traumatic brain injury patients. Perhaps, well, I'm not really sure. Perhaps one of the reasons why is because the autoregulation is already deranged, so, and there is trauma, systemic trauma, so perhaps the perhaps mas prone to infection yung patient. So I'm not really sure why they concluded that.
Okay, thank you, Dr. Abdul. The next question is for Dr. Hodges. Somebody here wants to know if you have any experience in a far-flung, low-resource area in the Philippines.
No, the only place I've worked in the Philippines is Davao.
Okay, so do you have plans in doing so, Dr. Hodges?
If I was given the opportunity, I would love to. I'm not sure that that opportunity will arise. I arrived here about 6 weeks before the severe lockdown prior to the pandemic, and for quite a long time it was difficult to even leave Davao City. So I haven't had that many opportunities to travel.
Thank you, Dr. Hodges. Do we have time for more questions? Okay. Okay, there's a live question here.
Hello.
Please introduce yourself, Doc.
Yes, Dr. Melissa Morala Caranto from the Philippine Heart Center. This is more of a reaction than a question. I'm quite glad that the neuroanesthesia has adopted physiologic triggers rather than the number as a transfusion trigger, because that is our general direction in the field of blood transfusion. We don't believe in 10, 9, 8, 7 anymore. We believe in the physiologic triggers, in the SVO2, in the venous saturation. We believe in looking at how the patient is, yes, doctor, at the patient status, and whether the patient is bleeding, and whether the patient is decompensating, rather than pegging it on a certain number, because that number is not something to treat. So even if we have a bigger number, if the patient is decompensating, why should we withhold transfusion? And why should we transfuse in a patient that is okay with a chronic kidney disease at the hemoglobin of 8? Diba? So I'm quite glad that everybody is following the same direction of following the physiologic triggers. Thank you, Doctora.
Thank you, Doctor. Okay, we have another question here. This is also for Dr. Abdul. In clinical practice, what parameters can be used as surrogates for CPP?
In clinical practice, well, CPP is actually MAP minus ICP. So, clinically, well, because I practice in a hospital where we do not have high-tech gadgets for measuring CPP, so clinically, we just we just check the baseline BP of the patient, and then we check the pupillary reaction of the patient, the GCS score, so those parameters. So mostly clinical talaga, because we don't have the high-tech gadgets for measuring the CPP.
Thank you, Dr. This next question is also for you, Doc. Would you recommend using D5 containing IV fluids for patients with TBI?
As lectured earlier, when you have TBI patients, the first line of treatment for volume resuscitation is using glucose-free isotonic fluids. However, if you have patients who have diabetes or have diabetes, I think we have, madali lang naman mag-check ng CBG. So, in answer to that question, we don't recommend giving glucose-containing fluids for TBI patients. And however, if the patient requires glucose-containing, we can check the CBG first before we give glucose-containing fluids if needed.
Okay, this question is also for you, Dr. Abdul. So sorry, the questions are all for you. Considering the importance of the CO2 level in resuscitating a TBI patient, would you recommend that the paramedics also employ the use of capnograph as another requirement with the pulse oximeter to avoid complications and the secondary TBI?
Well, actually, end-tidal CO2 is part of the ASA standards in monitoring our patients. During the pandemic, we had experience na we don't recommend checking the chest rise and auscultating the chest. So at that time, we make use of the end-tidal CO2. So if the budget permits, I think it's we can recommend the end-tidal CO2.
Thank you, Dr. Abdul. Do we have more time for a few more questions? Two more questions. Okay. Okay. Dr. Hodges?
I just wanted to add something to that. Pulse oximetry is a relatively cheap form to develop a monitor. Lifebox managed to develop a monitor for $250, small little portable monitor. End-tidal CO2 has always been a lot more tricky. There's been a lot of work over the last few years trying to develop small portable end-tidal CO2 monitors. And right at this moment, we're trialing 2 monitors through Lifebox, which do pulse oximetry and end-tidal CO2. They're both portable. They're not yet on the market, but we're trialing them. So those would be the ideal ones when you have budgetary constraints to use for your paramedics for measuring your end-tidal CO2 in those situations.
Thank you, Dr. Hodges. Okay, one more. We have time for one more question. This is for Dr. Abdul again. Would you recommend lung recruitment strategy in a patient with TBI?
Lung recruitment strategy is actually tricky, and before there were strong proponents for that. However, well, based on the lecture, may mga part of the complication of lung recruitment is pwedeng bumaba yung BP because of the lung recruitment strategy. And well, I'm not really well-versed into the indication for lung recruitment therapy. But based on my lecture, the PEEP recommendation is at 5 to 10 lang. So I don't think na lung recruitment therapy is indicated. If may mas makakasagot po, please help.
Okay, thank you, Dr. Abdul. So that wraps up our open forum for the last 3 lectures. Stand by for the next set of lectures.
So we'd like to thank Dr. Panuda for moderating this set of lectures. So we will now have a 30-minute break. Dr. Roa, our next speaker, is presently indisposed and will not be able to deliver a lecture. We can make use of this time to visit the exhibitors area and maybe take a quick break from sitting down for the rest of the day. So we'll see you again at 3:30. Thank you, everybody.
Our cordial greetings to all distinguished guests, colleagues, and friends. In behalf of the Philippine Society of Anesthesiologists, Southern Mindanao Chapter, I would like to take this opportunity to express my deep appreciation for your enthusiasm and participation in our society's first hybrid Midyear Convention here in Davao City. The current crisis has taken a colossal toll on all of us. We were torn between choices on which to prioritize: lives versus livelihoods, health versus economy, lockdowns versus survival, and the list may be endless. But little did we know that all these choices have been intertwined, intimately integrated, and interdependent. Health is not a luxurious commodity, but a basic foundation of social, economic, and political stability. As they say, when health falters, everything flounders. In the midst of the global pandemic, confounded by the very volatile geopolitical, security, and economic uncertainties in Europe, we remain steadfast with deep dedication, vigilance, and resilience. Today marks another milestone as we pioneer the combined virtual plus in-person comprehensive scientific sessions and industry-sponsored discussions. This will further enrich our faculties and sharpen our skills as anesthesia and perioperative care providers in the service of our fellow men. Take part in the various academic and recreational activities specially prepared for all of us. Have fun and savor the delectable cuisine and exotic fruits of Davao. Again, thank you. Daghang salamat and stay safe.
Maayong adlaw, good day. Maayong pagabot sa inyo tanan, and welcome to Davao City. Come and join us. The Philippine Society of Anesthesiologists warmly welcomes you to its 2022 virtual hybrid Midyear Convention here in Davao City. Indeed, this is the perfect venue to slowly restart our face-to-face reunions and celebrations. Let Davao's rich history that reflects undisputable warmth and reliance be our background in our renewal of commitment to the society as we promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interest of our members, our patients, and the nation. Let the Dusit Thani Hotel be our concourse as we forge our strong commitment to quality care, our sincere concern for members, and our genuine interest for professional growth. In full force, let us join hands in re-navigating anesthesia practice. Take part in our remarkable exchange of expertise and experiences as we discuss a wide array of topics from common perioperative issues to high-risk anesthesia. Be alert as we listen to lectures on urgent surgeries and patient safety. Let us highlight virtual updates on sepsis, acute kidney injury, trauma, and critical care. Keep the beat as we tackle dysrhythmias. Be mindful of our mental health. More importantly, as we re-navigate anesthesia practice, let us establish our academic compass and venture into new researches and discoveries. Clad in your Mindanaoan attire, join us during the fellowship night for our formal ceremonies and parade of magnificent fashion and marvelous singing voices. Be part of this historical event in the new normal as we, the Philippine Society of Anesthesiologists, brace ourselves for re-navigating anesthesia practice. Magkita ta. See you at the Dusit Thani Hotel, Davao City on May 26 and 27 for the 2022 Virtual Hybrid Midyear Convention. Thank you. Ako po ang inyong lingkod, Dr. Edgar Simon. Salamat kaayo.
Our cordial greetings to all distinguished guests, colleagues, and friends. In behalf of the Philippine Society of Anesthesiologists, Southern Mindanao Chapter, I would like to take this opportunity to express my deep appreciation for your enthusiasm and participation in our society's first hybrid mid-year convention here in Davao City. The current crisis has taken a colossal toll on all of us. We were torn between choices on which to prioritize: lives versus livelihoods, health versus economy, lockdowns versus survival, and the list may be endless. But little did we know that all these choices have been intertwined, intimately integrated, and interdependent. Health is not a luxurious commodity, but a basic foundation of social, economic, and political stability. As they say, when health falters, everything flounders. In the midst of the global pandemic, confounded by the very volatile geopolitical, security, and economic uncertainties in Europe, we remain steadfast with deep dedication, vigilance, and resilience. Today marks another milestone as we pioneer the combined virtual plus in-person comprehensive scientific sessions and industry-sponsored discussions. This will further enrich our faculties and sharpen our skills as anesthesia and perioperative care providers in the service of our fellow men. Take part in the various academic and recreational activities specially prepared for all of us. Have fun and savor the delectable cuisine and exotic foods of Davao. Again, thank you. Daghang salamat and stay safe.
Maayong adlaw, good day. Maayong pagabot sa inyo tanan, and welcome to Davao City. Come and join us. The Philippine Society of Anesthesiologists warmly welcomes you to its 2022 virtual hybrid Midyear Convention here in Davao City. Indeed, this is the perfect venue to slowly restart our face-to-face reunions and celebrations. Let Davao's rich history that reflects undisputable warmth and reliance be our background in our renewal of commitment to the society as we promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. Let the Dusit Tani Hotel be our concourse as we forge our strong commitment to quality care, our sincere concern for members, and our genuine interest for professional growth. In full force, let us join hands in re-navigating anesthesia practice. Take part in our remarkable exchange of expertise and experiences as we discuss a wide array of topics from common perioperative issues to high-risk anesthesia. Be alert as we listen to lectures on urgent surgeries and patient safety. Let us highlight virtual updates on sepsis, acute kidney injury, trauma, and critical care. Keep the beat as we tackle these arrhythmias. Be mindful of our mental health. More importantly, as we re-navigate anesthesia practice, let us establish our academic compass and venture into new researches and discoveries. Clad in your Mindanaoan attire, join us during the fellowship night for our formal ceremonies and parade of magnificent fashion and marvelous singing voices. Be part of this historical event in the new normal as we, the Philippine Society of Anesthesiologists, brace ourselves for re-navigating anesthesia practice. Magkita ta. See you at the Dusit Tani Hotel, Davao City on May 26 and 27 for the 2022 Virtual Hybrid Midyear Convention. Thank you. Ako po ang inyong lingkod, Dr. Edgar Simon. Salamat kaayo.
good afternoon once again. So let's resume our sessions. We have a few more lectures, so please sit down and join us while we enjoy our lovely lecture for this afternoon. But before that, let's introduce the moderator for this session. So Dr. Romil Oraiz is a member of the Board of Directors for the PSA Southeastern Mindanao Chapter. He is a chairman for the Department of Anesthesiology for the Davao Oriental Provincial Medical Center, where he is also the chief of clinics. Let us all welcome Dr. Oraiz.
Good afternoon. Indeed, the practice of anesthesiology is full of challenges, much more if we deal with COVID patients. This afternoon, our speaker will be talking about anesthetic considerations in patients with active or recent COVID infection. She had her clinical fellowship in intensive care at Prince of Wales Hospital in Hong Kong. She heads the Committee on Training of Non-Anesthesiologists at St. Luke's Medical Center in Quezon City. She is also the consultant of Department of Anesthesiology in the following hospital: St. Luke's Medical Center in Quezon City, Our Lady of Lourdes Hospital in Manila, Galileo Surgery Center and Vision Institute, Trinity Women and Child Hospital, and Providence Hospital. Colleagues, help me welcome our speaker, Dr. Alexandra Pacheco.
Thank you, Dr. Oraiz. 2 years ago, our lives were forever changed by a viral infection that took over the whole world. We lost family, friends, and colleagues to this illness, as well as some of the liberties we used to take for granted, such as dining together, gatherings, and travel. Thankfully, partially thanks to vaccines and health protocols, we have slowly been able to open up and continue with our lives living with the virus. Emerging variants, however, have caused setbacks through surges in infection rates. This afternoon, I will be discussing the anesthetic considerations in active and recovered COVID-19 patients. I'd like to thank the PSA for this opportunity. Early this year, the Philippines again stumbled on a setback because of the Omicron variant surge. I'm pretty sure we as anesthesiologists had at least one deferred procedure, either because the patient turned out positive or because the patient could not even book a PCR test required for elective surgery in most institutions. Infection rates have once again gone down, but the threat of variants and surges still exists, and we will have more and more patients either with COVID or recovered from COVID in our practice. As of May 25, 2022, the Philippines has a total of 3.68 million cases and 3.62 million recovered patients, according to data from the DOH. This means that it is very likely that we as anesthesiologists have and will encounter COVID-infected or COVID-recovered patients in our practice. Unfortunately, our Department of Health does not have any data regarding the incidence of COVID-19 in surgical patients or the incidence of surgical cancellations due to COVID-19. This may be a possible topic to write on so that we may have numerical data on how much COVID-19 has affected our practice. Fortunately, majority of people who had COVID-19 fully recover, largely due to the nature of the disease, but also through developments in vaccines and medical treatments. Current evidence, however, suggests that as much as 10 to 20% of those who recover experience a variety of mid and long-term effects after their initial illness. This has been described as post-COVID condition or long COVID, which the World Health Organization defines as illness that occurs in people who have a history of probable or confirmed SARS-CoV-2 infection, usually within 3 months from the onset of COVID-19, with symptoms and effects that last for at least 2 months. The symptoms and effects of post-COVID-19 condition cannot be explained by an alternative diagnosis. According to WHO, there does not seem to be a relationship between the initial severity of COVID-19 disease and the likelihood of developing post-COVID condition, meaning patients with mild acute illness can also develop long COVID. Listed on this slide are the most common symptoms of post-COVID condition or long COVID. Long COVID has been shown to affect the quality of life as it affects recovered patients' ability to perform daily life activities. It is likely that we as anesthesiologists will encounter patients with long COVID who are due for surgery. It's important to document these patients' long COVID symptoms and rule out other causes for these. So while COVID-19 starts as a respiratory tract infection, it can also have damaging effects on various organ systems. Multi-system critical illness is associated with a higher risk of mortality. The postulated mechanisms of systemic effect vary between systems, but common among them are direct viral injury and excessive inflammatory response. I will briefly discuss the effects of COVID-19 on the various organ systems in the context of anesthesia care. COVID-19 is highly transmissible through droplet or airborne routes. Certain variants have been found to be more contagious than others, though the degree of illness has been said to be milder compared to earlier variants. New variants and subvariants continue to emerge with the potential for increased transmission. So when caring for patients with active COVID-19 infection, appropriate PPE must be worn, especially when performing aerosol-generating procedures. Anesthesiologists are called on to perform intubation for severe or critical COVID-19 patients and are at higher risk for contracting infection. The lungs are the primary target of the virus, with it traveling through the conducting airways and triggering an immune response. Endothelial damage also disturbs pulmonary vasoregulation, causing VQ mismatch and fostering thrombogenesis. The pulmonary symptoms of COVID can range from mild upper respiratory symptoms to pneumonia and acute respiratory distress syndrome. COVID survivors who develop long COVID may have shortness of breath, persistent cough, chest pain, prolonged symptoms of exertional dyspnea and exercise intolerance, and some may even require oxygen support post-discharge from the hospital. For the anesthesiologist, lung protective ventilation strategies must be employed when caring for these patients, with careful fluid management to avoid overhydration and pulmonary congestion. The cardiac complications of COVID-19 are thought to be due to direct cardiac tissue damage by the virus, increased metabolic demand, procoagulant activity, inflammation, hypoxia, and increased myocardial demand. Symptomatic or asymptomatic tachycardia is the most often diagnosed arrhythmia in COVID-19, but bradycardia has also been noted. Other noted abnormal rhythms include atrial fibrillation, AV block, ventricular tachycardia, ventricular fibrillation, QT prolongation, or pulseless electrical activity. The high incidence of arrhythmias in COVID is thought to be multifactorial due to causes like hypoxia, myocarditis, cardiac injury, or prominent inflammatory response, direct viral invasion, and the use of QT prolonging medications. Arrhythmias may persist past COVID recovery and may still be seen months later. Plaque collapse and coronary thrombosis may cause acute coronary events because of inflammation or increased shear stress in high-risk patients. Heart failure may occur secondary to sepsis as a sepsis-related cardiomyopathy, and COVID-19 may also cause decompensation of an underlying heart failure. There should be a high index of suspicion for cardiomyopathy in case of sudden cardiac function decline, and appropriate testing like echocardiography should be done. In a COVID-recovered patient for surgery, it is prudent to assess if the patient may have residual cardiac complications or indications of myocardial injury. Follow-up echocardiography and ECG may be warranted, and if abnormal, additional testing and investigations such as stress testing or cardiac MRI should be considered. COVID-19 has been associated with a prothrombotic condition that induces venous and arterial thrombosis and elevated D-dimer. The reported incidence of cerebrovascular disease in severe COVID-19 patients range from 2.3% to 22%. The increased antiphospholipid antibodies have been implicated as a potential cause of ischemic stroke. Impaired consciousness, delirium, and symptoms of brain fog such as poor concentration, confusion, psychological symptoms, and behavioral changes may still be present or manifest up to months after recovery from the acute COVID infection. Rare cases of GBS have been reported after COVID infection, but causal association remains uncertain. Distinguishing respiratory failure due to GBS from that due to COVID lung disease may be difficult. Unsurprisingly, the prevalence of depression, anxiety, and other mental health problems increased during the pandemic, both in patients and non-patients. For patients with COVID-19, the stress brought about by their illness, fear for their health, and isolation and quarantine contributes greatly to the deterioration of their mental health. Patients may therefore be on the receiving end of psychopharmacologic therapy, which may affect the actions of anesthetic drugs as well. Prior to anesthesia, active COVID and COVID-recovered patients must have a neurologic assessment to document any deficits present post-COVID. Patients at risk for thrombosis and stroke might have been started on anticoagulation, and this is one of the things to be considered by the anesthesiologist. The pathogenesis of renal injury in COVID is multifactorial, including direct viral injury on the kidneys and immune response-mediated kidney injury. The hypercoagulable state associated with COVID-19 has also been postulated to cause renal thrombotic microangiopathy or microvascular thrombosis. Drugs used in the treatment of COVID, such as remdesivir, azithromycin, and tocilizumab, may also cause renal injury. Some studies have shown that the incidence of AKI in COVID patients may be as high as 25%, and patients with AKI or CKD had a greater in-hospital mortality rate compared to those without kidney disease. Unfortunately, survivors may still require RRT even after discharge. The anesthetic care for COVID or COVID-recovered patients with renal injury will need to consider avoidance of nephrotoxic agents, electrolyte management, and management of the potential for fluid overload. Abnormal coagulation parameters and increased biomarkers of inflammation in COVID-19 have been reported in several studies. Elevated levels of fibrinogen, D-dimer, increased protime, and elevated IL-6 have been observed. Inflammation activating procoagulant pathways has been the postulated mechanism. Thrombocytopenia is among the most common hematologic manifestations in viral infections. Possible mechanisms include direct viral invasion of bone marrow cells, platelet destruction by the triggered immune system, and platelet aggregation in the lungs. Because of the hypercoagulable state, COVID patients and COVID-recovered patients may be on some form of anticoagulant therapy, whether for prophylaxis or for the treatment of an existing thrombosis. This and the presence of thrombocytopenia become an issue in perioperative patients as discontinuation or bridging of anticoagulant therapy may need to be done because of the risk of surgical bleeding. Thrombocytopenia may also preclude the use of regional anesthesia. Injury to the gastrointestinal system is postulated to be secondary to viral enteroneuropathy with small vessel thrombosis, as well as direct viral injury of hepatocytes. Hepatotoxic effects of drugs also induce GI injury. Patients with excessive gastrointestinal losses through diarrhea or vomiting may have acid-base and electrolyte disorders, which should be evaluated and addressed prior to surgery. Hepatobiliary dysfunction, acute pancreatitis, and GI ischemia may be indications for emergency surgery or ICU admission in COVID patients. When caring for these patients, care must be taken to decrease the dosage or avoid hepatotoxic drugs. COVID-19 patients may have some degree of hormonal imbalance resulting in conditions such as hyperglycemia, thyroiditis, metabolic syndrome, and hypothalamus pituitary adrenal axis dysfunction. These may be due to inflammatory response to the disease, immune mediation, or secondary to the stress response from the infection. COVID-19 patients should be on some form of steroid therapy as part of their management, as they are prone to develop critical illness-related cortisol insufficiency. This has implications on anesthetic care. Glycemic control should be part of anesthetic management, and hypocortisolism should be considered in cases of refractory hypotension and shock with stress doses of steroids given. Musculoskeletal complications such as myalgia, myositis, and elevated creatinine kinase in COVID-19 can result from direct viral injury or from prolonged immobility, systemic inflammation, the use of corticosteroids, and prolonged paralysis, or critical illness myopathy. Even recovered patients may still have muscle aches, as earlier mentioned as a symptom of long COVID. This can contribute to difficulty in weaning patients from mechanical ventilation. COVID-19 or recovered patients for surgery should receive an assessment of muscle tone and strength preoperatively. Skin lesions such as COVID toes, livedo reticularis, acrocyanosis, and limb ischemia can result from microvascular injury and cutaneous thrombosis. Patients with severe skin lesions may require anticoagulation, which must be noted by the anesthesiologist prior to procedures. So early on in the pandemic, it has been established that surgical patients have unique risks due to COVID-19. Patients with COVID, either symptomatic or asymptomatic, have an increased perioperative risk for morbidity and mortality. An Italian study in 2020 showed that surgical patients with COVID had a 30-day mortality risk of 19.51%, which was significantly higher than those without COVID-19 who had a mortality risk of 2.44%. The odds of perioperative pulmonary and thrombotic complications were also higher in infected surgical patients. The American Society of Anesthesiologists and the Anesthesia Patient Safety Foundation have released a joint statement regarding elective surgery and anesthesia after COVID-19 infection. Both the anesthesiologist and surgeon or proceduralist must agree to proceed with elective surgery, deciding based on two questions. One, is the patient still infectious? And two, for patients that are no longer infectious, what is the appropriate length of time to wait between recovery from COVID and surgery in terms of risk to the patient? So up to when is a COVID-19 patient still infectious? Current CDC isolation recommendations are based on the severity of patient symptoms. Asymptomatic patients can end their isolation after 5 days. Those with mild symptoms should isolate for 5 days from symptom onset and must be fever-free for 24 hours. Those with moderate symptoms must isolate for 10 days, and those with severe illness are considered infectious up to 10 to 20 days from symptom onset. Longer isolation periods are recommended for those moderately to severely immunocompromised. There's increasing information to address the timing of surgery after COVID-19 infection. However, these studies lag behind emerging variants and vaccination rates. Because COVID-19 affects virtually all organ systems, timing should consider perioperative risks. A multi-country, multi-center study in 2020 reported increased risk of morbidity and mortality up to 7 weeks after COVID diagnosis. Note, though, that this study was conducted before these patients received even one dose of the vaccine. This data found increased risk to be present up 5 to 6 weeks, regardless of being asymptomatic or symptomatic, older or younger than 70, having major or minor surgery, or undergoing elective or emergency surgery. The ASA and the APSF have jointly come up with the following recommendations. Elective surgery should be delayed for 7 weeks after infection in asymptomatic, unvaccinated patients. There is insufficient evidence at the moment to make recommendations for those infected after vaccination. Delays in surgery should be weighed against the patient's time-sensitive needs. If surgery is deemed necessary in a period of increased risks, these risks should be discussed with the patient. Consider extending the delay if the patient has continued symptomatology, pulmonary or otherwise. And any decision to proceed with surgery should consider the severity of the initial infection, the potential risk of ongoing symptoms, the patient's comorbidities and frailty status, and the complexity of surgery. Now we discuss the perioperative anesthetic management for COVID and COVID-recovered patients. First and foremost, there should be a consensus between the anesthesiologist and surgeon whether the procedure should be carried out as discussed earlier. Emergency procedures can proceed despite infectivity if this is a life or limb-saving procedure for the patient. However, if the procedure can be done electively, we must again consider the factors to decide whether to continue. As with all patients for anesthetic care, a thorough pre-anesthetic evaluation must be done to now include history of COVID infection, vaccination, and the complications of COVID-19 infection, if any. Treatment protocols and medications should also be reviewed as they may affect anesthetic and surgical management. COVID-recovered patients must be interviewed and examined for symptoms of long COVID and documented accordingly. Pre-anesthetic testing and risk stratification may be required in patients, particularly those with cardiac and pulmonary complications or long-haul symptoms. Abnormal laboratory findings that are correctable, such as electrolyte imbalances, must receive attention if possible before anesthesia. COVID-19 patients or recovered patients who are on anticoagulant therapy may require bridging therapy depending on the risk for thrombosis. COVID-19 patients or recovered patients on long-term dialysis should have their procedures scheduled after an RRT session. For intraoperative management, early in the pandemic, most anesthesiologists opted to use regional anesthesia and avoid general anesthesia whenever possible. This was to reduce the risk of exposure to aerosolized droplets emitted during procedures like intubation. This is still a logical thing to do so that we can continue protecting ourselves and decreasing the risk of infection. But still, anesthetic technique selection must be based on what is the most appropriate and agreeable to our patient, as well as what is the most appropriate for the procedure. Standards of care during intraoperative management must still be maintained, while taking particular care of a few issues such as careful fluid management and use of lung protective ventilation strategies. Lower tidal volumes of 4 to 8 ml per kilogram predicted body weight are preferable with high PEEP, while targeting plateau pressures less than 30 centimeters water. Nephrotoxic and hepatotoxic drugs should be avoided to preserve organ function. Post-operative care, as usual, aims to maintain patient comfort with pain control strategies. Still, we should be aware to avoid nephrotoxic and hepatotoxic drugs post-op. Anticoagulant therapy may need to be resumed post-operatively with all services in agreement. So in summary, active COVID and COVID-recovered patients require the same care as our other patients, with extra precautions addressing the complications of the infection. COVID affects essentially all organ systems and may continue to affect them up to months after the acute infection. The decision to proceed with surgery and anesthesia should be made considering the perioperative risks related to COVID and the urgency and necessity of the procedure. As the world gains more insight to the disease, our knowledge and practices may change to accommodate these new findings. As anesthesiologists, we continually adapt to provide quality care for our patients while protecting ourselves. Thank you for your time, and you stay safe always.
Thank you very much, Dr. Pacheco, for that very interesting and informative lecture. Now we will go to our open forum. If you have questions, we'll entertain it live, or we are going to look at the chat box to answer your question. How about the live audience? Do you have a question? Okay. Let's take from the chat box. Doctor, we have a question here. In the current setting wherein most are already vaccinated and with milder symptoms, what is the expected clinical course for positive patients? Is the treatment symptomatic like an ordinary flu, or is there a need to give prophylactic anticoagulants?
The use of prophylactic anticoagulants is not mandatory, or you should not give it to all patients unless you have assessed the patient who have increased risk of thrombosis or complications related to thrombosis. So it still requires individual assessment of the patient before starting any anticoagulant therapy.
Thank you, doctor. Here's another question. Asymptomatic vaccinated patients for elective surgery, do you still recommend RT-PCR test?
Currently, it's now institution-based. So one of my institutions now no longer require RT-PCR prior to surgery or admission if the patient does not have any symptoms. However, other institutions still require RT-PCR testing. So this is a decision that should be made in conjunction with the Infection Control Committee of the hospital and the rest of the administration.
How about rapid antigen, doctor? Is there a role for a RAT test for elective surgery?
I think pretty much the same as RT-PCR, because since RT-PCR is more sensitive compared to an RIT, I would rather perform an RT-PCR test if it is feasible.
Okay, thank you. Since we have no more question here in the chat box, let's give our applause to our speaker, Dr. Pacheco. Thank you very much.
Thank you.
Okay, thank you, Dr. Orais. So we can move on to our next session. So the moderator for the last sessions is the Associate Dean for the University of Southeastern Philippines. She was the past Dean of the same university, the past President for the Philippine Medical Association's Davao del Norte Medical Practitioner Society Incorporated, and the past Chairman for the Department of Anesthesiology for the Davao Regional Medical Center. Let us all welcome Dr. Marites Domingo.
Good afternoon, everyone. The first topic that I'm going to, that will be discussed is about anesthetic management for ERAS after elderly and high-risk patient. Our lecturer had her residency training in anesthesiology at the Medical City. She had her fellowship in surgical intensive care at the National University Hospital, Singapore. She had a diploma in regional anesthesia and pain medicine at the University of Montpellier, France. She is currently the section head in critical care anesthesia at the Rizal Medical Center. She is also the training officer in Adult Critical Care Fellowship Training Program at the Medical City, Philippines. Colleagues, ladies and gentlemen, help me welcome Dr. Emily Rose Neri.
Thank you. Thank you for that kind introduction. So good afternoon, everyone. I'd like to commend the people still left in the ballroom to listen to the rest of the talk. So it's always a pleasure and an honor to be invited, and this time to share with you updates and insights regarding the feasibility of an enhanced recovery program in the elderly and high-risk patients. So probably in our practice, we are seeing more patients coming in for surgery who are older and vulnerable, especially in cancer surgeries, no? And if you are currently practicing ERAS in your hospital, perhaps this talk will validate your clinical management. And if you are new to ERAS, you may be wondering if this is feasible for the elderly and high risk. So the topic is very relevant because worldwide, the trend is going up. We are seeing older patients, as I've said. The Philippines, compared to global estimates, is about 5%. So these are the learning objectives, my disclosures. So the concept of ERAS began more than 20 years ago. A paper published in 1995 reported a case series of about 8 patients who are 80 years old and above who underwent colon surgery and were discharged 2 days after. This was very interesting at the time because previous to this paper, most patients stay an average length of 6 to 10 days. The authors of this paper concluded that the rapid recovery was a combination of epidural anesthesia as a way to control pain, improve mobilization, and early nutrition. A couple of years after, a larger case series published by Kellett confirmed that this multimodal approach really translated to shorter length of stay. Around this time as well, other scientists were addressing perioperative care from a point of view of an endocrine and metabolic. They were discovering the effects of carbohydrate drink, especially to mitigate the effects of fasting, as well as identifying the roles of amino acids in the perioperative nutrition, inflammation, and protein metabolism. And so, in 2001, a group of mostly European doctors converged in London and decided to form a study group called Enhanced Recovery After Surgery. And the goal was to harness the data available at that time from evidence and literature and publish protocol aimed at reducing adverse outcomes and improving recovery. Since then, so the first published paper was on colorectal surgery in 2012, and since then, numerous publications have been published, literature has been published based from the original care elements. And currently, coming soon, we are waiting for 3 more guidelines, especially about emergency surgery. So that's something we are looking forward to. The success of an enhanced recovery program rests upon 3 pillars. The first is care protocol. The ERAS elements are assembled into a pathway as a basic standard of care, and they span across the perioperative journey. So the second pillar is the team. So you need a team. It is made up of healthcare professionals who are members from each unit involved in the care of the patient. This team holds regular meetings to review and audit patient care. And this brings us to the third pillar, which is the audit system. An audit system is a tool for continuous data-driven management. The system will give you insights on what is going on. It will allow communication among colleagues and as well as facilitate changes. So in the next part of the talk, we will navigate through the many factors affecting post-operative recovery and how it translates to ERAS elements. The most important, I think, challenge lies within a better understanding and control of undesirable perioperative responses that lead to organ dysfunction. And the primary mechanism is surgical stress response. It is made up of neuroendocrine responses that leads to a catabolic state. And second, the inflammatory immunological responses that occur in response to surgical trauma. Unfortunately, among the ERAS elements, only minimally invasive surgery can mitigate the inflammatory changes. But what can we do as anesthesiologists? There are other challenges that we can address, like pain. I think earlier, Dr. Hannah gave a very good talk about managing acute pain. But even though, like he said, even though there are numerous guidelines out there, we are still debating on what is the proper strategy when it comes to controlling pain, especially post-op. The focus is still on opioid rather than, it's mostly centered on opioids, right? And the goal is to use multimodal approach in pain management. Others like screening for cognitive function, blood management, and fluids as well. So this diagram shows you the typical ERAS flowchart and plots the journey of the patient as he goes through the different areas of the hospital, from outpatient to the pre-op units, the operating room, the post-operative recovery, and the ward. And each unit has its own focus. There are personnels and there are specialists. And each unit affects the ones to follow by their management choices. So for example, if a surgeon orders bowel prep the day before, you as an anesthesiologist may be faced with a dehydrated patient on the day of surgery. So these, for us, no, as anesthesiologists, the only opportunity to see the patient is within the perioperative phase, and rarely do we encounter patient, especially post-op. And so we have limited insight as to whether our anesthetic choices really made an impact on outcomes after hospital discharge. So if you go and look for the guideline, there are essentially 25 basic core elements, and across different specialties, there will be procedure-specific elements. So, is ERAS feasible in the elderly and high risk? The simple answer is yes. But there is a caveat, and which I will highlight later. So there are numerous studies that you can search and look, no? For example, between ERAS and a conventional care after colorectal surgery, yes. ERAS provides the advantage of lower post-operative morbidity and shorter hospital stay. in older elderlies, yes, a standard ERAS protocol is safe and feasible. And this has been shown in other specialties like orthopedics and cancer surgery. So from a pragmatic point of view, it is logical to see how ERAS, by mitigating the surgical stress response, benefits our elderly and vulnerable patient. However, and this is the caveat, we need to be more stringent in the pre-admission elements. So just to pause, I'm sure you're familiar with this statement. Life begins at blank, and you're supposed to insert a number depending on how old you are. And as we get older, the number keeps changing. So essentially, we are always waiting for life to begin. And how does that relate in this talk? So we know that chronological age does not translate to a vulnerable patient. So that's it. No? Age is really just a number. But there are things that are associated with aging. The two things are cognitive dysfunction and frailty. And this is what we would like to focus on, especially when we see patients coming in pre-op. The other thing is, the combination of rehabilitation and nutrition strategies together with screening. So the upper blue line, so this is a slide to show you that a fit older adult who is functionally independent at baseline, following an acute stressor like low-risk surgery, the fit elder decreases in his functional decline or abilities, but eventually returns quickly to baseline, right? But, however, if you have a near-fail individual, which is represented by the lower blue line and the purple lines, after experiencing a stressor like surgery, will deteriorate more and will not return to his baseline functional status. So what is the process that leads to frailty? So that's the important concept that we need to understand. It's mostly the interplay of genetics and environment. It provides us a physiologic reserve. And functional abilities are at their peak when we are young, right? And however, with normal aging, these reserves and functional independence change. Factors like physical inactivity, nutritional insufficiency, and declining mood. Cognition and social support can combine to hasten the decline. And an acute stressor, like for example, an illness, or in this case, surgery, a patient may be pushed beyond the threshold into frailty. Frailty is correlated with poorer outcomes, including falls, delirium, disability, increased care needs, hospital admissions, and morbidity. So these are the care elements arranged pre-op, pre-admission, pre-operative, intraoperative, and post-operative. And this is based on the most recent guideline on elective colorectal surgery. So again, we should focus more on the pre-admission, and I will go through each of them. So there are no ERAS guidelines specific to elderly and high-risk patients. Several studies have shown that ERAS principles work in the elderly, but we need to give more attention to pre-admission items, and the quality of evidence and recommendations are as follows. So anemia may be a risk factor for all complications. However, the administration of blood products perioperatively may also increase complications, right? So the WHO defines anemia based on gender. However, recent literature suggests that this classic definition of a woman being anemic at 120 grams per liter should be reviewed. And research should focus on women with hemoglobin values between 120 and 130 to determine if this has an impact on outcome. So, in essence, all patients, regardless of gender, presenting pre-op with a hemoglobin less than 130 should be targeted at assessment and the cause of anemia diagnosed and appropriate treatment initiated. Of course, smoking cessation and avoidance of alcohol is still part of that. But what I'd like to focus on is risk assessment. The ASA, the physical status that we use, is not enough to determine physiologic reserves in the elderly and high risk. So the recommendation is to add a comprehensive geriatric assessment, screen for cognitive decline, and screen for frailty as part of our pre-admission and pre-op assessment. So this is an example of a comprehensive geriatric preoperative assessment. So it's made up of a lot of elements. How about prehab? Prehab is a very weak recommendation. Essentially, prehabilitation is defined as a process in the continuum of care that occurs from the time of diagnosis until the beginning of acute treatment and includes physical, nutritional, and psychological assessment. So, in normal circumstances, after a stressor such as surgery, a patient will return to independent function, especially if there are no complications. However, if an complication occurs, return to independent function may be compromised. However, prehab will enable that patient to withstand the stressors by augmenting functional capacity, as we can see in this slide. But like I said, we need more robust data before we can fully recommend this in an ERAS protocol. So the key recommendations for the geriatric surgical patient: assess for impaired sensorium, especially delirium, cognitive impairment, or depression. Evaluate for functional impairment by asking about activities of daily living and instrumental activities of daily living. Screen for fall risk by asking about falls within the past 12 months, as well as difficulty with walking. Counsel, of course, to quit smoking and provide behavioral support to aid in the cessation of smoking. And physicians should use a validated tool to screen for potentially inappropriate medications during a medication review. So, going back to your institutions, to your hospitals, how do we begin navigating now or re-navigating our patient's perioperative journey? We can start with reading the evidence. A good place to start is the ERAS Society website. The guidelines are free to download, to read. You can peruse the procedure-specific protocols, which is appropriate for your practice. I would highly recommend reading the two-part anesthesia literature as a jump-off point. Second, ERAS principles work within a multidisciplinary and coordinated framework. So no single ERAS element alone can improve outcomes. ERAS is the ultimate team activity. I cannot overemphasize the importance of having each member aligned towards the same goals. And for the elderly, you might want to bring in geriatric specialists, a primary care, or a general practitioner if you don't have a specialist available. And finally, audit. You cannot, if you do not collect data, you don't know if you're doing the right thing, right? If you are ultimately aligned with the protocols. So utilize an audit tool. Your goal is to turn data into information, information into insight, and insight into action. So with that, I would like to end my talk, and thank you again for the invitation.
Thank you, Dr. Neri, for that very relevant and informative lecture. Now for our second lecture for this afternoon, it is on updates on the anesthetic management of burn victims. Our lecturer had her residency training in anesthesiology at the University of Santo Tomas Hospital. She had her clinical fellowship in neuroanesthesia and neurocritical care at Tan Tock Seng Hospital, Singapore. She is currently the residency training officer of the University of Santo Tomas Hospital Department of Anesthesiology and an assistant professor, University of Santo Tomas, Faculty of Medicine and Surgery, Department of Anesthesiology and Department of Basic Human Sciences, or LIPMED. He had her clinical, he is currently affiliated at the Chinese General Hospital and at Cardinal Santos Medical Center. Colleagues, ladies and gentlemen, help me welcome our lecturer for today, Dr. Sherry Ann Liquete.
So good afternoon. My lecture today would be on the updates on the anesthetic management of burn patients. So initial care of patients with serious burn injury presents challenges in the airway, vascular access, hemodynamic, and pulmonary support. As anesthesiologists or specialists in each of these areas, we should be familiar with the unique features of the perioperative management of burn patients. A burn occurs when heat, chemicals, sunlight, electricity, or radiation damage skin tissue. So the objectives of my lecture would be to present guidelines for the anesthetic management of burn patients, updates in the perioperative evaluation and preparation of burn patients, including all of the following. So here are the latest burn management guidelines worldwide. So in 2021, the review in the European Burn Journal compared 5 burn care guidelines internationally. So they found that there are no great disparities in the basic steps in burn treatment worldwide. But different burn associations focus on specific aspects concerning first aid procedures, transfer criteria to burn centers, treatment, and rehabilitation recommendations. In particular, for our setting, focus of the International Society for Burn Injuries focuses on includes resource limited settings. So burn management guidelines for resource limited settings. Initial management follows the same principles of care as those for any trauma injury. That is to say, prioritizing the airway, breathing, and circulation of the patient. Primary and secondary survey should follow the ATLS, or acute trauma life support principles. So we mustn't get distracted by the burn, because upon presentation, burn patients must receive a thorough evaluation. There is accompanying mechanical trauma that occurs in 40 to 40% of burn patients. So we should assess them using ATLS algorithm while also treating the burn injury, followed by a referral to a burn center if needed if the patient has any of the following: inhalation injury, burns to the face, hands, feet, genitalia, perineum, or major joints, or circumferential burns, and burns involving more than 10 to 20% of body surface area. So, as of 2017, here are the hospitals with burn units in the Philippines. 4 are in the NCR, 1 in the northern Luzon, and 1 in Mindanao. Okay. So, as anesthesiologists, we may be called to provide care and management of burn patients throughout the perioperative period as airway experts during a preoperative airway management and resuscitation, intraoperative anesthetic care, management of post-op pain in the ICU, sedation, and subsequent surgeries after the acute injury. Okay. These are the latest American and British updates on the anesthetic management of burn patients. Note that there is no set standard of care given by ASA or the British Association, but these are just guidelines. Okay? So when we are first called to manage a burn patient, here are the pre-anesthetic considerations. Here are major preoperative concerns for burn patients. At first, when you first see a burn patient, we must estimate burn extent and severity in order to calculate the total body surface area and calculate the fluid resuscitation rate. Okay. Here, there are many ways to estimate burn extent. We have the commonly used, or we have memorized this, the rule of nines. Then the rule of hands or palm, which the palm is 1% of body surface area. And there's another one, which in the next slide. Just note that accuracy suffers with the rule of nines when burns are scattered or irregularly shaped. Here is the suggested chart for patients with different proportions of burn in varying areas of the body. And this is also proposed to be used in pediatric patients, the Landbroder chart. Okay? A careful burn diagram should be completed at the time of initial evaluation, including burn, wound size, location, and burn depth. Okay. This is a sample chart, which most burn centers and emergency rooms have. And here is a classification of burn depth. So burn injuries involving 20% or more of total body surface area, or 10% or more in children and elderly, are more likely to result in burn shock. Hence, they must be referred to burn centers or need specialized care. Next, we calculate fluid resuscitation rate. There are several formulas to predict fluid resuscitation needs. Here are the formulas. Most frequently used is the Parkland formula, which we all know, which estimates 4 ml per body surface area multiplied by the patient weight and divided into 24 hours infusion. Okay. The Parkland formula was prescribed because the theory was that more rapid correction of the patient's extracellular sodium deficit during shock would result in better outcomes, better perfusion. However, now they found that there's a concept called fluid creep, which is a tendency to give excessive volumes of fluid for resuscitation, which has occurred in some burn patients with complications. So there's a tendency for Parkland formula to have fluid creep. Okay, and fluid creep also involves diluents used for infusion, such as pressors, opioids. So we must take note of all these. So they came up with the Brooke formula, modified Brooke formula, which predicts a more conservative volume for resuscitation, which is 2 ml per kilo of body surface area of lactated ringers. They also recommend colloid in the form of plasma, which we'll discuss later. Then, the rule of 10 for adults was developed by the U.S. Army Burn Center, which estimates the initial infusion rate as 10% body surface area with additional 100 ml per hour for every 10 kilogram of body weight above 8 kilograms. So they found that this reliably produces an initial rate that falls within the Brooke and Parkland recommendations. Okay, so those are the 3 commonly used formulas for fluid resuscitation for the first 24 hours. In 2008 and 2019, the American Burn Association published the guideline formula of 2 to 4 ml per kilogram per body surface area based on the modified Brooke and Parkland formulas. And they incorporated in 2019 the rule of 10 for adult burn resuscitation as part of disaster management. But the key here is that these are just estimates, and infusion rate must be adjusted hourly based on individual responses, physiologic response. Now, there are adjuncts to fluid resuscitation. There is a proposed colloid protocol for failed or runaway resuscitation, meaning if you infuse with fluids. This is utilized by the U.S. Army Institute of Surgical Research Burn Center. So several recent studies have suggested that plasma is useful as a colloid, plasma as a colloid is useful in decreasing total fluid administration, thereby reducing the risk of fluid creep, which may result to edema formation, compartment syndrome, and compartment syndrome. So this is useful when started as an as-needed basis only after the post-burn, first post-burn day. So not during the first 24 hours. Okay. Sorry. There's little consensus with respect to indications or dosing, and the use of plasma has not yet been demonstrated to have a mortality benefit. So studies are still ongoing. So here, this is just an example of a burn resuscitation protocol in a burn center in Scotland. So burn centers usually have their own protocols, but these protocols would not differ significantly from each other. Okay. So the experts have no consensus on which formula or which fluid is best. However, there is an agreement on two important principles. First, the minimum amount of fluid required to maintain organ perfusion should be used. Okay. Then the fluid infused should be continuously titrated to avoid both under and over infusion. Most centers titrate with fluid with urine output and clinical signs. A urine output of 0.5 ml per kilo per hour is considered adequate in adults. And fluid resuscitation formulas are useful as starting guidelines and not absolute protocols for resuscitation. Note that burn depth, inhalational injury, patient age, delay in resuscitation, and increased opioid analgesics may increase fluid requirements during burn resuscitation. Okay, after assessing percent total body surface area and computing for fluid requirements, we next assess the airway for need for resuscitation. So during the acute phase of injury, this is the usual reason for referrals to us anesthesiologists. The following are the current recommendations as indicators for intubation. Burn size more than 40% regardless of location, total body surface area. And the lower threshold if the burns are deeper. Burns to the head and mouth with significant smoke inhalation injury, delay in transfer to a burn center or delay in transfer to the emergency room or hospital, altered level of consciousness, and change in voice or hoarseness. Now, when in doubt, we should perform endotracheal intubation. Okay, all right. So next, after assessing the need for invasive airway access, we need to assess the cardiovascular status of the patient preoperatively. So when you first see a patient, note the time elapsed since the burn. When is the patient referred to you? Because during the first 24 to 48 hours of burn injury, this is called the low cardiac output phase or the ebb phase. Pathophysiologic changes in the early phase is characterized by decreased cardiac output and decreased blood flow to all organs. And this is due to loss of intravascular volume, direct myocardial depression, increased pulmonary and systemic vascular resistance, and hemoconcentration. This can lead to metabolic acidosis, and which might have an effect on your anesthetic plan. If the patient is referred to you after 48 hours or 72 hours after the burn, this is characterized by high cardiac output phase or the recovery phase or flow phase, characterized by hypermetabolism, increased oxygen consumption, increased carbon dioxide production, increased cardiac output, with enhanced blood flow to all organs, including the skin, kidney, liver, with decreased systemic vascular resistance. In general, while assessing intravascular fluid status, the goal of fluid resuscitation is to maintain organ perfusion at the lowest possible cost, which relies on careful hourly titration of the infusion rate to meet individual patient needs and no more. Okay, so the ASA recommends the following. This is in the journal Anesthesiology in 2015. Recommend the following physiologic endpoints. So urine output at 0.5 to 1 ml per kilo per hour. For children, it's 1 ml per kilo per hour. Blood pressure, heart rate. But heart rate may be variable with patients in the hypermetabolic state to be tachycardic. Then urinalysis, invasive technique using TEE, and base deficit. Okay. Right. So next, we assess for pulmonary abnormalities because burn patients with smoke inhalation injury have higher likelihood of pulmonary complications because the inflammatory response produced by the chemicals in the smoke can induce. So they have high risk for bronchospasm, which may require aggressive bronchodilator treatment. Systemic and respiratory effects of chemicals result in ciliary dysfunction, thickened secretions, leading to hypoventilation, loss of hypoxic pulmonary vasoconstriction, pulmonary hypertension, atelectasis, VQ mismatch with shunting. A restrictive, so these are the respiratory patterns of injury resulting from burns. A restricted lung defect with impaired ventilation can result from severe chest wall edema when there are circumferential burns in the thorax, or from scar formation, which causes restrictive lung pattern injury. Patients may develop respiratory failure due to loss of chest wall elasticity and decrease in effective lung volumes. So how about intraoperatively? So problems may arise in the placement of the standard ASA monitors. So for the ECG, we might need the burns in the torso and upper extremities prevent adhesive ECG lead placement. In these cases, we might need needle electrodes or surgical stapling of the electrodes. Sites for pulse oximeter probe application may be limited in patients with extensive burns to the face, neck, extremities, or if there is a planned skin graft in those areas. Okay? So therefore, ideally, we should have probes for multiple sites. Okay. Also, patients with carboxyhemoglobin or CO, carbon monoxide poisoning in the acute burn injury phase, the pulse oximeter may be falsely elevated. Just take note of that. And then blood pressure placement may be, BP cuff placement might be hard. So we might need intra-arterial catheter placement. Okay. Aside from physiologic variables and endpoints such as urine output and blood pressure, patients with extensive injuries who will undergo major surgery or who are admitted in the critical care unit may require hemodynamic monitoring. Dynamic hemodynamic parameters are recommended, and a variety of cardiac output monitors are available. Most are invasive and available only in specialized centers. So there are some guidelines that recommend dynamic hemodynamic monitoring using the arterial pressure waveform analysis, which is a minimally invasive and economical technique of potential benefit. Okay, so here we use the arterial waveform to look at systolic pressure variation, pulse pressure variation, and stroke volume variation. However, take note there are no large prospective randomized trials which have assessed this technique in burn patients. Here, this is what we call when the patient is fluid responsive curve, and this part when there are no changes with respiratory, with the respiration, the patient is not volume responsive. Okay. Right. So aside from determining hemoglobin, coagulation factors, electrolytes, some centers measure lactate, and because elevated lactate levels are an important indicator of reduced global tissue perfusion. In centers when lactate is not available, other centers use base deficit measurement as an alternative to lactate levels. Although increasing serum lactate levels or sequential ABG indicates persistent poor perfusion, these lab values do not provide information on intravascular volume status because they're just intermittent measurement and not continuous. Blood glucose monitoring is also recommended because patients are prone to both hypo and hyperglycemia. Okay. So how about intraoperative airway management? So burn patients, especially with those with burns in the upper extremity, upper airway, there's a high probability of difficult ventilation and intubation, depending on the location of the burn. So ABA recommends following the current ASA difficult airway algorithm. After intubation, securing the endotracheal tube for patients with burns in the face can also be challenging. So techniques to achieve adequate fixation of the tube include cloth tape around the tube and tying it around the head with tracheal ties or around the neck. Also, you can also fix them intermaxillary or suture them, right? So we follow still the ASA difficult airway algorithm, and fiber optic intubation may be indicated. So what is the decision? How do we decide for algorithm for fiber optic intubation? Here's a recommendation. First, examine the face and airway, and then determine if there is tightness on the lips and tissues or moderate tightness to determine if you would need fiber optic intubation, the left side of the algorithm, or you can do the traditional technique if there is only mild to moderate tightness of the lips and mouth. So how do we decide which patient will be under awake fiber optic or asleep? Here. So from the Cambridge University, they decide whether if the patient is cooperative or uncooperative. If the patient is cooperative, we can do awake flexible bronchoscopic intubation. On the other hand, if the patient is not cooperative, we induce anesthesia with preservation of ventilation and proceeding with flexible. So in short, no paralysis. Then proceed with flexible bronchoscopic intubation. So all of these are available online, the algorithms. Okay. Now, how about anesthetic management? So burn patients have altered pharmacokinetics and pharmacodynamics, depending on the timeline of injury. So during, as I discussed earlier, they have the acute phase, 24 to 48 hours, or the patient can be in the recovery phase after 48 to 72 hours. So during the acute phase, there will be decreased induction need for the induction dose due to decreased intravascular volume, probably sepsis, and burn severity, which may lead to hypotension. So you should have cautious administration of induction agents. Even ketamine or etomidate may still lead to hypotension. Now, once you are in the recovery phase, dose of anesthetic agents are increased because of increased hepatic and renal clearance, including increased dose of neuromuscular blocking agents. Take note, no succinylcholine is recommended after 48 hours. Okay. So during the first 48 hours following a major burn, succinylcholine may be used, but must be avoided from 48 hours to at least 1 year after the injury due to risk of acute severe hyperkalemia because of the upregulation of immature extrajunctional nicotinic acetylcholine receptor subunits. Then we recommend close monitoring of the degree of muscle relaxant, neuromuscular blockade, because there's resistance to muscle relaxants with a peak at 5 to 6 weeks. Also, they also wear off earlier. Okay? So monitoring is recommended, and no adjustments and reversal agents needed. The choice of maintenance technique. So it's still recommended, inhalation-based or balanced technique is still recommended, with total intravenous anesthesia being recommended for patients who require special ventilator settings, such as high-frequency ventilation. A retrospective study in burn patients undergoing debridement and grafting compared inhalation versus ketamine propofol-based TIVA technique with an opioid showed overall outcomes and use of vasopressors were similar. So no difference. How about intra-op fluid management? In general, intra-op volume losses are added to the formula-guided resuscitative fluid volume. And it is estimated that 2.6% of adult patients' total blood volume, or 3.4% in children, is equivalent to 1% burn wound excised or autograft harvested. So that's how to estimate. Okay, next. Intravascular volume and hemodynamics are maintained to optimize end organ perfusion and prevent burn shock. American Burn Association recommends, as mentioned before, urine output of 0.5 ml per kilo per hour for adults and more than 1 ml per kilogram per hour for children. Although best endpoints for adequacy of resuscitation are not conclusively determined. Okay. How about for transfusion? In one randomized multi-center trial, a restrictive hemoglobin transfusion with set threshold for transfusion at hemoglobin 7 to 8 resulted in fewer transfused units of PAC-RBCs compared with the liberal strategy at 10 to 11 hemoglobin levels. Secondary outcomes that included infection, organ dysfunction, and mortality did not differ between restrictive and liberal transfusion groups. This was in 2017. So the authors recommend restrictive hemoglobin transfusion strategy, but individualized to physiologic endpoints, of course. Then, tranexamic acid may improve hemostasis in burn surgery, as in other types of trauma injury. Okay, a single dose given before surgical incision in burn patients noted reduced blood loss, while side effects such as thromboembolism were not noted. Okay. How about for post-operative management? So this is towards the end of the lecture. All aspects of burn injury, including dressing changes, excision and grafting procedures, physical therapy, line insertion, are associated with pain. So there's ongoing background pain, procedure-related pain, and chronic pain, which may be aggravated by anxiety. So pain management can be challenging, and it is often reported by patients to be inadequate. So currently also, there's inconsistency in practice standards. So the pain in burns has hyperalgesic and allodinic components. So they recommend continuous pain management and intermittent sedation for bedside procedures are treatment priorities in the post-operative period. There is also a tendency to develop either acute opioid tolerance or opioid-induced hyperalgesia, which may develop even over a short period of time. In particular, in patients with pre-existing opioid abuse, it may develop as early as only 2 weeks of uninterrupted opioid use. So in 2020, the American Burn Association guidelines on the management of acute pain in the adult burn patient updated their review from 14 years ago to 2020 and concluded that there is insufficient data to fully support any high-level evidence-based standards of care. So they just combined all available data with expert opinion and provided several guidelines for the assessment and management of pain during acute burn hospitalization. Okay. With careful attention being paid to managing analgesia and sedation so as to provide appropriate analgesia while avoiding hemodynamic compromise, delirium, and oversedation. So the following pharmacologic and non-pharmacologic strategies were reviewed by the ABA, and they recommend use of long-acting opioids may be helpful in some burn patients. They recommend the use of multimodal opioid-sparing techniques, including non-opioid analgesia, and local regional anesthetic techniques whenever possible. Ketamine, dexmedetomidine, and clonidine, and gabapentin can be used as adjuncts. Non-pharmacologic methods such as hypnosis, cognitive behavioral therapy, and virtual reality are the most studied techniques. So, to summarize, ABA guidelines require regular pain assessment, individualized opioid therapy, use non-opioid analgesics and adjuncts, incorporate regional anesthesia techniques, and non-pharmacologic techniques. Here's just a sample from the Anesthesiology 2015. But note that now the first line for sedation in both ventilated and non-ventilated patients is dexmedetomidine, not midazolam anymore. Okay. So to summarize this lecture, for patients who are referred to you for anesthetic management of burns, we should first do primary and secondary survey following the ATLS principles. Major burns require a dedicated multidisciplinary team for adequate management. For airway management, we still follow the ASA difficult airway algorithm. The goal of fluid resuscitation is to maintain organ perfusion with careful titration to meet individual patient needs. Crystalloids is still the fluid of choice for resuscitation, with transfusion following the restrictive transfusion strategy. For monitoring, dynamic hemodynamic parameter monitors are recommended. Then for post-op management of pain and sedation, ABA guidelines on the management of acute pain in burn injury patients are recommended. So this is a summary found in Anesthesia and Intensive Care Journal on the preoperative, intraoperative, and postoperative considerations for managing a burn patient. Here are my references. So I know that this lecture focused mainly on management of adult burn patients, but there is now an update, if you're interested, in the management of burn patients in pediatrics, published in 2020. So it's also found online. Okay? So thank you for your time, and thank you to PSA for inviting me to lecture in the convention. Okay?
Thank you, Dr. Aliquete, for that very comprehensive and detailed lecture on anesthetic management for burn victims. We will now be having our open forum. So any question from the audience, please? There are microphones there, out there. You can use them. Walang question? Okay, thank you.
This is for Dr. Liquete. Dr. Liquete, I was wondering, is she on? Okay, I was wondering if you can treat the metabolic acidosis aggressively, or do you wait for the fluid correction? Oops.
Oh, sorry. Yeah, 2 years na nakakalimutan ko pa rin mag-unmute. Anyway,
Okay,
may I
no
ask if you meant giving like sodium bicarbonate?
Yes,
ganyan?
do you
Or-
have to treat the metabolic acidosis aggressively, or can you?
Well, first we need to treat the fluids, and then may or may not, depending if you need blood. And then if you still cannot, those are just recommendations. But in cases that are severe, like below 7.2 pH below 7.2 and symptomatic, like patients developing arrhythmias, like that, we can treat with temporarily with sodium bicarbonate. But first, it's recommended to correct first the fluid requirements, or patient may need blood transfusion, or if the cause of the acidosis is perhaps sepsis, we should treat the cause.
Okay, thank you so much.
And also, yes, all right, Lisa.
Thank you.
Okay, thank you for that. Any more questions from the audience? Okay, here's a question in the chat box addressed to Dr. Neri. What if the targeted hemoglobin is not met? A hemoglobin of 13 is not met in both genders. Thus, this patient will require transfusion or medical management at the least to increase hemoglobin to its optimum.
Okay, thank you for that. Thank you for that question. So I think the take-home message with regards to management of anemia, especially for elderly patients, is that, okay, one, you need to screen, and you need to not be complacent about the levels of hemoglobin. The problem, I think, most women, a quarter of us, present with iron deficiency anemia as the cause. And that can be corrected, right? If you have the luxury of time, if you've seen this patient, coming in for elective surgery, then you have time. You can either correct through giving oral iron supplements, and if the patient cannot tolerate that, you can use IV sucrose. So those are things that you can do. However, having said that, whether or not correcting hemoglobin levels to 130 pre-op really translates to improve outcomes, we don't know yet. The data is still not, very robust when it comes to that aspect. But again, I guess you should look for the cause of the anemia pre-op if you have time.
Thank you, Dr. Neri. Another question for Dr. Liquete in the chat box. How do you suggest what you noted as inconsistent in burn pain management across all institutions?
Hello? Can you hear me po?
Yes, yes.
Alright. So anyway, based on research and existing studies, the reason for inconsistencies are because there are very few studies made regarding this matter. So regarding burn pain management, and also the author cited like difficulties because of the the complications I mentioned earlier, like hyperalgesia and the psychiatric component. And so therefore, most institutions make their own pain guidelines. And then I guess this is sort of beyond the scope of my lecture, but I would recommend, like, for example, per institution, right? Not institution, burn center. Per burn center, you can have your own pain guidelines. And then I think this would require a multi-center study because of that. Also, yes, the inconsistencies in burn pain management will be because of the difficulty of managing pain in these population.
Okay, thank you. Another question from the audience? Okay. I have a personal question with Dr. Neri. What about, how do you deal with surgeons who are sinauna? Yung they are not into ERAS.
Do not accept their case, na joke. No, seriously, it's difficult. It's really difficult. But I guess to encourage us, the ERAS is not only being introduced in our practice alone. There are efforts in other specialties to educate other doctors on the advantage of ERAS. So eventually, we hope it will translate to better, care for patients. They said that it takes about 15 years for scientific progress to translate into healthcare. It's been more than 20 years. since ERAS was, introduced to us. There's a lot of challenges really involved. And implementation apparently is one of the key factors, no? Nahirapan tayo implement. We have all the guidelines are free. We have a care team. We have people who are willing to try it. But the problem lies mostly leadership, push, at saka implementation. And last, audit. Most of us think we're practicing ERAS, but sometimes when we do audit, we realize we're not really doing ERAS. No? So ang take-home message doon, audit, whether or not you use a paid tool or not, audit your data, audit your practice, really see if you're doing what you say you're doing.
Thank you, Doctora. Okay, sorry.
I just wanted to add, and I think I forgot to highlight this in my talk earlier about fluids in ERAS. In the beginning, when the guideline came out, there was a trend towards restrictive. Remember, parang mas restrictive tayo when it comes to fluid management. Now, recently, data has shown that because we were being too restrictive, it's swinging the patient towards the other end. No, you have issues of AKI after surgery. So now the recommendation is to aim for a positive fluid balance between 1 to 1.5 liters post-op. So that's okay.
Okay, thank you, Dr. Neri. We have another question for Dr. Liquete from the chat box. Are there exceptions in using succinylcholine in the first 48 hours in burn patients?
Sorry, can you please clarify po? First 48 hours, exceptions like, before 48 hours, most guidelines recommend that, not recommend, in the book, and also theoretically, before 48 hours, we can still use, first 48 hours from the burn, we can still use succinylcholine. But after 48 hours, and up to as much as 1 year, and in some books, the older ones, 2 years, we cannot use succinylcholine because of the upregulation of the extrajunctional NMBs. Extrajunctional receptors. So anyway, by exception, did you mean during after 48 hours? No, there's no exception. It's scary because you might induce a hyperkalemia and lethal arrhythmias. Did I understand your question correctly po?
Sorry, it's an anonymous attendee, or is he around? So if there's none, then I'll go to the rest of the question. Do you use Tiva or inhalational anesthetic in burn patients?
Well, I haven't had a burn patient the entire COVID pandemic, no? But maybe because patients are, all the people are inside. But anyway, studies show that we can use any technique. There's no difference based on data. No difference between the paper I read was propofol with ketamine, and versus sevoflurane base. No difference in mortality or morbidity. Then also in pain analgesia. However, for myself, I would use either. But if an airway procedure would be required, of course, the Tiva would be better, so as not to, because of the requirements of surgery, for if it will be an airway procedure.
Okay, thank you, Doctora. Question for Dr. Neri. How would you recommend to implement ERAS strategies in centers where there's no institutional ERAPS protocols. They are not widely established. Different services have their own protocols, pre-op and post-op.
So you're saying there's no organic pathway currently in the hospital, right? Because the guidelines are available, and it's all about not really implementing, but using them as a guide to create your own pathway. So the start will be to find the champion, really. To find that one person or group of people who are willing to start an ERAS program. Start from there. And then let us know. The society is always looking for hospitals, for physicians who are willing to start their ERAS programs.
Okay, thank you, Dr. Neri. Another question for Dr. Liquete. What are your anesthesia induction modalities for a burn patient scheduled for surgery?
Induction. Oh, well, depends on what kind of surgery. As I mentioned in the lecture, for burn patients, it can be acute, like the acute injury. For example, patient has concomitant fracture or immediate debridement is needed. Or will this be an airway access surgery, or will this be reconstructive, like in the future, after the acute phase and after recovery, and the patient is scheduled to undergo series of reconstructive surgeries. But in general, the usual, what we call, of course, there's no usual, but what we call our usual would be, and also, of course, it depends on the patient's hemodynamic status. If a patient is usual burn patient, of course, after going through the preoperative assessment like that, induction would be, if I was going to do inhalational based anesthetic, it will still be the usual IV induction. And then for TIVA, same thing, but of course, non-depolarizing muscle relaxant. But if it was going to be a bedside procedure, like change of dressing, painful bedside procedures, can just opt to give ketamine, like that, as an analgesic, or TIVA based, because bedside procedures, usually we don't have access to inhalational agents. If I understood the question correctly.
Okay. Thank you, Dr. Liquete. Then another question for Dr. Neri. In ERAS protocol, where do you inject your local anesthetic post-op? IM or sub-Q? Perhaps wala na siyang IV access. So, and where do you inject your local anesthetic post-op?
Is this for multimodal pain management? Okay, all right. Local anesthesia. Okay, so again, no, there are different approaches to pain management. Usually, the choice is procedure specific. For example, in minimally invasive surgery, you use different strategies to address pain. And let's say for LAP, I would ask the surgeon to infiltrate local anesthesia subcutaneously. Is that the question? Now, another emerging concept is the use of regional anesthesia, especially nerve blocks, and I think one of our speakers will talk about that. But that is an aspect that we should all try to explore, try to learn it so that we can apply it, in our pain management strategies.
Okay. Thank you for that answer, Dr. Neri. Another question, last question for Dr. Liquete. Just in case the use of succinylcholine is unavoidable, like in reintubation, can hyperkalemia be just treated with glucose-insulin combination, hyperventilation, and other means?
Well, I've never encountered, to be honest, I wouldn't dare, because I might be the so-called last touch anesthesiologist, and nowadays I wouldn't be so scared naman for reintubation if there's no airway. For example, reintubation, do you mean po difficult? If it is not a difficult airway and paralyzing the patient is not an issue, no difficulty in ventilation or intubation, I would opt to use rocuronium in a higher dose, in a 1 milligram per kilogram. Anyway, I'm not, there's already, I wouldn't be as worried now that we have Sugamadex to reverse the long-acting, to reverse rocuronium. I wouldn't dare use succinylcholine for fear of inducing sudden death or anything like that. And I've actually never encountered, during my research for this lecture, I haven't encountered anyone who mentioned this practice before of using succinylcholine for these patients. Personally, I wouldn't dare. Now, if this is a difficult airway, I wouldn't paralyze at all. If I have no, I have no backup plan for the emergency reintubation. So just sedate the patient and then intubate without paralysis. Yes.
Okay. Thank you, Dr. Aliquete, for that. Okay, since that's the last question, I would like to commend both the speakers as well as the audience for a very interactive open forum. The last topic that I'm going to present is a sponsored lecture by Aspen entitled The Resilience of Regional Anesthesia in the Next Normal. Our speaker is the section head in the Regional Anesthesia Department of Anesthesiology in the Medical City. She is the training officer of Regional Anesthesia Department of Anesthesiology, the Medical City, and a consultant in the Department of Anesthesiology, the Medical City. She is also a member of the Manila Academy of Regional Anesthesia. She is known to be exhibiting an exceptional drive to practice and propagate the art and science of peripheral nerve blocks. Ladies and gentlemen, help me welcome Dr. Maria Natalia Montemayor.
Good afternoon. I'm Dr. Natalia Montemayor. Today, we reflect on how resilient have we been during the COVID pandemic. We all had new experiences, but what are our future plans? These are my disclosures. Being an educator, I have no conflict of interest. Looking at this chronicle of evolution of regional anesthesia, generally, we note 3 bumps that clearly show progress in the use of regional anesthesia. The first was the advent of epidural catheter, then the use of ultrasound, and then in 2020, COVID transformed healthcare because patients needed access to regional anesthesia. Sometimes the world needs a crisis, turning challenges into opportunities. John F. Kennedy, Albert Einstein, Plato, and the Chinese all said the same thing. The COVID crisis bolstered regional anesthesia. It has created new opportunities in education. Safety has traditionally been defined as freedom from accidental injury. In contrast, resilience is the ability to adjust one's functioning before, during, or following events, and thereby sustain required operations under both expected and unexpected conditions. Safety is incorporated in resilience. These are my learning objectives. On the 2nd anniversary of the COVID-19 pandemic, we reflect on what we have learned. This has been covered earlier by previous speakers, that the post-operative mortality among COVID-19 patients is 20% and post-operative ICU admission rate of 15%. And post-operative pulmonary complications occur in half of patients with perioperative COVID infection with an even higher mortality for those 70 years old and above. Shown are the benefits of regional anesthesia compared to general anesthesia in the context of the coronavirus. Regional anesthesia preserves respiratory function, making it the first choice for a COVID patient needing surgery. These are the general recommendations for performing regional anesthesia. Regional anesthesia could be neuraxial or a peripheral nerve block, whichever you are comfortable performing. But avoid blocks that can further compromise respiratory function that may already be affected. For upper extremity surgery, axillary or infraclavicular blocks are good choices in avoiding respiratory compromise. Regarding adjuvants, balance the effects with their side effects. The use of a perineural catheter should be determined on a case-to-case basis. The risk of immunosuppression with adjuvants such as dexamethasone and side effects such as sedation, bradycardia, or hypotension from clonidine or dexmedetomidine should be weighed against their benefits. And many more large studies continue. Information, we continue to ask questions in our quest for better evidence to inform our decisions. We support the use of regional anesthesia as the first choice anesthetic, but we believe the decision to choose regional anesthesia must remain as patient-centered. The concern on block failures, avoiding the need to convert into general anesthesia may be solved by having only the experienced practitioners perform the block. To determine the readiness of trained residents to do regional anesthesia during COVID, Vincent Chan and his colleagues have enlisted the minimum knowledge and skills required. General anesthesia are for patients with oxygenation levels lower than 93% or dyspneic, for early airway support. Otherwise, consider for regional on patients who are septic but stable, hypotensive, normal on point of care ultrasound. Regional anesthesia may be central neuraxial block or a peripheral nerve block, whichever you're comfortable performing. The following are contraindicated unless the patient is in early sepsis, then a low-dose spinal anesthetic will do. The patient's informed consent is important, not to be biased. Should the patient choose general anesthesia, that should not be denied. However, strongly consider regional anesthesia for high-risk patients. This is a journal regarding the public's fears and perceptions of regional anesthesia. Out of 1,200 people surveyed, 27% of respondents were very concerned about permanent paralysis, back injury, pain, and the prospect of a needle in the back. But in 2021, patients' preferences changed. Their choice for regional anesthesia increased from 43 to 85%, among surgeons, 28 to 56%, and from 75 to 78% among anesthesiologists. The highest increase was seen after blocks, followed by spinal with or without blocks. The conclusion is to focus on upskilling on non-regional anesthesiologists on high valuable Plan A blocks to utilize and increase regional anesthesia use even after the pandemic. 3 regional anesthesia organizations, the American, European, and UK Societies of Regional Anesthesia, captured responses from 73 countries. Half of the respondents expanded their practice of regional anesthesia during the first surge. Now, what are the core reasons for choosing regional anesthesia? This is an extensive literature regarding outcome following peripheral regional anesthetic techniques. The great majority of the blocks reviewed were associated with a combination of reduced post-operative pain, reduced opioid consumption, increased patient satisfaction, improvements in post-operative pain and surgical pathway efficiency, and complications were rare. High level of satisfaction. This study, including more than 6,000 peripheral nerve blocks, documented having 90% high levels of patient satisfaction, especially with information provided during the anesthesiologist-patient interaction. 94.6% were willing to undergo a repeat peripheral nerve block in case of future surgery. Shorter length of stay. Among 56,000 patients undergoing hip fracture surgery, they found an association between greater use of regional anesthesia and the reduction in length of hospital stay after a hip fracture, but not necessarily associated with statistically significant differences in mortality. Fast-track recovery, also known as accelerated or enhanced recovery programs, have been developed with the aim to reduce perioperative surgical stress, facilitating patients' recovery after surgery. Regional anesthesia, whether conduction blockade or peripheral nerve block, or infiltration of local anesthetics, are associated with several recognized physiologic advantages. Reduced requirement for transfusion. In an Australian guideline on patient blood management, there is a reduced blood loss under neuraxial block. A meta-analysis found that neuraxial block reduced blood loss by 100 to 200 milliliters and a reduced transfusion rate from 33 to 12%. Decreased post-operative delirium. This is a systematic review and the meta-analysis on regional anesthesia techniques and post-operative delirium. Delirium is reduced only if used during the post-operative period because intraoperatively, other factors influence this outcome. Green general anesthesia is a coined term for the non-polluting benefits of regional anesthesia. Avoiding volatile inhalational agent use gives us an opportunity for anesthesiologists to help prevent global warming. However, another study says that while using oxygen during spinal anesthesia contributes to the carbon print, re-sterilizing reusable items contributed substantially to the carbon dioxide equivalent emissions of both spinal and combined anesthesia, as well as the warmer. This is another study in Melbourne saying that all anesthetic coaches had similar carbon prints. Sevoflurane was a significant source of the carbon. Recommendations: the final carbon footprint is determined by using low-flow anesthesia, total intravenous anesthesia, reducing single-use plastics, reducing oxygen flows, and collaborating with engineers to augment energy efficiency and renewable efficiency. During the 90s, there was a liberal use of opioids for the treatment of non-cancer pain. Therefore, the opioid crisis happened. This article was just released last month. The number of deaths is highest ever in 12 months. Attention was focused on who are those prone to misuse and abuse opioids. How can regional anesthesia help? This is an old journal from 2001. Going back to the basics of the pain pathway, interventions can modulate activity at each point, and local anesthetics play a major role. This study was done among young athletes who underwent anterior cruciate ligament reconstruction. Two groups were studied, one with continuous peripheral nerve block with elastomeric reservoir, the other a single shot nerve block. The average utilization was only 1.3 pills of hydroxycodone acetaminophen combination with both groups, even less with the continuous peripheral nerve block group. Enhanced recovery after surgery has emerged as one of the strategies to improve value and quality of surgical care adopted for surgical procedures. The goal of this article was to outline important components of opioid-sparing analgesic regimens. Regional anesthesia is now being considered in place of opioid dependence. As a significant tool in the enhanced recovery, it is not so much in the field of play due to a lack of exposure in knowledge, training, and block performance. So what are the key findings on the application of regional anesthesia on COVID as well as in non-COVID patients? At the beginning of the pandemic, choosing a technique was only an extrapolation of known benefits of regional anesthesia to the healthy population. Minimal data was available to guide our decision making, only expert opinions, and there's no definitive data that general anesthesia is safer than regional anesthesia or that regional anesthesia brings about better outcomes. Such as this group of Italians said that regional anesthesia can be the sole technique providing anesthesia care whenever possible in trauma patients who are usually the elderly, fragile, and they sustain a fall, get a humeral fracture, and are suspected of COVID-19. When doing an interscaling, it can miss the C8 to T1 nerves. Thus, a supplementation of a supraclavicular block is done, and so came the hybrid technique. Karmakar shared this experience, which is an alternative technique called the selective trunk block. It is a two-injection technique. The first injection is between the superior and middle trunk using a small volume so as to spare the phrenic nerve. The second injection is at the corner pocket of the supraclavicular fossa. Small volumes of local anesthetic can produce anesthesia of the entire upper extremity from C5 to T1. This has become the one-size-fits-all or all-purpose technique for upper extremity surgery. The Indian Society shared the experience of ultrasound-guided brachial plexus block via various approaches in 22 suspected COVID-19 patients who sustained upper limb fractures. Details of the types of block are shown. Ultrasound-guided axillary block is a simple, safe, effective, and time-saving technique. In this randomized, single-blinded study, the authors compared a standardized perifascial technique and a selective perineural technique. 42 patients scheduled for elective hand surgery were randomly assigned to the two groups. This is the perineural group, identifying each nerve, which are the radial, the median, ulnar, and musculocutaneous nerves, versus the perifascial along the latissimus dorsi and the superficial axillary fascia. The conclusion, perifascial is faster than the perineural. In Italy, major trauma and neuroemergencies were performed on all elective and non-deferrable surgeries in COVID-positive and negative patients from March 1 to December 31, 2020. Regional anesthesia was performed in 97% of all the orthopedic patients, and there were no complications. These are up-to-date, evidence-based recommendations on the safe performance of regional anesthesia in the light of COVID. This summary of publications are expert opinions, case reports, case series. These are up-to-date, evidence-based recommendations on the safe performance of regional anesthesia in the light of COVID. This summary of publications are expert opinions, case report, case series which were almost all central neuraxial blocks. Emphasis importance to use safe practices, choose the right procedures, and be vigilant. On the use of continuous perineural catheters for COVID patients, single injection nerve blocks only last for hours, while continuous peripheral nerve blocks can last days or longer. The Bridma can be done bedside and be discharged earlier. Since majority of the emergency cases were hip fractures, I would like to compare the effectiveness of regional anesthesia versus general anesthesia. What was observed was that probably regional anesthesia is better than general anesthesia, but in 2007 to 2008, a large observational data showed that regional anesthesia reduced pulmonary complications and death by 25%. Moving forward to 2009 to 2015, this investigation was done to reduce selection bias. 96,000 patients confirmed that regional anesthesia yielded a better outcome in terms of a 30-day mortality than did general anesthesia for elderly patients undergoing surgery for hip fracture. Furthermore, delirium requiring pharmacological intervention was significantly lower in patients who received regional anesthesia. There was a lower incidence of ICU admission, ventilator care, hospital costs and complications, including pulmonary embolism and cerebral hemorrhage. Then this is an even bigger study from 1946 to August 4, 2020. This is an evidence-based international expert consensus regarding the impact of peripheral nerve blocks used in total hip and knee arthroplasty surgery. Using the PRISMA flowchart, they investigated the impact of peripheral nerve block utilization on major complications. Conclusion: the consensus group recommends peripheral nerve block use in the total hip and knee arthroplasties for improved outcomes, except when contraindications preclude their use. Evidence level, moderate. Recommendation, strong. This is an updated systematic review from 2005 and 2010 to develop recommendations for the management of postoperative pain after primary elective total hip arthroplasty, randomized controlled trials, and meta-analysis published between July 2010 and December 2019. Out of 108 randomized trials and 21 meta-analyses, the summary of the regimen included a peripheral nerve block, which is the fascial yaka or local infiltration analgesia. They do not recommend epidural analgesia. What's new for other specialty surgeries are the fascial plane blocks. Cardiothoracic surgeries need optimal analgesia as a vital part of enhanced recovery. Traditionally, analgesia in these surgeries has depended on large doses of intravenous opioid. Fascial plane blocks of the thorax and chest wall have been shown to be of benefit for a variety of surgical procedures. Another new technique is the erector spinae block. This meta-analysis demonstrated that compared to control group, erector spinae plane block reduced the accumulated opioid consumption during the first 24 hours after surgery. Besides, the erector spinae plane block could prolong the time to first rescue analgesia after surgery. It has less adverse events. This is a fresh article using pre-operative point of care to predict post-operative outcomes. By measuring the quadriceps and rectus muscles, one can examine the frailty and post-operative outcomes of the patient after surgery. What does the future hold for regional anesthesia? We need to increase our resiliency for what happens next. Systems and policies have shifted. The emergence of talent will be that If COVID becomes endemic, regional anesthesia will continue to progress because it has become an integral component of modern perioperative care. Lessons we learned from the COVID crisis will continue to bring further opportunities to demonstrate the outcome benefits of regional anesthesia, such as in times of war, because it is field friendly, patients in the critical care unit presenting special challenges to the regional anesthesiologists, and probably particular considerations in many medical emergencies encountered during prolonged space flight. The pandemic accelerated our need for a new kind of growth. Yes, we need further education. We have lots of learning left to do. We have to plan our efforts to improve quality and effectiveness of teaching. Commit our time to teach, as residency programs and workshops rarely teach blocks effectively. We need to formalize our teaching program. This is a chronology of how education in regional anesthesia evolved. It used to be see one, do one, teach one, wherein there were volunteers on phantom models, cadavers, live scanning, simulation-based training. Simulation is best in practicing technical skills in regional anesthesia procedures, as well as clinical simulated situations for crisis management scenarios. While there are several published recommendations and guidelines for trainees undertaking subspecialty fellowships in regional anesthesia, a similar document evolved describing a core regional anesthesia curriculum for non-fellowship trainees, released in July 2021, though less defined. The aim was to produce an international consensus for training and teaching regional anesthesia applicable to majority of anesthesiologists worldwide. Worldwide directors of regional anesthesia training gave strong consensus for a total of 25 items. A strong consensus was reached for 8 core peripheral and neuraxial blocks, and 17 items describing the objectives and skills assessment, and plus a high volume of practice, which is 16 to 20 blocks per anatomical region. Implementation of a standardized curriculum will improve quality of training and quality of nerve blocks performed by generalist anesthesiologists, though its application in each hospital may vary. Virtual education played an important role. Strategies such as watching didactic material and high-quality regional anesthesia videos prior to periodic teleconferences for questions and discussions are helpful. During the crisis, there was free and easy access to surgical video libraries, and encouraging regional anesthesia societies to share their resources with residency programs and anesthesiologists in order to maintain rigorous standards of education and training in regional anesthesia procedures. These are the key points of e-learning in regional anesthesia. E-learning has a profound impact on regional anesthesia training. E-learning modalities can facilitate understanding of basic theory and real-time block performance. But e-learning has to be integrated into traditional teaching methods, deliberately practiced with face-to-face training. This is critical for creating regional anesthesiologists who are both safe and resilient. But is new necessarily better? Technology can be an accelerator or its nemesis. E-learning make it easier to distribute learning content. This may not always make it easier for students to learn, more so acquire the skills. Trainees and consultants should keep in mind that over-reliance on e-learning resources may lead to unconstructive learning habits, while educators need to cultivate safe and resilient practitioners. I would like to go back to my first slide. Safety is incorporated in resilience. Resilience would be avoiding things going wrong and knowing how to get things right. Someone asked, what is the road to wisdom? And but less and less and less. This requires a conscious reflection and deliberate analysis of all one's performances over time and a large volume of practice. The global anesthesia drugs market is expected to chart a high growth trajectory in the forecast period of 2019 to 2029. The major driver is the rise in the older population suffering chronic diseases, growth in various types of surgeries, labor and delivery, and for post-operative pain. The pandemic has brought out the best in anesthesiologists because we have emerged stronger. Resilience will keep us strong in the next normal. For there will always be a frontier where there is an open mind and a willing hand. Thank you and have a good evening.
So thank you very much, Dr. Montemayor. Also, thank you, Aspen, for our snacks this afternoon. For people who have questions for Dr. Montemayor, please direct them to the Q&A box so that Dr. Montemayor will answer them there. With that, we end today's session. So the people and the delegates here in the ballroom, thank you very much for sticking around and joining us live. We can go take a break and see you again for the fellowship night at 7 p.m. right here at the Grand Ballroom of the Dusit Hotel. Thank you again, everybody. Have a good evening.